Good morning, everyone. Thank you, Dr. Rajendra, for that introduction. So we have only 45 minutes to discuss a case of complex Crohn's. I think that's anyways not possible to discuss such a complex disease in such a less time with such an esteemed panel here. So we are going to rush through many slides, and we are going to pause at some points wherein we find them, worthy of discussion. So I look forward for a very, very engaging discussion. So we start off with this case. So this is a case of a 34-year-old female. Onset of symptoms was at 19 years of her age. In 2009, she had a history of intestinal obstruction. A right hemicolectomy was done at her local place. She was diagnosed or told to have tuberculosis. We don't have any surgical details. We don't have the biopsy reports. And she did receive ATT for almost 12 months. Now, 2010 to 12, she had mild symptoms of abdominal discomfort and occasional loose stools. 2013 onwards, she started having chronic intermittent diarrhea and weight loss. And apparently a colonoscopy done again at an outside hospital suggested that there are descending colon ulcers. And it was suspected, as she was suspected to have IBD Crohn's. And initially she was given mesalamine and prednisolone. Now this is a very, very common scenario in what we see in our clinics day in, day out, that any obstruction, the first label is of tuberculosis, and then subsequently if the patient has symptoms, they are labeled as IBD and given mesalamine and prednisolone. So first I would like to bring in Dr. Mohan Reddy. Sir, what kind of investigative workup would you like to do if the patient comes to your clinic, and whether do you agree with, if it is Crohn's, assuming this is Crohn's, would you like to go ahead with mesalamine and prednisolone at this point? Sir, your mic.
I would like to recheck our diagnosis of Crohn's in view of previous history of tuberculosis. We don't know actually, we don't know the biopsy report available previously, but still, our colonoscopy done outside, it was suggestive of a Crohn's, but the records were not available. So that I prefer to go with again a colonoscopy to reconfirm whether it is a Crohn's or something.
So you would like to reconfirm by repeating a colonoscopy at your center, take repeat biopsies?
Repeat biopsies to confirm it's Crohn's or not. Then if at all the biopsy was negative, if the biopsy was positive and showing the entire Crohn's picture like having granulomas and other features of histology suggestive of Crohn's, then I would rethink as a Crohn's and I would start treatment with as a Crohn's. Otherwise, if not, biopsy was not so suggestive, then I'll depend on some other serological investigations or like that. I would prefer to consider the diagnosis of Crohn's. Once I confirm it's a Crohn's, but mesalamine, I am not so much interested in mesalamine because it's not a good drug to induce the remission. I'll go with steroids as a first preference rather than the mesalamine for the induction of this.
So the specific reason why I kept this question was this, please remember this was in 2010 to 12 era. So if I can hazard that guess, post-op prophylaxis of Crohn's was completely non-existent in our practices, even in most of our seniors' practices. That was a concept which most of us were alien to. So, a patient who has been labeled as tuberculosis, every stricture, every granulomatous disease was tuberculosis unless proven otherwise. So yes, a repeat follow-up scopy to check for healing is definitely necessary. And mesalamine, again, an important thing that any IBD is taken as IBD without the differentiation of ulcerative colitis and Crohn's, and mesalamine is very, very commonly used, even by some of us when we are not very, very sure of the diagnosis. So that's why that question was brought in. So when we are discussing today's case, so there have been very recent publication of ECHO guidelines on medical management of Crohn's and surgical management of Crohn's just 3 weeks ago. So I'll be taking out some statements from there and trying to discuss those. So the very first statement in the medical management, they make it clear that there is no role of use of mesalamine in treatment of Crohn's disease. Maybe in some situations of mild Crohn's, physicians still use it, but it has got no role in contemporary management. Again, we come to 2014-15, the patient continues to be symptomatic. She has persistent diarrhea, she has pain abdomen. Now she starts developing perianal fistulae with discharge and vaginal discharges. Again, she is treated with mesalamine, steroids, intermittent prednisolone. She is treated with budesonide for more than a year. And azathioprine is started by another physician. Again, not a very, very uncommon scenario considering the timeline. So Dr. Ganesh, I would like to have your opinion. What are the features which are considered high risk stigmata of aggressive? Do you think this is aggressive or not? Then second, then should we be still on the same therapies what this patient was on at this point of time?
Yeah. Anyhow, we know that Crohn's is a progressive disease and it's going to become aggressive in certain people. And some people, they are indolent and continuous activities there. As we know that mesalamine and steroids are not sufficient enough to suppress the immunological activity in Crohn's. We will be using more drugs which we'll be talking about, and the aggressive factors which we know that the patient factors when they are very young or young females, and also the parents of the kids having early onset of Crohn's disease or inflammatory bowel disease, the penetrance and the severity is very high in this group of people. And coming to their habits of smoking, persistent smokers, again have a worse outcome and complications. The other factors in the intestine as such, the extensive disease nature involving upper GI tract and extensive small intestinal disease, and colonic disease, even if it is colonic disease and if it's got deep ulcerations and entire colon being involved, is considered as one of the severity factor for aggressive therapy. And also the presence of fistulas, especially any fistula type, was being enterocutaneous or other fistulas apart from perianal fistulas, and multiple surgeries in the past, or if they have been using any other drugs for this with steroids non-responsive, or multiple flare-ups during the episodes in each year, and also the failures of use of biological agents in the past are definitely considered as worse factors in these group of people. So we should be very careful dealing with them rather than using milder variety of immunomodulators, as we know that the hitting hard from top-down approach from various trials, including the sonic trials. These sort of group of patients are definitely a group of patients with high severity. So they will be better off starting with biologicals at the earliest when we diagnose, and we discussed about this yesterday also.
Yes.
So
you're
a biological add-on would be the best option instead of mesalamine or steroids and tapering down and adding, continuing with the azathioprine with, if you are using TNF factors, anti-TNF antibodies, which is going to be the first thing which we're going to use.
So absolutely, I agree with whatever you have said. So the idea is to stratify patients immediately into a low risk and high risk, and by every stretch of imagination, our current patient qualifies as a high risk patient. And again, you know, azathioprine monotherapy, we have always been conventionally using azathioprine as a step-up approach in Crohn's. And now with the fabulous discussions we had all yesterday and with the kind of experience we have had with biologics, we know that, you know, upfront a top-down therapy has to be initiated. So again, I would like to emphasize here, you know, even the echo suggests that azathioprine as a monotherapy, especially in aggressive Crohn's, is not acceptable.
So in this case, we should start on infliximab, which is a well-tested drug.
So again, the timeline. This is 2014. So we had only 2 biologics available in this country. Most of the gastroenterologists did not have adequate experience at that point to start biologics. They were very, very expensive. There was a lot of fear factor in usage of those biologics. Accessibility, affordability, everything was a question. And this is not a justification, but this is the reality what was happening in it. So 14 to 19, she kept on having intermittent symptoms, and 19 continues to be symptomatic, had significant weight loss with diarrhea, with active perianal and rectovaginal fistulae. And 2019 was the time when she was first evaluated at an IBD center, and she was started for the first time on adalimumab and low dose azathioprine. She couldn't tolerate higher doses of aza. because she developed leukopenia, and she had a very good clinical response to combination therapy. The fistula discharge decreased, diarrhea improved, she was off steroids in 8 weeks' time. So, Dr. Shahji, do you agree with the therapy which has been chosen, or adalimumab? And do you want to, switch over to any other therapy at this point? You would have chosen differently?
Okay,
Again, I would like you to remember that, at that time in India, there was only infliximab and adalimumab biosimilars which were available. There was no other biologic which was yet available to us.
I think first of all, we should acknowledge this young patient who has, from age 19, has got a pretty terrible time. The best years of her life is being taken over by the disease. So whatever we are doing now needs to give her hope for going forward. So here we have somebody who has perianal fistula, and I agree with Ganesh that she has all features of high-risk disease. And my drug of choice here would be infliximab, but I actually would give infliximab along with at least 4 weeks of ciprofloxacin, because there is, you would be aware of this trial called the ADAFI trial, admittably that used adalimumab in that, combination with ciprofloxacin for 4 weeks, along with adequate drainage, along with high-dose infliximab, achieved better features. And now we know the mechanistic reason behind it, that fluoroquinolones improve the levels of infliximab as well. So that's our standard practice, almost give this thing. But we also give higher dose of infliximab upfront. So we tend to, for perianal fistula patients, we tend to give
infliximab as the first choice,
Yes.
high dose infliximab, combination,
along with ciprofloxacin, along with
antibiotics, ciprofloxacin preferably for,
and along with
what duration of
thiopurine.
ciprofloxacin, Dr. Shahji, if you can?
So usually it's 4 weeks. In a DAFI trial, it was 4 continuous weeks, and it is not for control of infection. It has got other mechanism in this setting. But I also will give azathioprine, and I use this terminology, I don't know whether you would agree with, it's called throwing the kitchen sink at. We have somebody who has got terrible disease, who had terrible time period for the last 5 years. We need to actually try and get on top of it quickly. So
that's top down, that you hit them hard with the best drugs which are possible, the best proven medicine which is possible, right?
I would always use thiopurines because of immunogenicity.
The combination of thiopurines, infliximab, high dose with antibiotics would be your first choice.
Yes.
What about adalimumab? So adalimumab right now also is the cheapest biologic which we have in here. In this particular scenario, are you okay to use that?
I am not against the use of it. My go-to will be infliximab, because that's what has got randomized controlled trial data. It is actually shame on our community that fistula, the only RCT data is actually, apart from post-hoc analysis, is from infliximab. Yes, the P19 antibody, the guselkumab is being trialed at the moment, but nobody wants to invest in that space.
No head-to-head, but your choice
no
will be
head-to-head.
still infliximab.
But adalimumab is perfectly reasonable by extrapolation, but go-to will be infliximab.
Yeah. So just to bring in some context, so this was the infliximab first trial published way back in 1999, which showed infliximab to be highly effective in patients with fistulizing Crohn's disease. If we come to echo statements, they recommend infliximab both for induction maintenance. They recommend it for perianal complex fistulae. They also recommend adalimumab can be used as an alternative to infliximab as an agent to induce induction and even in maintenance. Both for complex perianal fistulae, both the drugs are still recommended as per the recommendations, but infliximab, as Dr. Shahji pointed out, remains the first drug of choice. Dr. Rajendra Patel, any other therapy? So patients keep talking about diet. So is there a role, had this patient come to us at AIG IBD center, will you recommend use of exclusive enteral nutrition?
Yes, so diet is an important component in treatment of Crohn's disease. So we always include an expert IBD dietitian in our multidisciplinary management of Crohn's disease.
So Dr. Rajendra, this is a postgraduate session. So in one line or 2 sentences, can you explain also what is exclusive enteral nutrition, just like for a layman purpose?
Yes, so exclusive enteral nutrition is giving exclusive diet to the patients with liquid formulation, either polymeric or formula-based diet, and avoiding
So we're talking about commercial formulations to be used, liquid formulations, or you can have them self-prepared?
It can be self-prepared or liquid formulation which is available in the market, mainly prepared by dietitian based on the requirement of the patient's carbohydrate, fat, and proteins actually. So it can be either polymeric or elemental diet actually. It can be in the form of exclusive enteral nutrition, either given orally. If there is a tolerability issue, we can give via feeding tube. Also, sometimes we can combine with Crohn's disease exclusion diet. Like initially we start with exclusive enteral nutrition, subsequently we go with partial nutrition, subsequently we can go with CDD diet actually. So this is all the nutrition, and to avoid some amount of food which causes inflammation. So we are restricting some amount of food component, so to prevent healing and to prevent gut permeability and have anti-inflammatory action actually. So we have robust or RCT data in pediatric Crohn's where it has shown good clinical response and remission in mild to moderate luminal Crohn's, but there are case series or prospective and retrospective studies in adult Crohn's, including some cases in perianal Crohn's, where they have shown response and fistula healing at a tune of around 50% actually. Few studies from China and India actually.
Okay. So EEN, if patient agrees, very good data from pediatric age groups, adults, some data, sparse data, and you would like to put your patients on a Crohn's disease exclusion diet, followed by a partial enteral nutrition,
Yes.
along with the standard of care,
Yes.
continued infliximab, azathioprine, and ciprofloxacin, as Dr. Shaji pointed out.
Yes.
Not a question, just a comment. It may be for all the audiences here. When I manage people with active Crohn's disease or even general IBD patient, I diverge their attention from what you eat, but I say what you're absorbing is more important. Active Crohn's disease have problem absorbing the nutrition and re-emphasizing why we are recommending exclusive enteral nutrition, because it can better absorb rather than what you eat and you will just excrete.
Absolutely. So,
Can I just comment a little bit because you were talking of fistulas and I mean 2014, 2015, already the patient had vaginal discharge. And you're talking about the presence of rectal vaginal fistulas. Although a lot of your infliximab data is driven at perianal fistulas, our rectal vaginal fistulas a different ball game altogether.
different ball game, yes.
The surgeon should be called in 2014-15 because you're already encumbered by the fact they have lack of choices in 2014-15, as you clearly said. And you know that even the most persuasive data on infliximab on rectal vaginal fistula is at best 30 to 40%. So I think if the patient was already this, and the quality of life to a young lady, you know, vaginal discharge is extremely troublesome and disturbing to them psychologically as well. The surgeon should be called right at 214.
Absolutely. We absolutely agree, and surgeons will be coming in, but they'll be sent back by this patient. So just bear with us. We'll go. It gets murkier upfront. So yes, there is a suggestion for using of exclusive enteral nutrition in induction therapy for mild to moderate Crohn's disease who are motivated patients. Okay. Now, before starting of biologics at this center, she underwent a TB screening protocol, and she had a quantiferon TB Gold and MAN2 tests which were positive, and she did receive INH and rifampicin prophylaxis. She developed zoster twice during her therapy and treated with valganciclovir. Okay. Dr. Sukanya, just for the discussion, do you follow any pre-IBD therapy screening protocols, immunomodulators, biologics, or advanced therapy, or any specific vaccinations which you recommend for your patients before you put them on biologics, or you even consider them for on starting immunomodulators?
At our center for the screening before starting biologics or immunomodulators, of course, everybody I think in India does look for latent tuberculosis. So we do an IGRA and an HRCT, though chest X-ray would suffice as well as per the guidelines. And we look for anti-HBC total, apart from the routine viral markers, HBsAg, anti-HCV. Core total antibody is something we look for. We haven't, if we're giving tofacitinib, we are always looking for a herpes serology as well, the zoster serology. These are things which we routinely do as pre-screening protocol, and then TPMT levels, of course.
So you do TPMT levels or TPMT genotype?
Depending on the availability, yeah. So we are doing, most of the time we are doing the genotypes.
So
Yeah.
you said viral markers, hepatitis B, C, HIV, at times herpes serology.
Yes.
And what about the TB screening?
TB screening, I said the IGRA testing.
IGRA
IGRA
testing.
and HRCT test.
So I would just like to bring notice about this paper which was
Yeah.
published by Dr. Vineet's group. So there was a stringent screening strategy which they followed. They saw that initial years of practice they had an early cohort when they were not following a stringent strategy for TB screening. The rates of TB reactivation in their group of patients was as high as 26%. And then when they started in a late cohort following a set protocol of 6 parameters, and if any one parameter is positive, they used to treat their patients with chemoprophylaxis along with biological therapy, and the rates of reactivation fell in that cohort from 26 to 1.9. Again, significant improvement if the stringent screening protocols are followed. Yes, TPMT, NUDD15 whenever they are available. TPMT, some centers don't prefer saying that NUDD15 is the one common mutation which is there in Asians. If it is available, yes, we do it before that. Okay. Again, she had relapse of symptoms. To be fair to the center which was treating her, they did call in surgeons, but this patient was adamant on not getting any form of surgery done. So she had, again, relapse of her symptoms, increased abdominal discomfort, loose stools, fistula became active. Dr. Rubin, what could be the reasons for relapse and what are the treatment options at this stage?
So I think straight off, we've already agreed that this is a very difficult disease to start with. So it could be the disease itself. That's the
Absolutely.
reason why there's a flare. But everybody on biologics start off as affordable, but as time progresses, they find it a strain, and ADA is something that patients take by themselves at home. And if she's paying for it by herself, I think I'd have a chat to see about the compliance. Whether
Okay.
she's taking the drug, is there any difficulty she's encountering, and maybe then reinforce that if that's the case. No. MDT would be what we would do at our center. I would once again ask my colorectal colleagues. Obviously, there's a flare. The perianal and the fistula component would be separate now in terms of, is there an infection, is there an abscess, examine. If not, then do we need a ceton in place while this is going on? For the vaginal fistula, once again, surgeons, it's very drastic. Is there a need for diversion? I don't know. That's something that we'll have to discuss the surgeons and the patient. I know here, then obviously, if you want from the drug point of view, you want to know whether the levels are low and the antibodies are high, or the antibodies are non-existent and the levels are low and you can accelerate. I don't have access to that, so I would probably just accelerate and hope for the best.
Again, if I can summarize, you said compliance. Second thing, if you can do the levels, you will do, but ADALI levels are still not yet available in this country. We don't do that. Third is definitely, which should have been done, as Dr. Jin pointed out, in 2019, surgeons should have been called in, and a surgical placement of ceton, drainage of abscesses should have been done. But we still don't have any data with us whether there was any MRI and what were the findings and whether there were any abscesses or not. So these options were discussed with her. She refused surgery again. She was managed with antibiotics, and the dosage of adalimumab was increased in keeping with her choices. She had partial relief of symptoms. Then she did what some of the patients do at this point of time, get frustrated, stopped all treatment for a year and opted for alternative therapies and was lost to follow-up. Again, then and the next follow-up was in Jan 2022. She at this point had significant perianal pain, perianal and vaginal discharge, pain, abdomen, loose stools, significant weight loss from 50 kgs. She has dropped down to 37 kgs. Not surprising the way the treatment has been going on for more than 10 years now, and very poor general condition. The labs showed anemia, high count, a low albumin, a very high CRP, fecal calprotectin of 800, iron of 8% transferrin saturation, and a ferritin of 10. So poor general build, significantly nutritionally compromised, significant symptoms, perianal fistulas, rectovaginal fistulas which are discharging. So this is the time when we have her first colonoscopy images ever which have been taken. So there are large ulcers. Okay. There are large ulcers. There were ulcers at the anastomotic site. There were some ulcers in the neoterminal ileum, significant perianal disease. There were multiple fistulous openings which were visible in the rectum. The histopathology from the ulcers showed granulomatous colitis from colonic ulcers, which showed epithelioid cell granulomas, no necrosis, acute on chronic ileitis. Colonic ulcer biopsy was negative for MTB gene expert PCR. The fistulogram showed bad disease, multiple fistulae, significant rectal inflammation, small collections in the perianal area. The MR enterography, in addition, done showed long segment colonic thickenings, significant pericolonic fat stranding, significant inflammation around the colon. Okay. So what we have is a perianal fistulizing disease A1, B2, L2, P as per the Montreal. Status post 1, major surgery, right hemicolectomy for intestinal obstruction way back in 2009. Failed adalimumab, maybe possibly a secondary loss of response. Azathioprine intolerant. She has active disease with deep colonic ulcers and active perianal fistulae and rectovaginal fistula with a small perianal collection. Yes, a very, very dismal situation. And Dr. Shaji, again, how would you like to proceed now? The ideal. Now the patient is with us, and ideal circumstances, what all should be done for her?
So, first of all, this patient needs a multidisciplinary care, and ideally I would see this patient in a joint clinic environment, having a nurse for providing support, because this would have taken a toll on her over the years, but now is in a pretty poor clinical state as well. In a multidisciplinary clinic with the presence of a surgeon, a nurse, and maybe even a stoma therapist, because that is something which may be discussed, along with involvement of the caregivers, because it's important. This young girl started at age 19, so caregivers needs to be brought into the equation as well. So a proper, well-structured clinical environment, if that is possible. Then there are the medical aspects. She clearly has got perianal sepsis now. Her inflammatory markers are elevated. She's got clear evidence of abscess on the MRI. So first and foremost, before intervening with any additional medical therapy, we need to clear the sepsis. Now that's a discussion which needs to ideally happen in a joint clinic setting. But I also think that we need to be upfront and honest with this patient, because what you're seeing there is large openings in the low rectum adjacent to. There is already fibrotic disease there around. This fistula is never going to complete healing. You have to be honest upfront. You need to set realistic expectations from the patient as well as you. So drain the sepsis. Nutrition is critical. And I heard the earlier and completely agree with nutritional interventions. But to me, any nutrition is important for this patient, because she's nutritionally compromised, which is clearly going to have impact on her healing. So if we have cleared the sepsis, have put in measures to improve her nutrition, have had a realistic discussion with patient and care family, I would still start this patient on high dose infliximab, because I think this is still maybe secondary loss of response. I'm not sure, because we don't have levels, etc. So I still will go to infliximab along with antibiotics, along with the thiopurine, or she's a childbearing age, probably not methotrexate, but one of all three together once the sepsis is drained, and preferably a loose ceton placed. I think ceton, you mentioned that this patient is not very keen for surgery. I think this patient does need a ceton.
So she needs a surgery. There is absolutely no debate or doubt in our heads. She needs a multidisciplinary team discussion with this colorectal surgeon, with the gastroenterologist, with the dietitian, with the possible stoma nurse, maybe a psychiatric opinion upfront. Those are the ideal things which should be done for these patients. So just for the management side, we can classify the fistulas as simple and complex, and by every terminology which is mentioned by AGA classification, this classifies into complex fistula. In the newer terminology, a new expert consensus classification which has come in 2022, which gives a more functional classification for perianal fistulas. And on all parameters, this patient which we are discussing, one particular patient, classifies into a very, very complex perianal disease. So this is the general management guideline which has been taken from Dr. Deepak's review in Indian Journal of Gastroenterology for complex perianal disease. And as Dr. Shahji pointed out, that we start off by treating, taking a good history, doing a perianal exam, examination under anesthesia, doing a good MRI, classify them as simple or complex. We are dealing with a complex. It's a combined medical and surgical treatment. Antibiotics, anti-TNFs, thiopurines, access the fistula activity, mucosal disease. We see that this is quite active in our patients, and we need to drain those abscesses. We need to put in the cetons. We need to do a diversion or a proctectomy if the patient deserves it, and then continue further medical therapy. So when we are dealing with cetons, when we are dealing with surgery, there are these two trials which needs to be mentioned in today's world, which are the PISA trials. Dr. Shahji, do you want to quickly tell us about PISA 1 and PISA 2?
So, PISA trials were originated in Amsterdam, and there are quite a lot of caveats about this study, which I was closely involved in steering group. It took 7 years to recruit, it under-recruited, had to change some primary endpoints, etc. But what it has given is reinforced what we talked about earlier, that you need multimodal treatment to have any realistic hope of control, or if it was treated earlier, maybe closure of the fistula. What we tend to do in practice in new patients is that we give anti-TNFs, and after 3 or 4 doses, the cetones are taken out with a backup plan, which is important, that they have direct access to come back for an EUA and reinsertion of
If I can just put it this way, that there is a perianal abscess and an actively discharging fistula, you drain the abscess, you put the cetons, you give the induction therapy, and maybe at the end of the induction therapy, you would like to consider taking out the cetons.
Yes.
So those cetons are important. They are not, they should not be the sole treatment which is being offered to the patient. It has to be always a multidisciplinary team which has to take care of the patients, in medical therapy. In addition, has to continue, and that's what I think the ECO also emphasize. So this was the PISA 2 trial which said that anti-TNF therapy, cetons, followed by a surgical closure in patients whom surgical closure can be offered, and most often these patients are the ones which do not have significant rectal inflammation, should be the treatment of choice for complex perianal fistulas. Again, chronic ceton therapy as per ECHO should not be the sole treatment which we are offering the patients, and a drainage by ceton preceding the medical therapy is the norm, and combination of medical therapy with surgical fistula closure, amenable patients with complex perianal fistula should be the treatment of choice. So all 3 statements have to be kept in mind before we are offering any treatment options to any patient. Again, we discussed all the options: surgery, examination under anesthesia, cetons, diversion if required. Vehemently opposed by the patient and her family that they don't want a surgery, and that's not, again, very uncommon in our practice. She did agree for a drainage of a small perianal abscess, and that's what we did. We gave her IV antibiotics. We started on infliximab, 5 milligram per kg induction as a low dose because she was not tolerating high doses, and antibiotics. Perianal abscess was drained. Counseled for EEN, refused. We put her on partial enteral nutrition, advised a high protein diet, parenteral iron and vitamin D supplementation. 6 months post-treatment, she did have a significant good clinical response. Stools became well formed, 1 to 2 per day, no abdominal or perianal pain. Fistula discharge significantly decreased. Weight gain from 37, she gained some weight back, came back to 45. Hemoglobin improved, CRP decreased, albumin improved, fecal calprotectin improved. 8 months post-treatment, she did have perianal pain. There was again a recurrence of a small abscess. Examination under anesthesia and a perianal drainage of the pus was done. Clinically, she is doing well for 2 years, no new symptoms, perianal fistula, no active discharge. In September 2023, on infliximab 5 mg per kg, she presented with increased stool frequency again, mild discomfort, CRP has again started going up, fecal calprotectin is 150, refused a colonoscopy, but you forget what this patient did. Dr. Rajendra, how would you like to proceed now?
So
She's
this-
on infliximab, she has failed a DALI,
She can be
bad disease, refusing surgery.
Yeah, there can be again relapse actually, new development of abscess actually. So local examination is important. We have to do colonoscopy to look for active.
You want a
proctitis.
colonoscopy?
Yeah, to look for active colonic disease actually.
Yes, ideally,
Sometimes
yes.
there can be stenosis at the anal canal which prevents fistula healing and development of new fistula and new abscess and also that is also important. To look for MRI actually, long-standing disease sometimes rarely can have fistula malignancies actually, so that also we have to look into. Also we want to look for drug levels actually and to look for any anti-drug antibodies.
So very quickly, we are short on time now. So you
Local
want
examination,
you want a
colonoscopy.
colonoscopy, repeat MRI. You want the drug levels,
Yes.
and again you want to call in the surgeons. You want to look at
Yes,
for renal
surgeon
structure.
always should be there.
Okay. So I'll skip this flow chart for the time being, which tells us that how do we do. So what we did was, because there were significant financial constraints, we did pester her to increase the frequency of dosing. Node levels were done at this point of time, and the CRP marginally improved. The symptomatically patient became a little better. January she had a full-blown flare again, symptomatically. Again, the increased stool frequency came back. Fecal calprotectin has risen up to 300 now, and CDAI was 247. Now, this was the second colonoscopy after 2022, and we see that there is significant fibrosis in the anal canal. There are these ulcers in the distalmost rectum, but surprisingly, the anastomotic site, the rest of the colon, has shown good amount of mucosal healing. The anastomotic site now only shows some nodularity there, but there are no active ulcerations. The ileum became absolutely normal. But these rectal ulcers are persisting, and there is an anal stricture which is developing there. So these were the repeat MRs. They still show a long persistent thickening of the colon. The inflammation has significantly come down as compared to before. It has not improved. The inflammation still persists. We can clearly see in these T2 images that there is inflammation better than what it was 2 years back, but not completely better. Similar story with the MR fistulogram. There is persistent fistula. Some of them have healed. There were at least 4 of them. Now there are only 2 active. But externally fistulas have healed. So this time we got a drug level, and the drug level was 4.7. The normal range is 3 to 7, and no anti-infliximab antibodies. Now I'll come back to all panelists. What are the further options? We can, yeah, Shaji, you can start.
I think for fistula, the level of 3.7
It's terribly low.
It is terribly low. You would want, upwards of 12. This thing. So I would still increase the
So
dose.
no antibodies. You would like to
I
hike
would
up the dose.
increase the dose and perhaps also frequency. And as I said here perfection will be the enemy of good. You're never going to be perfect here, but there is scope for improvement with what you have, what's in your pocket. You don't want to exhaust that too early by switching out of class. I think still infliximab is doing something, but we have opportunity to optimize. But then you could consider other classes.
So you want an increased dosage to maybe a 10 mg per kg and increased frequency as well?
I would go 10. I mean, I don't have any experience on 20 milligram per kilogram, but we have gone up to 10 milligram Q4H per kg. And as long as you have levels, closer to about 15, that is maintenance level I'm talking about, is when we can make a decision. At the moment, I won't switch based on that levels.
So ideally, increased dose, increased frequency of dosage. Yes, if money is not a problem and if the patient agrees. But again, most of these patients are paying out of their own pocket. No insurance company will take them up, even with higher premium rates. So that's a possibility which we have to consider. Rajendra, very quickly.
Adding surgery is an important, diversion is an important option here actually, and stoma actually.
So every visit keep talking about surgery. That's what we have been doing, but so far we have not been successful. So Surgery at every visit has to be discussed. There is an anal stricture which is clearly developing. Though the external fistulas, there are external discharge has come down, but we can clearly see that the perianal disease is still active. It has not completely disappeared. And Dr. Ganesh.
Yeah, I think cost is not a factor, and if they're not accepting for surgery and infliximab is not working with increasing the doses also and reducing the frequency, we'll be going for ustekinumab. In my experience, we had 4 patients with similar ectovaginal
Much more
fistula.
expensive, sir.
Very expensive. If, as I said, if you're not talking about the cost.
So I would not say infliximab is not working so far in this patient. It has actually worked. The only thing is, as Dr. Shaji pointed out, that levels are terribly low. We would like anything upwards of 10, 12, maybe 15 also in this patient, but not this.
We have used up to 10, not beyond 10.
Okay.
I think we don't have experience. But as I said, we switched over to ustekinumab, and it showed within 6 months after the 3 doses had shown better response. If that's another option. But even though the healing rates are more or less comparable to infliximab in fistulas, especially rectovaginal fistulas are the most difficult ones to treat with these sort of drugs. And one more option is about using cyclophosphamide and mycophenolate, which is not out of the box and still been in a trial. It's shown some good response in fistulas if they don't have any infection as a component added to it, cleared by cetans and stuff. So option is, as I said, one is infliximab higher dose, increasing the frequency, and number 2, change to ustekinumab or try with mycophenolate and cyclophosphamide.
So if you have to choose one, you want to increase the dose or you want to
Plus
switch?
increasing the dose of infliximab.
You will
And
increase
then
the dose.
Increasing the frequency.
Dr.
as well.
Rubin, I would like to ask your opinion. Do you think this patient is going to respond in absence of surgery? I think surgery should have, as Dr. Jin pointed out, 2019 she would have done.
I work in resource-restricted settings, so my
Welcome to the
patients are
club.
poor.
Yeah.
And I think you did mention, I caught on to that money was a problem.
Money is a problem.
I think
The young
then
working
we are
professional.
stuck
There is a lot of
accelerating.
social background, and Dr. Jin actually latched on to that there will be a social and a mental trauma which would have happened with the disease going on for so long.
I think this
Affordability is a major issue.
if that's the case, I think once again, we really need to spend time and talk to the patient and say that diversion will be the best option for her.
Agreed.
And then we need to take her to patients who have diversion done and talk to them and let them see what it's like. Otherwise, she's going to go bankrupt and have a terrible situation.
So surgery. Your option will be surgery. Okay.
One thing
Dr.
is with these patients, very young patients, unmarried, they have very big social stigma. When I try to convince them, they never get convinced, and if we can go against their will, it's going to be a big problem. So only these biologicals and whatever discount are things which we can are the best options.
So very quickly, Dr. Sukanya.
I think I would agree with the diversion surgery. If
So
she does-
diversion one.
That's one. And if she is vehement about not having it, maybe explore the possibility of a long-term ceton placement. We've had patients with complex fistulas where cetons have been there for a year. They have a good quality of life. They have that thread there, but then they have a...
But
they're fine.
will we agree to that, Dr. Shaji? Because now the current evidence which is coming in is that long-term statons may not be the right. We were doing it.
No. No, absolutely. I mean, in this patient, I completely agree. A long-term ceton drainage is an option for this patient. Here, you are not going to be perfect.
So surgery, again, all of you agree that surgery is the
Yes,
is
but
the way
there is
to
a
go forward.
caveat. There is a caveat. This patient has got already colonic disease. Whenever
Yes.
we do any intervention, we have to think about what is our exit strategy 3 years or 5 years down the line. This patient previously had small bowel disease. She's almost likely, surgery will definitely improve her quality of life. Okay, maybe both long and short term, but we also need to think about what you are then going to do with the disease as well. So perhaps combination of chronic ceton drainage and optimizing, if resource is not an issue, optimizing infliximab will be my first, and then otherwise is stoma. I do have some concerns about stoma on this patient for the reasons I mentioned, because she's young. We don't have an exit strategy unless we think that the new.
So in
drugs will
yesterday your talk, you did mention that most of the patients in this particular scenario, when they're going in for a stoma, it has to be an kind of an end stoma, and only 10 to 15%, if I remember the figure correctly, will land up with a reversal. Is that the reason you're?
None. In her case, probably.
Probably never. So if I have to summarize that, yes, a surgery, maybe a diversion, maybe an end stoma, along with continuation of at a high dose infliximab, along with the low dose thiopurine, whatever she is tolerating, will be the way to go forward. Is that what all the panelists agree upon? There's a lot to be left desired in this patient. There's no doubt about that. And the idea was not to point out the mistakes of the previous centers or our center. The idea is to discuss, because we do land up with situations very commonly. What do you want to do?
And
Dr. Charlie, you want to say?
I think
that will
more
be the-
on parenteral nutrition with taking off the injury due to the nutrition, and also give peptone diet for a long period of time. It's difficult to tolerate, but they do sometimes very well with intracutaneous fistulas. We have found that keeping them on 3 to 4 months with peptide-based diet has shown a good response along with biological agents.
Yes. So I think I'm getting my cues from the organizers, Dr. Charlie. Kiran, we can take one comment
Thank you.
last.
Just a quick point. Thank you for sharing this very illustrative case. I think what this really illustrates is the natural history of aggressive Crohn's disease, and what the real learning here is, for this kind of patient, you need to get on top of it right away at the start.
Absolutely.
Multidisciplinary care at the start, then you get in with drainage of the sepsis, you treat with high-dose infliximab, full-dose azathioprine at the start. You watch these patients closely, you monitor, you optimize. This is not everyday Crohn's patient. These are the patients where you throw everything at them, you get the money, and you get it sorted. So I think this really illustrates that nicely, because now in 2024, we know what to do with these patients.
Absolutely.
So don't give them steroids and mesalazine and wait and see. That will not work.
So don't give them mesalamine, don't go on treating with steroids.
Or therapy
Don't
monotherapy, or standard dose infliximab, or not following up aggressively, all of it.
Sure. Thank you. I think that should be the learning point for our discussion. And thank you to all the panelists for being patient. Thank you.
Thank you, Sumit, and all the panelists. That was a fantastic discussion which happened. I invite Dr. Ravishankar Reddy as the next team director to take over further proceedings. Good morning, all. A good topic for the today's discussion, new fund trends in IBD. I'll invite chairpersons for this topic, Dr. Pratibha Shetty, Dr. Uma Maheshwar Reddy, Dr. Sai Krishna, Dr. Akash Chaudhary, Dr. PBSS Raju, and Dr. Satish Kumar. I request Dr. Raju to invite the speakers.
Good morning, everyone. The current topic is new frontiers in management of IBD. There are 3 topics in this. I invite the first speaker, Dr. Jacob Began. He'll be dealing with new drugs and combination therapies ready for prime time.
Okay, thank you very much. Hello, everyone. It's great to be back for day 2 this conclave. And again, thanks to the organizers for inviting me to present today to this wonderful conference. It's been fantastic and was very nice to get to know some people yesterday. Today I've been given the topic of newer drugs and combination therapies ready for prime time. It's an extremely large topic, so I have been selective about what I'm going to present, but hopefully there'll be some themes, and maybe I'll talk about a couple of molecules that haven't been discussed yet. So when we talk about new and emerging therapies, it's a time to throw out the old and go in with the new. And we've seen a dramatic increase in the number of agents, mechanisms of action, modes of delivery that are available in inflammatory bowel disease. And since the 2020s, so in the last 5 years, we've seen a number of agents that have now passed through the clinical trial phase and are coming to markets around you, although I realize not in all parts of the world. I thought that I would present just on two mechanisms of action in the limited time that I have available, and one would be the new agents that we've had targeting IL-23, since we've seen 3 of these agents now be approved in the last couple of years. So IL-23 is a molecule that signals through its cognate receptor, and it's a heterodimer made up of the P19 and P40 subunits. The existing drug on the market, ustekinumab, targets the P40 subunit, which means that it targets both IL-12 and IL-23, and the newer agents are anti-P19s. They target IL-23 specifically, but they're not all the same. There are slight differences between the monoclonal antibodies available on the market, and that may have implications in disease, although that remains to be seen in many cases. And IL-23s have been used in psoriasis treatment, where they've really shown quantum leaps in the effectiveness over other agents, but not so much in rheumatology. The joint space doesn't seem to be as well targeted by IL-23s. I thought I would present a little bit of recent data with these molecules, particularly with respect to how they perform against what we have on the market, ustekinumab. So the first study I'll present is the VIVID study, which was a study, the registration study actually, for mirikizumab in Crohn's disease that included an ustekinumab reference arm in the clinical design. And what I'm showing here are the major endpoints after 1 year of therapy. It was a treat-through design. And in orange is mirikizumab, in beige, I guess, is ustekinumab. And when we look at clinical remission, maybe not with this one. Here we go. We can see that there's really no difference with respect to clinical remission between ustekinumab and mirikizumab. And if you break it down by patients who would have a prior biologic failure versus those without a prior biologic failure, we see that those who previously failed bios, maybe there was a numerical advantage, although it did not reach statistical significance. And the same was true for endoscopic endpoints. No difference between the two all-comers. When you look at just the previous bio failures, maybe a numerical difference, but not significant. The other trial that was recently presented, this was at ECHO earlier this year, and last year too, was risankizumab versus ustekinumab, the sequence trial. This was a phase 3B open label study. So investigators and patients knew what they were getting, although endoscopy was blinded for central reading. But in this study, which had also a treat-through design comparing risankizumab to ustekinumab, there was superiority seen with risankizumab, both in terms of endoscopic remission, mucosal healing endpoints, and deep remission at both week 24 and week 48. One thing that's been mentioned about this study is that there was a high dropout rate in the ustekinumab arm, a higher dropout rate, and because it was not blinded, this may have biased results. Why this study that was just presented at DDW this year, which is the Galaxy 2 and 3 trial, a trial of gazelkumab in Crohn's disease, which also included an ustekinumab reference arm and was powered for superiority, was quite anticipated. And in this study, we saw that gazelkumab was superior to ustekinumab in Crohn's disease, both in terms of the endoscopic response, which was their primary endpoint for this analysis, endoscopic remission, and also when you combine with clinical remission. But interestingly, when you just look at clinical remission alone, there was no difference, and that probably points out the fact that clinical endpoints in Crohn's disease trials are challenging because of high placebo rates, et cetera. And the other thing that's interesting about gazelkumab is you get away with a much lower dose. 100 milligrams Q8 seems to be equally effective as 200 milligrams every 4 weeks, and when you look at the comparable doses used with the other agents, they are maybe 5 times as high the dose. And perhaps this has to do with this CD64 binding story, or perhaps it's something else. So just to summarize the P19s then, they appear effective and safe in clinical trials that have been done both in Crohn's disease and UC. There may be an advantage over ustekinumab in Crohn's disease, although this is probably a small improvement. Not all P19 antibodies are the same. We shouldn't lump them all together. There's going to be differences with each agent. And it's really not a transformative increase in efficacy. It's incremental. And with biosimilar ustekinumab available in some parts of the world already and coming to other parts, the incremental benefits that you see with P19s may not be cost effective in the long term. The other agent that's emerging that I wanted to touch on was TL1A, which I think is actually a very interesting mechanism of action, particularly for Asia. So TL1A is a cytokine that targets a variety of cells through the DR3 receptor, and it also targets fibroblasts, which means that there might be some anti-inflammatory potential with this pathway as well. And so targeting this pathway is quite attractive. It might have, this pathway emerged, the hints of it, through genetic studies showing that the TNFS15, which is encoding TL1A, is implicated in inflammatory bowel disease, both UC and Crohn's disease. And this was one of the first cabs off the rank, although there are multiple TL1A programs in development in parallel by many companies. This was the Artemis UC trial that was presented at ECHO last year, which showed that it hit its key primary and secondary endpoints in terms of clinical remission, endoscopic improvement, and clinical response. And what was interesting and enticing about this trial is it included an arm that had a diagnostic performed on it, the CDX test, which basically tests for activity of this pathway. And the hypothesis was that if you had a increase in this biomarker, you had high TNFS15 signaling, that you might respond better. And although it's large error bars, then there was a hint perhaps that the CDX performed better, although I think we need much larger numbers to say that, but it would be very appealing to say, oh, here's this biomarker that indicates that perhaps this agent might be best of you. It's that marker we are still looking for from Charlie's presentation yesterday. And as I mentioned before, TNSF15 seems to play a large role, genetically at least, in IBD seen in Asia, and perhaps this would be an appealing agent because of that. So stay tuned for phase 3 trials. I think the earliest one will probably have its readout or registration in 2030. All right, so 7 minutes left, huh? Okay. So the second part of my talk was going to be combination therapies in IBD. So I will try to get through this before I run out of time. But what's the rationale for combining therapies? Well, we have limited remission rates with advanced therapies when used as single agents, as we've seen so far in this conference. Mechanistic failure can develop over time with single agents. We see high loss of response rates with our anti-TNFs, for example. When you use advanced therapies in succession, they tend to be less effective. You always see that biofailure effect. And agents effective for luminal disease, such as vedolizumab, might not attack EIMs so well. And multiple pathways drive these diseases, so maybe we should be targeting multiple pathways to start. And these are the principles of combination therapy. If you have two drugs, A and B, say, and if you put them together and you get something that's the combination of A and B together, that's additive. If you put them together and you get better than either one adding together, that's synergy. And then you have other things, subadditive and interference, for example. And what we'd really love to get, the name of the game is synergy. And how do we achieve synergy? Well, perhaps through pharmacokinetic synergy, when you have two different routes of delivery, or you can ameliorate immune effects, for example, azathioprine plus infliximab, or pharmacodynamic synergy, when you're targeting two different MOIs that may be complementary. And when you're putting combination therapy together, I feel like there's two sort of broad principles. One is sort of a step-up combination approach. Start on agent A, add agent B, and maybe continue both, or perhaps stop agent A over time, or a top-down combination therapy to steal from the parlance of the day. And I think it's really important, if we want to maximize combination therapy, to select our patients carefully, identify and exclude patients at increased safety risk. We have to make sure what we're doing is safe, and identify patients who have the most to gain from ACT, either through clinical profile or some precision medicine approach. And then for the treatment strategy, pick agents where we can identify the lowest dose needed in order to achieve effective combination. And if it's safety that's a concern, use strategies that minimize those safety risks. So for example, if we're thinking about a JAK inhibitor that might have a higher safety risk, that we use it at a low dose and as short a period of time as we can get away with. Low-hanging fruit might be combining therapies for co-immunomediated diseases. So if you have another disease at play, as we often do in our patients with inflammatory bowel disease, be it skin disease, joint disease, or neurological disease, pick agents from one class that will treat each disease if you can. And I'll present a couple of examples. So in terms of picking your agents, we know that there are a lot of immune pathways at play in inflammatory bowel disease. It's a complex disease. And if we're going to pick agents, why don't we try to pick them somewhat rationally? So if we think about JAK inhibitors and IL-23, for example, those have quite an overlapping effect, and targeting both pathways might not give us that synergy that we're looking for. However, if we target, for example, IL-23 and anti-TNF, then we might get synergistic effects, or if we target leukocyte trafficking either through an anti-integrin or S1Ps, and perhaps that would have a complementary effect with other classes of agents. I'll point out this paper, which was published a couple of years ago, looking at a meta-analysis of cohort studies that looked at combination therapy. We don't have a lot of trial data. I will show what we do have. But in this study that included 30 studies on 288 patients, we can see sort of what the disease distribution looked like for all of these. A lot of patients were on corticosteroids and immunomodulators at baseline, and these are the dual therapies that were trialed. Anti-TNFs with a variety of agents, vedolizumab with a variety of agents, and IL-23s in the mix as well. And when you look at the outcomes, clinical remission was seen overall in these studies about 60% of the time, but it's really important to pay attention to the safety. So serious adverse events and adverse events, 30% adverse events and 7% serious adverse events, which is somewhat reassuring, although I will note that the infections here were about 20%. One of the earliest combination trials was this trial by Bruce Sands and colleagues, which was published over 15 years ago now, looking at combination therapy with natalizumab and infliximab. And you can see over here, when we just look at clinical remission, as I said, it was a bad endpoint. There's not much difference between the addition of the two, although if you get rid of the patients who had a normal CRP and just look at those at elevated CRP, maybe there is a little bit of synergy, although the numbers were low. So overall, non-significant efficacy trends in favor of combination therapy, but it was well tolerated with no new safety concerns. Of course, we don't use a lot of natalizumab in practice because of the risk of PML. The Explorer trial is a more recent attempt at this, so this was presented a couple of years ago. This was biologically naive patients with newly diagnosed moderate to severe Crohn's disease. It was an open-label trial which used this interesting combination, I think, of vedolizumab, adalimumab, and methotrexate. You can see here the regimens and durations. They were pretty much maintained on vedolizumab. Adalimumab and methotrexate were used early on in the piece. And these were the efficacy here, 60% endoscopic remission at week 26, which was interestingly higher than the clinical remission at the same time. And here are the adverse events from these 55 patients who participated in this trial, which overall infection rate, again, about 35% in this trial, but treatment emergent adverse serious events were low. The Vega study, I think, is an interesting proof of principle of how these studies perhaps will be run in the future. And this was a combination therapy between gazelkumab and golimumab, anti-IL-23 and anti-TNF. And they had 3 arms, monotherapy with both or a combo therapy for the first 12 weeks, and then monotherapy and induction. So the combo therapy went to gazelkumab monotherapy for the maintenance period. And these were their endpoints in this combo trial. Combination is in blue, and we can see that it was superior to either monotherapy alone when you look at the secondary endpoints. And the primary endpoint, it's certainly superior to golimumab, but not quite statistically superior to gazelkumab monotherapy, either at induction or maintenance. But when you look at some of the important secondary endpoints, including clinical remission, where it has clear superiority both in the end of induction and maintenance, but also in terms of endoscopic improvement and endoscopic normalization, which we know will give us the best long-term outcomes in these diseases, we see that combination therapy was superior to either monotherapy, even after you switch to monotherapy after 12 weeks. And this is an area of active investigation. Watch this space. There are 2 large trials underway that are expanding on Vega, looking at gazelkumab and golimumab in Crohn's disease, and in ulcerative colitis, that should say. Victriva is a trial of upadacitinib and vedolizumab in Crohn's disease, and in the pre-IND stage, there's several combinations that are getting ready for launch, which is TL1A plus anti-integrins, IL-23s and anti-integrins, and IL-23s and TL1As. So it'll be an exciting space to watch moving forward. So how do I look at combination therapy? And we do use quite a bit at our center because we have quite a refractory referral base. So who? Look for patients who are refractory to multiple medical therapies, where surgery might not be a good option, who have high-risk phenotypes, as we've discussed before during the case, and might have concomitant EIMs that would benefit from multiple lines of therapy. How to do it? Often recycling, using at least one agent that's already administered. Often we'll have patients who are on dose-escalated something or other. We will then add a second agent and then keep that first agent on as we add the second agent in our combination regimen. You could also think about simultaneous induction for very aggressive, one more slide, starting with 2 agents up front versus adding on. Which agents? TNFs in CD, as we've already heard, are especially good, especially in ileal Crohn's disease or in fistulizing disease. Preference for Veto in UC, and a preference for anti-TNF agents or ustekinumab or JAK inhibitors in patients with concomitant EIMs. And finally, there's a lot of unknowns. So, to conclude, combination of conventional therapies have a long history in inflammatory bowel disease. Sonic, in fact, which I didn't show, but it was one of the main first combo therapies that really changed the way that we practice medicine with anti-TNFs. Combining agents with different mechanisms of action may help to improve efficacy, but need to consider safety and cost. And agents with novel MOIs or gut restriction may enhance safety and efficacy. And with the growing number of MOAs, we need better ways to identify rational combinations. So top-down therapy may evolve to the upfront combination therapy. That might be what we're talking about in time to come. So thank you very much. Sorry for going over.
Thank you, Dr. Jacob. You've given such a lot of information in such a short period of time. So it was a very elusive presentation. I would like to invite Dr. Charlie Lees to present the next topic, Evolving IBD Management, the Convergence of Digital Telemonitoring, AI and Smart Technology.
Great. Thank you, Jake. That was a wonderful talk. So I'm going to go a bit future-gazing now to talk about emerging IBD management. Here are my disclosures. So I'm going to just set the scene to recap about the burden of IBD globally, emphasize some key challenges we have with IBD being highly heterogeneous, dynamic, and unpredictable, and set the scene for the innovative solutions that we can now really think about as we enter this technological revolution, which is probably akin to the Industrial Revolution today and the impact it will have. This is the current scene with IBD across the world. This is the future that we seem to be moving towards, not just now in the West, but here in India and across China. Two huge nations with huge technological prowess and abilities perhaps to take to this problem. And as we look towards the increasing emergence across the African continent, we realize we have a real pressing duty, not just to do better with what we've got, but to really think to truly innovative solutions. Our environment has shifted enormously. The key epidemiological signal is urbanization. And 2007 is the point where the WHO said that more of the world's population was living in urban rather than rural settings. Although India is tracking a little bit behind this, the inevitability is there. With urbanization in the West, over the last 50 to 100 years, if you look at 1920, you start to see the emergence of flushing toilets and running water. More recently, you saw refrigeration, household, microwaves, air conditioning, electric power. And if we look at compute, well, Moore's law has shown the number of transistors you can fit on a chip. This is looking at price performance of computation from 1939 to 2023, still tracking up at an exponential rate. This is driving forwards the AI revolution, and we're able to communicate rapidly anywhere in the world now. This is a current map that I took from the internet last night of the Starlink coverage across the globe. Every single one of these dots is a Starlink satellite providing low latency, high frequency telecommunications wherever you are on the planet. That includes, of course, the whole of India, the whole of Latin America, the whole of sub-Saharan Africa, and it means we can think to innovative solutions. We talked a bit about this yesterday, But infectious diseases in the last century in the West have plummeted, and more recently in the developing world. On the other hand, immune-mediated illnesses are going up. But let's stick with the good news story. When we really put our mind to it, we can affect good change. These are deaths by diarrheal causes across the world from 1990 to 2019. Recent timeline, you can see a very big reduction. But look where the reduction comes. It comes in the under fives. This is a fantastic achievement for humanity. And how do we get there? Why have diarrheal deaths reduced in kids under 5? You can see the big things that are trending down here. The top 2 lines here are unsafe water source, child growth failure, and unsafe sanitation. Poverty also declining across the world, from 1820 on the left to 2020 on the right. And you can see it is shifting again in the more recent time frame, and education is increasing, including, you will see here, trending up on the bottom, but rapidly catching up is India too. So that's really important optimistic context to set the question, how do we care for all of the patients living with IBD? This is in Edinburgh. This is at 2018 in the middle. You can see where we are, or where we were when we did our calculations, with 0.78% prevalence going up to 1%. We will be going up to 1.5%. My clinics are getting really, really busy. We diagnose IBD in young people. It's a lifelong illness with no known cure, and we never undiagnose IBD. Isn't that a curious thing? The one-size-fits-all approach to follow-up is broken. We have more ambitious treatment targets, and now we're not just looking after the gut, we're looking after the whole patient. IBD is not just in the gut, it's outside the gut. We have the complications of the drugs and the disease to contend with. We have the sequelae of inflammation and comorbidities. We're going to hear from Deepak about one aspect of this later. Older patients, multimorbidity, polypharmacy, and frailty are all real issues. But at its core, we have 3 big principles. IBD is heterogeneous, IBD is dynamic, and IBD is unpredictable. This is a challenge. No 2 patients are the same. IBD does not respect age, gender, geography, social status. IBD is highly dynamic. So whilst over time an individual might have periods of flare and remission, in the background, the inflammation is driving irreversible bowel damage changes, as we heard illustrated in that case earlier today. And underlying all of this, if we look with our magnifying glass, we can see the inflammation that is driving these changes, and it gives us clues as to what we target. The second big problem, or the third big problem, is that IBD is unpredictable. And I spoke a lot about this yesterday when I showed about the defects in our current precision medicine. We want to be able to predict at each step along the way. Let's now think about this from the patient's perspective. They have the physical aspects, the psychological aspects, the fear of the long-term complications of the disease, also the while living with flares, with unpleasant, intrusive symptoms, major disruption to everyday life. And this bedeviling disconnect between symptoms and inflammation. I feel fine, doctor. Calprotectin 1,000 micrograms per gram, CRP 10 milligrams per litre. Jake puts his ultrasound probe on the belly, rip-roaring terminal ileal inflammation. Oh, doc, my belly aches, I can't sleep, I need painkillers, I can't work, I can't do anything. Everything normal. How do we monitor this in the real time? Our current monitoring strategies work, but they're invasive if we're doing colonoscopy. They're unpleasant if we're asking patients to collect a pot of poo so that we can measure it regularly. Patients will do it, they don't like it. There's a faff factor. And we can never do it frequently enough to test. We can hardly ask patients to go round with a rectal probe inserted so that we could do continuous calprotectin monitoring like we might do with a sweat patch for glucose for a diabetic. So what are the opportunities? We have this technological revolution. Well, with global satellite coverage, with telecommunications, we can enable digital telemonitoring to enable frictionless monitoring. We can think about dynamic biomarker modeling to predict outcomes for patients, and I'll talk about that in a minute. We can consider new smart technologies, wearables like my Whoop band that tracks my sleep, my fitness, and my other activities, to passively monitor physiology, and potentially, with the advent of sweat patches, still very much in its infancy, but looking to see if you can measure CRP, IL-1 beta, TNF-alpha in sweat. And then artificial intelligence, which will enable us to bring this together to deliver precise predictive algorithms, which can then transform endoscopy and imaging too. So my brilliant fellow Nick Pleveris in Edinburgh and I put together this review in gastroenterology a couple of years ago, and with our last display item we looked towards the future, where we considered that you might take a patient with active inflammatory bowel disease at diagnosis, where you would then take the patient into a remote monitoring setup using their smartphone, their wearables, point of care calprotectin if they're flaring, and then if the point of care parameters are abnormal, they would then come in for medical input. All of this driven by a local AI on their phone to drive forward improvements in their care. And we now have innovative finger prick collection kits so that we can do not just calprotectin point of care, but also blood tests. And these blood tests can be used to measure any number of proteins or chemicals or metabolites in the blood. But our best current biomarker, by the way, is fecal calprotectin. And we've been very early adopters of calprotectin in Edinburgh. We've been using it for 20 years now in clinical practice, and all the time I have refused to let the lab change the ELISA assay. So we have the same lab, ELISA, for 20 years, providing continuous data over that time period in our population. And I now have a brilliant mathematician working as a postdoc in my group, Nathan, and we've been working at modeling longitudinal trends of calprotectin over time, using mathematics to take patients' calprotectin trends over time, agnostic to anything else, and then using the machine to cluster patients. And you start to see clusters of patients with Crohn's disease here who are doing well or not so well. This was our first look. We're now modeling this in much larger populations, and you can start to look at calprotectin and CRP and highlight with the calprotectin, for example, some people who go down that red line and then do very well over time. You can see that dotted blue line across the middle. That's a calpro of 250 micrograms per gram, roughly what we would consider within target. Other patients who seem to be quite slow to do well, but ultimately do. And then this big group of patients who, for whatever reason, are just trending very badly over time. We see, as you would expect, that calprotectin clusters and CRP clusters don't interrelate. And so we think this is just one way you can take the existing biomarkers that we have, using the longitudinal trends to capture the dynamic nature of IBD, so that we can then take these inputs along with others from the EHR, feed these data sets into machine learning algorithms to then output true input with predictive changes for our patients in the clinic. And this, I think, will transform care soon. While I was here yesterday, I used ChatGPT to draw me a vision of the future. This was the image it generated for me. This patient, this physician looking at a patient's colon using artificial intelligence mechanisms to get things better. But it doesn't look too similar from the endoscopy units of today. This was from here in Hyderabad, thinking about how we can bring these tech solutions to our patient populations. So what does the disease monitoring of the future look like? Point of care testing for biomarkers, telehealth and teleconsultations, using mobile apps and wearables, as indeed is already happening, but we will skip to the next generation of these, where we will be able to truly get these working for our patients with meaningful data, with artificial algorithms that will take all of the data inputs in. This will transform care within the next 5 years. Within 5 years, I predict that all of your colonoscopy for IBD will be machine-read to complement what you're doing, that will give predictive inflammation. And then we will start to input dietary, microbiome, and molecular parameters as they're required and as the data provides it. But to get there, we need a path. The path is biomarker discovery and validation with deep longitudinal phenotyping of prospective cohorts with platform studies to test promising biomarkers. I discussed that yesterday. Smart technology to passively monitor. There is a lot of investment and work that needs to be done here to develop sweat patches, wearables, precision toilets to help improve health, with deep tech and artificial intelligent cares to develop truly innovative IBD care systems. And I think you really are well placed here in the tech hub, the tech capital of South Asia, perhaps, certainly of India, to truly transform care. Meantime, treat early, optimize, and monitor closely. And I leave you with my vision of the future, which will be that in 10 years, I hope every IBD patient, perhaps every person, will have not just a flushable toilet in their home to reduce the infectious illnesses we saw earlier on, but a smart toilet to measure continuously your calprotectin, your microbiome, your metabolome, so that we can truly passively monitor. Imagine being a person with Crohn's disease, going to the toilet, and having the toilet flash green in the morning as it flushes away your effluent to say, "Thank you, Charlie, have a nice day, your Crohn's disease is under good control." Thank you for listening.
Last topic of the session is intestinal ultrasound, when and how. Now we invite the speaker, Dr. Yoon.
All right, thank you very much. I just want to thank my dear friend Kiran and the organizing committee to invite me to this inaugural IBD Conclave meeting. It is my pleasure, and I'm happy to talk about intestinal ultrasound, which is passion of mine. But Kiran is so cheeky that he gives me 12 minutes to talk about this extensive topic. And I'll try my best to put it into 12 minutes, but if I go over, 13. One more extra. Oh my goodness, I'll try it in 13 minutes, but please don't give me that heart attack with the beep sounds. And if I can't finish and you want to hear more about it, more excuse to invite me back to India, which I love so much. So I will start, but before I start, let's go back. Can you raise your hands if you've been trained to perform intestinal ultrasound? So I know who my audiences are. Okay, put your hands up if you heard about intestinal ultrasound. Oh, majority. Okay. Now, be honest, courageous. Never heard of intestinal ultrasound. 1. Okay. So, we heard about probably intestinal ultrasound. We know that it's a valuable and increasingly important tool. Charlie was such a gentleman, he didn't even mention intestinal ultrasound throughout his talk, knowing that I'll be mentioning that, hopefully. It is a non-invasive and safe in both pregnancy. We don't have to prep the patient. We don't have to give them radiations. And look, it produces rapid result now and then. It provides a point of care testing that Charlie mentioned before. It is a good opportunity to educate the patients. It's easily repeatable, and it's a low cost with a huge cost saving. In our hospital, when we set up as a flare clinic, we saved about, I calculate, 6 million rupees in 5 months. That's how much cost saving you can do by avoiding hospital admission, ED admissions, and also all the investigation that's associated with it. Most of all, going back to the patient loves intestinal ultrasound. What can we see in intestinal ultrasound that how doctors love this modality rule, because we can see what Charlie refers as, we can see inside the gut, but also outside the gut, just then and there. We can look at the intestinal disease activity. We can look at important parameters like bowel wall thickness, Doppler signal, and mesentery changes to see whether someone got active disease versus in remission. We can also look at the location of disease activity to target the treatments. For example, in IBD patient with ulcerative colitis, what we had in panel discussion on Thursday, we mentioned what kind of diagnostic tool we're going to do and how we're going to manage it. It might be a wrong choice to do FlexiSeq on ulcerative colitis patient if they got reverse gradient colitis or has a cecal patch. So knowing where you're targeting is very important, and also assessing IBD complications, it is very useful. And you can also assess perineal assessment using perineal ultrasound. Not only that, our IBD patient also has a lot of functional symptoms that we come across. As Charlie said, there's a disconnect between the symptom and what we see as an active disease. So we need to manage patients not only IBD, but their functional symptom, and ultrasound is allowing to assess that and manage that effectively. What's in for patient? We did a survey in Australia in 2020, which showed that patient prefers ultrasound over any other investigating method that you're thinking about. Patients also think that it improves their knowledge of their disease, and then they understand why they need medical therapy, and they also understand their disease extent. Not only that, when they start to see the functional component of it, they're not anxious, they're able to go through this management together with us. So, there's a famous saying, a picture is worth 1,000 words. In here, we can see, let me just get this. Here, is that pointing? No. I'm not tech savvy. Okay, it is wasting my precious 13 minutes. Okay, so here. Okay, it doesn't like me, it's okay. It shows bowel wall thickness. This is what it's meant to show on the top one, and it also shows a Doppler signal showing how active or inactive the disease is. But imagine, if picture says 1,000 words, a motion, active, dynamic imaging can tell million words. So the topic that I got is when and how. So I broke it into when to use IUS in IBD. You can use in screening and to expedite the initial diagnosis. You can use to evaluate disease activity and complications, and also monitoring treatment response. How do you incorporate ultrasound in IBD practice? Well, I can really briefly go through how to get started, including training, equipment and protocols, but also how do you adopt the new model of care, and a little bit example of how MATA did it. So when do we use intestinal ultrasound? I really think we can summarize into 4 different aspects. Before you diagnose IBD, it can be used as a screening tool. Once you diagnose patient with IBD, you can manage patient in IBD clinic setting, you can manage flare patient, and also inpatient. They present with a gastrointestinal symptom, then you need to differentiate between whether it's active disease, or is it related to functional symptom, motility, or is it the fecal loading that they're having trouble with. When it comes to the treatment target that we're talking about, STRIDE 2 guideline, which I'm sure STRIDE 3 will come out with ultrasound making huge impact in ultrasound IBD management. You can look at response to treatment, transmural healing, and also consider ultrasound as an important tool to even de-escalate the therapy. In terms of screening, let's start with screening. We do know that Charlie mentioned just before my talk, presentation to IBD can be slow. Delay in diagnosis, we know, is notorious for Crohn's disease. And while we sort out the diagnosis, we can advance the bowel damage. However, ultrasound, as I said, offers non-invasive point of care and able to cross-sectional imaging to see where the disease is. So it's a good tool to identify what's happening inside the gut or outside. So it can potentially accelerate the IBD diagnosis. We don't use ultrasound to diagnose this, but we can say, okay, this patient can't wait for colonoscopy. The typical example that I can think is small bowel Crohn's disease. Someone is feeling little bit of abdominal pain, fecal calprotectin, only slightly above increase. What do? How soon do you perform colonoscopy for diagnostic purpose? Well, in India, according to Kiran yesterday, no problem, -1 week waiting list. In Australia, if you are non-urgent and no red flag symptom, it can take up to 1 year to get colonoscopy in public setting. So you can delay the diagnosis. And as you saw in Charlie's diagram, it goes up and down in terms of inflammation. If you have a colonoscopy at the time when they're okay, you might misdiagnose until their next flare. So, small bowel Crohn's disease, our ultrasound performed well. Well, this is looking at the image between A, the intestinal ultrasound imaging, versus B, which is MRI imaging. Again, in Australia, MRI imaging costs it's very expensive. So, at the time of patient coming in, they have symptom, mildly elevated fecal calprotectin. We can just put ultrasound on their belly and we're able to see the inflammation. If you do, then you know that this patient needs to go to colonoscopy urgently. There's a study last year done by Giovanni and his Italian group looking at 234 patients with suspected small bowel Crohn's disease. What he showed is ultrasound MRI is very comparable in accuracy. MRI does a bit more better in terms of looking at small bowel extension and fistulas, and they perform pretty similar when it comes to detection of strictures and abscesses. How about evaluating disease activity? So we've done the screening. We have been diagnosed with the patients with IBD. Then it is a useful tool, which I've mentioned before, looking at inside problem and outside gut problem. However, I thought I might just put your attention to post-op recurrence, how we can manage that as well as an example. We've got 52-year-old male with a Crohn's disease diagnosed early, come to us, no treatment for 20 years, did well post-small bowel resection. Fecal calprotectin 300, CRP mildly elevated, but asymptomatic. He thinks he's doing good. So you're worried and perform intestinal ultrasound at the anastomosis. So you are seeing the normal small bowel as it goes. I'm sorry, I don't have pointer to show you what I'm seeing. Can you see this? No. It's all right. There is a pointer maybe. So, let me go back. Okay, so this is normal small bowel that you're looking at. And soon, this is where anastomosis is. You're just trusting what I'm saying here. I can sell you a drug right now. And this is the inflamed bowel. So this is where the normal gas interface is, and that's how thickened bowel wall is, up to 7.1 millimeters. So we do know this patient's bowel is inflamed. Or it's thickened, so not doing well. But important question after that, which I find much better than MRI, is this active inflammation or is it scarred tissue where we don't need to escalate therapy? That's what the next bit is important. Here, we put the Doppler signal on and there's a Christmas light on. I tell my patient, Christmas light on your bowel is not a good idea. So this is a modified Lindbergh 2, patient has active disease, then we know that we immediately need to escalate therapy to prevent that advanced bowel damage. What about monitoring of the disease? This is one example showing Crohn's disease patient who had a very bad bowel thickness of 5.1 millimeters with color Doppler signal of 3. Started infliximab. 3 months later, we repeat the ultrasound. Everything has normalized. Good transmural remission. So does it work in all disease? Yes. I don't have time to go through everything, but in Crohn's disease, there's TRUST-CD trial. They're looking at how early is everyone responding to these therapies that you initiated. What we're finding more and more is how early different treatment works, but not only that, we found that the colonic disease respond much faster to small bowel disease. So it's not just you're treating it, you're treating different segments so that you can keep optimize their therapy. You see similar thing, this TRUST-UC study showing it can be as early as 2 weeks that we can see the response of the treatment. We can also use transparent ultrasound. If you worry about someone with proctitis, can you see with ultrasound? Yes, we can if we use different ultrasound technique. In terms of acute CVUC, this is a study by our team in Yashoda Hospital, looking at patients with acute CVUC as early as 36 hours of starting steroid therapy. You can see that reduction in bowel thickness and Doppler signal changes can be associated with steroid failure. So, how do I do intestinal ultrasound? It sounds pretty amazing. How do I do that? Well, you need 3 things. You need training person. You need to go through the training program, whether it's through IBUS or Genius, which is Australian-based. Either program, you have to complete formal program. I know we're going to have some hands-on experience today, but that's more of get to know the machine a little bit and what the hoo-ha is about, but it'll be good to go through official program. Competence is different. It's more like people with previous abdominal ultrasound experience can do much better quickly, needing they require, for example, people without abdominal ultrasound training, about 66 scans needed. If you have an abdominal ultrasound scan before 33 scans needed to get to competent level. However, it's ongoing learning. I've done more than 6,000 scans up to now, but I still need ongoing learning. Different pathology teaches me different things. You need equipment, you need cart-based machine, you need probes. You need a protocol to implement this strategy in your clinic. But every country I visit, when I try to educate on ultrasound, you have to assess your own feasibility in your hospital and in your country and adopt innovative model of care. So I thought I might show you how MADA did it. We started in 2018, and we have IBD ultrasound clinic. We have ultrasound clinic in parallel to our ongoing IBD clinic, and we have a lot of consultants who are able to scan, so they also have ultrasound machine in their own clinic room. We implement this in adult clinic, young adult, and also fertility maternity clinic as well. Also, we have separate rapid access IUS clinic for flare patients. We do use it in screening strategy in general gastro in private clinic as well. We do inpatient ultrasound during ward round, and we also have research ultrasound time where we perform in people with clinical trials, investigator studies, and we have a lot of ultrasound research happening at MADA. Also, we've got a lot of training people going through our center, whether that's international, national trainees. So currently, this is what our ultrasound clinic looks like, our programs. And we have a 3 cart-based machine with 1 more coming up, and we have a 4 handheld devices, which we are trialing on. We do have, other than 2 IBD consultants, everyone is able to ultrasound in our clinic, and we've got a lot of fellows and training coming through as well. That ends my talk, but I'm happy to take questions.
We thank all the 3 speakers for their excellent talk on this session. Now the house is open for any questions.
I think that was a wonderful talk, ma'am. I just wanted to ask, where do you see a bowel ultrasound replace the traditional colonoscopies?
Oh, I'll sit up or I can stand. So in terms of can you replace colonoscopy? No. I think it addresses different things. I think it can assess disease activity, it can monitor the treatment response. However, colonoscopy has its own role when you're trying to target the hard endpoint of mucosal and histological healing, and also looking at cancer surveillance. So we can't just not do colonoscopy overall, but it definitely reduces the frequency that we need to perform colonoscopy. Good question. So no, for ultrasound, this is what good things about it. We don't need any preparation for patients. So when patients come as per clinic visits, they come whether they eat or not. They don't need to fast. They don't have to take any bowel prep. We can see as it is.
If the bowel is fully loaded, fecal loaded, does it obscure your imaging and all those things? A lot of gas and everything, because gas is your enemy and during the ultrasound. So you won't pick up if you have a lot of gas.
It seems like you know a bit about ultrasound, which is good. That's what we initially thought. Oh, I guess it's our enemy. We can't see the bowel very well. We can't see the bowel content. But that is not true. It becomes your friend. Meaning, if a patient have a lot of gas in the colon, it tells you why they have certain symptoms. Is that gas distension, too much gas distension that's happening within the bowel causing abdominal pain. So I guess even though that's gas or fecal loading, we need to know as it is rather than preparing for it, because we're not seeing snapshot of how they perform at that time.
How frequently you do to assess the activity to intestinal ultrasound in a patient with IBD?
So as per you see in your clinic, so I don't separately put them into ultrasound for the sake of ultrasound. It's when I will see them anyway for their monitoring of response, then I'll do that. But in terms of flare patient, when someone reports to our IBD nurses, I don't think I'm doing well, I got more of the flared up symptom, then we see them hopefully within business hours, within 24 hours in our ultrasound clinic. That's a good question. So I've been asked by a lot of different, especially in Asian-based countries, they say, look, we are seeing 500 patients in one clinic. We don't have time to do ultrasound. I guess that's what I meant by you need to come up with your own innovative care. I'm happy to support different countries to come up with their model of care, but I don't think it's feasible for doctors to do everything. However, working with radiology department can be helpful. However, point of care testing. So if you use ultrasound as referring to radiology and doing it, you're doing like MRI. You're referring on and you're finding out what it is to make a decision. The best way to collaborate with the radiology, I think, is patient just before seeing you, do ultrasound with the radiology department and come to your clinic with blood, stool, ultrasound. Then you can make decision then and there. But it should be done within few days.
Professor, do you do the routine screening ultrasounds after an MR angiography has been done, or do you see this replacing MR angiographies completely?
So,
do you want a roadmap before you try to screen those segments which showed activity earlier, or this can be taken as the first investigation in a resource-limited setting and we can avoid MRs altogether?
That's a fantastic question. I'm going to really have a heart attack before this meeting ends. Okay, so I think two different scenarios. One is someone's symptomatic, you are suspecting IBD, then you do scan to see how quickly different investigation has to happen is one scenario. Then I do it then and there at initial consultation. I just put a probe in, it takes me less than 5 minutes. I know how quickly I need to escalate things. The other question is once I know this is IBD patient, then I do road mapping of everything, especially in Crohn's disease patients. Then I do ultrasound baseline, MRI baseline, and colonoscopy at baseline. Then I got complete roadmap of how patient is doing at baseline from top to bottom. Then I monitor that with different imaging modality that I'll be using to assess how they're going.
Want of time, we conclude this session. Thank you.
Thank you very much. I think the new frontiers in IBD are really exciting. And I'd like to invite Dr. Yoon to kindly come onto the dais to hand over the mementos to our chairpersons. Yeah, I request the chairpersons to come onto the dais, please, to receive your mementos. And I would like to inform all the delegates that we have a quiz between tea break and lunch break. So I would request all of you to please download the app. I mean, be here because we have very exciting and very nice prizes for that. So,
good morning. Next topic is role of surgery. As we all know, surgery is a main role in the treatment of IBD. That is strictures, complex perianal fistula, and management of severe active colitis, etc. So for this session, I'll invite chairperson this session. So Dr. Kona Lakshmi Kumari, Dr. Prasad Babu, Dr. Surendra Jasti, Dr. Govind Verma, Dr. Suresh Chandrahari.
Good morning all. I invite Dr. Mallikarjun GR, who is actually a senior consultant surgical gastroenterologist and robotic surgeon. He has been trained for laparoscopy and metabolic surgery in HPV and colorectals also, working at Yashoda High-Tech City. He is a member of Indian Association of Surgical Gastroenterology and Gastrointestinal Endoscopic Surgeons. His area of interest is hepatopancreatitis. He is going to enlighten us on strictures in Crohn's disease. What is the best timing for surgery? May I invite Dr. Mallikarjun to please come on the
I request
dais.
Dr. Jagan Mohan Reddy, surgical gastroenterologist, High-Tech City, Yashoda, to join the panel as the chairperson.
Good morning all. I was asked to talk about the right timing in Crohn's stricture. As such, it is a tricky topic to discuss, and to discuss in a hall full of medical gastroenterologists and tell them it's the time to stop medicines and send for surgery is even more tricky. So I'll try my best to see what I can do about this. So this is a picture I think most of you will find interesting, or at least you're fond of and take great pride in this. And this happened for various reasons, but at least according to me, this is the reason it happened. The catch was taken at the right time. The timing was so right that we could win a cup. So just like this, in every surgery, timing is very crucial. Most of our surgeries like Crohn's disease, the timing is even more important to optimize the patient and take for surgery. So before jumping into the topic, let's discuss a bit about strictures. Strictures develop around 5 to 15% at index, and 50% of the patients develop within 10 years. And at least 50% of the patients who develop strictures will need surgery at some point in their lifetime. And the unfortunate thing is, in patients who underwent surgery, 25% of them will require surgery again in their lifetime, usually within 5 years. So if we discuss the indications of surgery, there's a big list of it. Rather, if you see the conditions separately, as you can see, certain conditions don't require discussion. They have no controversy regarding the indications. Conditions like complete obstruction, and there's a free perforation, fistulas that are not treated by medical management, or rare indications like massive bleed or suspicion of malignancy. There's no controversy. Most often they end up in surgery. The controversy or confusion is always with the indications like medical failure, or when there's a patient who presents with recurrent subacute obstruction that needs a decision to be taken. So stricture, at least in India, most often it is still inflammatory, more than 50%, and around 25% it is around stricturing disease, and commonly seen in terminal ileum and colon and ileum. So there are various classifications for stricture, but what matters is whether it's fibrotic or inflammatory, a single or multiple, short or long, accessible or inaccessible, benign or possible malignant. So stricture is a physical obstruction. Why are we discussing so much? Why not we go ahead and chop off the stricture and be done with it? Why are we trusting our medical gastroenterologists to try out all their magic potions before trying for surgery? What is that that's stopping us? So as we all know, surgery for Crohn's disease is not curative. Unlike ulcerative colitis, it is definitely not curative. And the most dreaded concerns are the anastomotic leaks. The leaks are as high as even 14% in some studies, leading to more surgeries requiring more bowel resection, sometimes even ending up in mortality. The other dreaded complication is the recurrence. Recurrence rates are almost 35% within 10 years. Again, this data is all data before 2010. Things have changed a little later. I'll discuss it a little later. So the other complication, or the other concern for surgeons doing surgery at will is intestinal failure secondary to short bowel syndrome. Patients most often require multiple resections, ending up in short bowel syndrome. So these are the concerns for us to operate at will. So does that mean that delaying the surgery works? Definitely not. Delaying the surgery for long only makes the patient more malnourished, makes him more prone for both intraoperative as well as postoperative complications. So delaying is definitely not the solution to avoid surgical complication. So this is one of our patients, just to quote, we operated last week. He was diagnosed with Crohn's stricture, fibrotic stricture 3 years ago. He refused surgery, postponed surgery, and waited for 3 years, ended up like this with skin and bones. So whose mistake is this? The timing is none, it's not in our hands. It's a timing he decided, ended up like this. He's still in ICU fighting for his life. So what's the right time to operate then? So if we can find answers to these two questions, most often we can end up with a diagnosis. Whether the stricture is fibrotic or inflammatory, or the patient still has a chance with medicines or medically untreatable. If we can find answers to this two, at least, or one of this, most often we can end up with the right decision. So strictures are not always like this: inflammatory requiring no violence, fibrotic requiring a lot of violence. Most often they are all confusing like this. So there are always an overlap of fibrotic or inflammatory. Whichever is predominant, it is what decides the course of treatment. So this, at least over a period of evidence, over a period of years, we have some evidence to find out at least where we are heading. So fibrotic strictures can be picked up with a combination of MRE and biomarkers. The problem is patients who present with subacute obstruction or complete obstruction have difficulty consuming a lot of contrast, making MRE difficult. And for patients who have difficult body habitus, intestinal ultrasound is also difficult. So we have to trust only the biomarkers, which may or may not be right during the episode. So once we have a diagnosis that it is inflammatory stricture with either biomarkers or MRE or CTE or intestinal ultrasound, there's clear evidence that inflammatory strictures need no surgery. It's proven beyond doubt by Creole study or Strident study or real world analysis that definitely anti-TNF therapy works for inflammatory strictures. There's no controversy about it. In fact, Creole study shows even after 4 years the results are persistent. So we need a stratification, risk stratification to make or diagnose which patients require surgery. Over the years there are many, but one that has proven to be, at least for now, is good is Bacardi scoring, which takes penetrating disease, anti-TNF exposure, genetic mutation of CAR2, pre-stenotic dilatation and inflammation as the criteria, of which pre-stenotic dilatation has taken 2 points, making it more significant in making a diagnosis of inflammatory fibrotic stricture. So patient with higher score will always end up in surgery, so it is better to involve surgeon from the beginning if a patient presents with a higher score. So just for completion's sake, I'm adding this endoscopy. I know Dr. Santosh discussed in detail about endoscopy yesterday. So endoscopy, when medically failed or when there's a fibrotic stricture, endoscopy is considered better than surgery if the disease is less than 6 centimeters or it's multicentric, or who underwent multiple prior resections, or patient is poor surgical risk patient, or the strictures are easily accessible. And one important indication definitely is the anastomotic stricture. Most often endoscopic dilatation works, if not for anything, anastomotic stricture, more so for a patient who is debilitated secondary to surgery or whatever medication is. So for a treating physician or gastroenterologist, the common scenarios where we always end up fighting with is acute obstruction who has a stricture which is suggestive of Crohn's, and other one is persistent symptoms with recurrent symptoms. So for a naive patient, at least this is what we follow. Luckily we have a good set of understanding gastroenterologists who will discuss and involve us from the beginning. So acute obstruction with the short stricture, suspiciously inflammatory stricture, who responds to medical management, has no complications like perforation. Medical management is definitely the first choice, but at the same time patient should be also counseled about the role of surgery, because it is proven beyond doubt when there's a short segment disease, surgery is as good as possibly better than medical management. But if the patient has a long segment disease but still a limited disease, multiple strictures, the obstruction is progressive with possible complications like perforation, then definitely surgery is more better, or is definitely more rewarding for the patient than the medical management. So this is not this is a medical gastroenterologist suggestion. ECHO guidelines of 24 says for limited disease resection is better. And this ECHO guidelines was largely based on this LYRIC trial. I think you all know more about LYRIC trial than me, because I think most medical gastroenterologists hate LYRIC trial. There's a landmark study where the resection is proven to be as good as infliximab therapy, and it's cost effective. What's more interesting is the follow-up study, which studied after 5 years. It has shown that 75% of the patients who underwent resection required no additional biological therapy, whereas almost half of the patients who are in the infliximab group required surgery at some stage. So it is more than the first study. The follow-up study clearly says surgery upfront is definitely far better than medical management for patients with limited disease. So once a diagnosis is made in the post-operative biopsy, it's always easy to start prophylactic therapy to avoid the post-operative recurrences. Now comes the biggest problem. So I tried to get the definition of medical failure or medically untreatable patients and tried to research for almost a day and spoke with at least 5-6 medical gastroenterologists to ask for the definition. And what I came to know is there's no definite definition. Everybody have their own definitions. So I rather leave it to you when do you call it as a failure, because you are the people who are seeing the patient from the day one. So you know better when you call failure. Rather I, surgeon, calling it a failure. But at least if a patient has many of these symptoms as shown here, persistent symptoms, severe dietary restrictions making food a threat to the patient, severely malnourished, recurrent hospitalizations requiring stabilization, significant pre-stenotic dilatation, small bowel fecalization. If the patient has any of these things or majority of these things, definitely it is better to diagnose, or most of the patient is already on anti-TNF therapy, then definitely the patient is medically untreatable. So to conclude, this patient with persistent symptomatic disease, length is more than 4 centimeters, there are more than 4 strictures with significant pre-stenotic dilatation and Bacardi score more than 4, definitely surgery is better than medical management. If there's an inflammatory stricture with less Bacardi score, definitely medical therapy. For those in between which failed with medicines and doesn't want to get operated, endoscopic therapy is very good. At least echo guidelines 24 says till now echo endoscopic dilatation is the only accepted therapy, not the other structuroplasties. So once we have decided for surgery, emergency surgery is always it's not in our hand, but if you are planning for a semi-elective surgery or elective surgery, it's always better to prepare the patient to improve nutrition, because enteral nutrition patient have lower post-op complications compared to parenteral nutrition patients. Cessation of smoking helps, and tapering of steroid works for the patient. And most importantly, if there are any infective conditions like sepsis, abscess, that control also helps in better post-operative outcome. Interestingly, anti-TNF therapy has no role in the post-operative outcome. So there's no need to stop anti-TNF therapy. That's a great relief for most patients because most of them are already on high doses of anti-TNF therapy. So once we decided surgery is decided, there are multiple randomized control trials that shows laparoscopy as a better option. The options are structuroplasty and bowel resection. What as surgeons we are always taught is that in IBD, more so in Crohn's disease, try and resect as minimal as possible. Don't try to remove bowel because it is gold. So try to preserve as much bowel as possible. Interestingly, we discussed so much about short bowel syndrome in Crohn's disease. There was a study done which studied almost 25 years of work in high volume IBD centers. In patients who underwent 3 resections, the average length of bowel removed is only 36 centimeters. So it is our assumption that we end up removing a lot of bowel, but in carefully done surgical hands, the resected bowel is usually less. So let's not fear that we are ending up in short bowel syndrome and avoid surgery forever. So to conclude, short strictures, a small segment of intestine with multiple strictures, maybe resection is better. Multiple strictures at various levels, structuroplasty is required. Most often, what we in real world, what we do is we always do a combination of resection anastomosis and structuroplasties. But if there is a suspicion of malignancy, if there is a fistula or there is a massive bleed, better not to do structuroplasty for those lesions. So just for the completion's sake, these are the surgical procedures, less than 10 centimeters. Any chemicals procedure, more than 10 finish, more than 25 mycolysis procedure helps. These are the structuroplasties. And the new anastomosis that is accepted with the echo guidelines are the conus anastomosis, which avoids the recurrence. So to address back the original issue, why are we worried about surgery? Anastomotic leaks. These leaks are all, the studies are all before 2010. With better surgical techniques, better optimization, the leak rates are less than 3% since 2010 or 12 with better techniques. Recurrence with good biologicals given as prophylactically post-operatively, the recurrence is less than 3% or 4% in 5 years. So let's not worry about the things we've always worried, the leak and recurrence. Short bowel syndrome, as I told you already, if done in good high volume centers of IBD, the short bowel syndrome is pretty rare. To summarize, there is no universal rule. And goal, most importantly, the goal is not to avoid surgery. Let's remember, the patient is to be treated, patient is to be made better. The target is not to avoid surgery for him forever. The target is to make him better. So in the multidisciplinary team, always include the patient. The patient is the most important part of the team. The surgeon is important, physician important, but the patient is the most important. Interestingly, this one study which is done well ahead of biological times, but still relevant. A retrospective study which collected the data from the patients, 70 patients were studied. All of the patients felt that they are happy that they underwent surgery, and 75% felt that they preferred earlier surgery. So to conclude, I quote this catch again: 1 second earlier, it's still a catch; 1 second later, it's a loss for India. So maybe doing it little early may not be a crime as we all think for these days.
Thank you, Dr. Mallikarjuna. I think we'll have the next topic, and after that we'll have the questions. So now I invite Dr. M.N. Pavan Kumar, Senior Consultant Surgical Gastroenterologist, Yashoda Hospitals, onto the dais. He has done his MCS Surgical Gastro from AIIMS Delhi and did liver transplant fellowship from Seoul. He has about 22 years of experience in the field and one of the busiest surgical gastroenterologist in Hyderabad. His fields of interest include laparoscopic surgery, single port surgery, GI oncology, and minimal access coloproctology. Dr. Pavan Kumar, over to you.
Projectors. Right. Pointer. Forward, backward. Pointer not working. Any pointer? Okay.
Okay. Respected chairpersons, colleagues, friends, and dear students, I am Dr. Pavan Kumar, and I'm here to talk about the recent advances in IBD surgery. As we know, most of the treatment, the primary treatment in IBD is medical management, but still there are a subset of patients, 30 to 40% of patients with ulcerative Crohn's disease and 20 to 30% of patients with ulcerative colitis who may have to come for surgery. So the advances, when we speak about the advances in medical management, they have been phenomenal. The advances in surgical management are either the consequences or the results of what are the advances which followed in the medical management. The most important trend which we see in surgical management is the patients. We are seeing lesser patients with severe colitis needing surgery, the failure of medical treatment, the indication being the patients who come with severe colitis not responding to medical treatment, that has reduced. We are seeing a higher proportion of patients who have either a suspicion or a confirmed malignancy or a dysplasia as an indication for surgery. Most of the patients who are coming to us are presenting at a later age. The earlier age, their disease is better controlled with the medical management, all these biologicals. So when we talk about the surgical management, as surgeons, we feel it is not a failure of medical therapy, but part of the multidisciplinary approach. So when I was asked to discuss about the advances in surgical management, this being a short topic, covering the entire gamut of surgical therapies in inflammatory bowel disease is not possible. So what I want to go ahead is give a surgeon's perspective, how we approach the patients with inflammatory bowel disease, what is the current standard of treatment, what are the advances which you have seen in the last few years, and what is the roadmap ahead. Coming to the indications of Crohn's disease, we all know this is the strictures which are not responding to medical management as a complete obstruction either in the small bowel, colon, or in patients with complete anal stenosis causing obstruction, perforation, malignancy, the fistulas which are resistant to medical treatment. These are the patients who need a surgical treatment. There are some group of patients who are at a higher risk of developing this severe disease, which includes younger age, patients with perianal disease, smoking, weight loss more than 5 kilograms, and all this higher number of flares, disease duration more than 10 years. The present trend is to identify these patients early, go aggressively in them initially, alter the course of the disease in them so that these unfortunate people may not end up with a surgeon's hand. Crohn's disease is one condition. Not only the patients, we surgeons are also averse for surgery. This is the most important thing is when patients come to us for surgery for any condition, let alone Crohn's disease, they want a complete cure. They want a lifetime warranty for us. Doctor, we come for surgery, is it cured? Crohn's disease is one condition where we cannot guarantee it. The continuation of the disease, recurrence, progression of the disease is a certainty, and that's what we tell them in the beginning. Our intention of surgery in these patients is relief of symptoms. Get over the present problem, target the segment of bowel which is irreversibly damaged, treat it out, do a safe surgery, and then hand over the patient to the medical gastroenterologist to work out their magic with the biologicals. There are various surgeries available for Crohn's disease, but the principles of surgeries is the same. The most important principles are summarized here. The perioperative optimization, like in any surgery, perioperative optimization is important. This is both nutritional and disease control. The disease control regarding the biologicals, I'm going to come ahead later in the slide. The nutritional optimization is important in these patients because malnourishment is not an exception. It's a rule in patients coming for inflammatory bowel disease. All of them have malabsorption, either a stricture, perforation, patients on steroids. These are malnourished patients. Improving perioperatively the nutritional status with either a parental nutrition or an elemental nutrition improves the surgical outcomes. The second important advance, the most important significant advances in the recent times is the minimal access surgery. Whenever feasible, I'm going to come to it later on in the slides. The next important thing is the preservation of bowel. Our main aim in Crohn's disease is we are not aiming at a cure. We are only trying to remove the segment of the bowel which is irreversibly damaged. So preservation of the bowel is most important. These are the patients who are prime candidates for developing a short bowel syndrome, not because we resect long segments of intestines, because these patients also have malabsorption. The conventional saying of 100 centimeters small bowel adequate prevents the short bowel syndrome doesn't hold in these patients. These patients are likely to come up for further surgeries in the future. They can have fistulas, they can have malabsorption. So preservation of the bowel is the primary important principle in Crohn's disease. The next two techniques are the wide mesenteric excision and the type of anastomosis. These are the things which may reduce the recurrence at the anastomotic side. This is the drawback of one of the surgeries. We want to do, is there any benefit in these things? I'm going to come in the next slides. Diversion stoma is this is the insurance policy for surgeon, for the patients. In patients, when we end up operating patients with poor nutritional status, sepsis, where we think the morbidity, post-operative morbidity is more, we advise diversional stoma. This relieves the stress on the anastomosis, tides over the present crisis, gives us time for the nutritional improvement later on, and then give a definitive cure later on. So we surgeons are not happy operating patients on high-dose steroids. Steroids increase the leak rates, impairs the wound healing. These mask the initial signs of sepsis. These patients tend to crash catastrophically post-operatively, and that's why we are not happy with treating patients with steroids. But what about the biologicals? The initial concern is biologicals also being immunomodulators may affect the wound healing. But the difference is these are targeted molecules, and is there any, the recent trials which are showing, which has described, my colleague has described previously, the Puccini trial which showed there is no significant difference except for the paralytic ileus and minor complications. In patients with ulcerative colitis, most of the major complications are not statistically different between patients who received biologicals in the 3 months prior to the perioperatively or patients who have not received the biologicals. The major complications like abscess formations, anastomotic leak, bleeding, peritonitis, these are not statistically significant. So it is safe to say patients who are on biologicals, they are not a contraindication for surgery. Minimal access surgery, this is the most recent, most important advance in the last few years. Like in any other abdominal surgery, minimal access surgery is the standard of care. The same applies for the inflammatory bowel disease. The last few decades has been about the developments in laparoscopic surgery. The last few years is the robotic surgery. This increases the indications for laparoscopic surgery. The more complicated patients we can operate with a robotic platform. The differences are obvious. Patients like it. Incisions are small. Wound healing is better. Post-operative pain is less. Cosmetically it is better. The earlier recovery is good. But what is there's no two ways of going about it. Operative time is slightly longer because any minimal access surgery takes longer time to operate, but this is more than compensated by the shorter post-operative stay in these patients. This predominantly is because of the lesser pain. Post-operatively, the wounds are less, the adhesions are less, so the earlier return to work, faster recovery. This lesser adhesions is significantly important in patients, especially in young women where fertility is a problem. This also helps us in earlier reversal of the stoma. All this we can achieve without significant change in the leak rates, blood loss, or readmission. So, okay, we have perioperatively optimized the patient. We have taken up for minimal access surgery. Is there anything which surgeons can do to reduce the anastomotic site recurrence? The conventional saying is the mesentery in the Crohn's disease is highly edematous, highly vascular. Don't go. Crohn's disease is a benign condition. Don't go into the mesentery. Stay close to the bowel. But the problem is, mesentery is also part of the bowel, and the same highly inflamed mesentery may be the reason for early recurrence at the anastomotic site. So with the advances of the recent vessel sealing instruments, the current saying is, we dissect as much of the mesentery as safely possible to remove the inflamed mesentery. This may reduce the recurrence rate not only at the small bowel but also in the colorectal resections. Blood loss is slightly higher when compared to the limited resection, but wide excision significantly reduces the disease site anastomotic recurrence, as shown in the recent studies. If you see here, except for smoking, compared to the limited mesenteric excision, the extended mesenteric excision significantly reduces the recurrence at the anastomotic site. So this gives the technique. When we operate patients with inflammatory bowel disease, we always end up with two segments of bowel, and both of them are luminally disparity. One is either we do an ileocolic resection where one end is the ileum, the other is the transverse colon, or when we resect a stricture, the proximal distended segment or the distal collapse segment. End-to-end anastomosis is technically difficult and it is not advised. What we do is the side-to-side anastomosis, the functional end-to-end anastomosis. We close the both ends of the loops and then do a side-to-side anastomosis. The problem is we end up with more suture lines and the anastomosis is close to the mesentery. These two are the factors which increase the chance of anastomotic recurrence. So the newer technique which was described at Kono et al. Is the Kono-S anastomosis. That is the second slide. If you see, the ends of the bowel are opposed to each other as the posterior layer of the cerebromuscular. There we open the bowel longitudinally along the antemesenteric side away from the mesentery and close transversely, giving us a wide anastomosis. The advantage lies in we have lesser suture lines, the anastomosis is far away from the mesentery, the recurrence rates in these patients are supposed to be less. The initial studies, they do not show statistically significant reduction in the anastomotic recurrence, but what we can see is higher number of patients are recurrence free, and there is those patients who also have recurrence have less severe inflammation. The percentage of patients with severe inflammation and stricture are less in patients with Kono-S anastomosis compared to the conventional anastomosis. The next field is perianal surgery. Mostly it's fistula, abscess, external or rectovaginal fistula, patients with fissure or stricture, like in Crohn's disease, like in small bowel disease. Here also our principle is less is more. Do always the least possible technique. Don't try to damage the sphincter. Our main intention is to relieve the pain, relieve the sepsis, relieve the obstruction. Here also the predictors of recurrence include significant rectal disease, complex tracts and strictures. These are the patients who need to be identified early, treat them with biologicals after training with the cetons or fistulotomy, and then optimize their condition. This is the management of the anal fistula where still old is gold. The simple fistulas which are short inter or intrasphincteric fistulas where the sphincter involvement is less, fistulotomy is the best option. You just lay open the fistula, drains the abscess, removes the fistula, end of the matter. For problem with the complex tracts or suprasphincteric tracts, transsphincteric tracts which involve laudosphincter, this is the place where we use cetons. We drain the abscess, place the ceton across the fistula tract. These cetons are always soft, non-cutting cetons, and then send the patient to the medical management. All these techniques are described like mucosal advancement flaps, fibrin glue, pores and mucosal plugs, WAFT, the video-assisted ablation of fistula tract, lift, vac therapy, laser ablation. These are all the techniques which we use in non-Crohn's disease patients. They are quite effective in them, but if you see the success rate in Crohn's disease is around 50 to 60%, which is not great. The only hypothetical indication which I see is those patients for these techniques is those patients who already underwent a ceton placement, biologicals, whose rectal disease has improved, but fistula is persisting for some unknown reason. I haven't come across this sort of patient till now. So for completion, I have included this. These are the indications for Crohn's ulcerative colitis. And the same thing, the prognostic factors, all are self-explanatory like extensive colitis, severe disease, high histological inflammation score, disease duration more than 10 years, except for male gender. Why I don't know, the ulcerative colitis has this preference for males. So when we come to the surgical principle for ulcerative colitis, here the concept is different. We are looking at a cure. Instead of palliation, we are looking at a cure. So the intention is to do a total proctocolectomy, do a completion reconstruction with an ileal pouch elastomosis or an ileostomy in patients where IPA is not possible like in patients with lower rectal disease. Principles are same. Here the dissection we keep close to the rectum. We are not worried about the mesentery. We are taking out most of the affected bowels, so unlikely to have a recurrence. So we stay close to the rectum, so preserve the nerve damage, improves the urinary and sexual function. The residual stump should be less than 2 centimeter. Again, same thing to leave the as less rectal mucosa as possible. Diverting stoma is important because it reduces the clinically significant leaks and less risk of pouch failure. So, okay, in ulcerative colitis, we have treated the disease. Disease is gone, but is the patient happy? Definitely no, because pouch-related problems are significant. Up to 30% of these patients do develop pouchitis, pouch stenosis. Most of the time, we end up removing the pouch. So, this is the thing which is coming up, ileorectal anastomosis, which is described in 1950s. The advantage is we are preserving the rectum. The proponents say it maintains better continence. Moderately functioning rectum is any day better than the best pouch. So better continence, better sexual and urinary function. But the flip side is it's not curative. Persistent diseases are seen up to 50% of patients and up to 14% may need late rectal resection. So, but the important thing is with the advances in biologicals, can we do anything about it? Especially in young patients or limited rectal disease or indeterminate or Crohn's colitis or in the other extreme, old patients with poor sphincter tone, can biologicals improve the outcome and can we get off with an ileorectal anastomosis instead of an ileal pouch anastomosis? I just wanted to discuss. So our intention is target to reach, minimal access and robotic surgeries are standard, perioperative biologicals are reasonably safe, and we need to look at modalities to reduce the recurrence at the anastomotic site from surgical perspective.
Thank you, Pawan, for a elaborative lecture. I think this house is open for the question. And I'm sure that being a very important topic for medical gastroenterologists to know when to refer and what to expect from the surgeon and as well from the patient after the surgery. So perioperative assessment and post-operative assessment for any patient who is undergoing surgery in ulcerative or Crohn's, how do you do it? I mean, do you leave it to medical gastro or as a surgeon you see that aspect?
As my colleague has discussed, the indication for surgery we leave to the medical gastroenterologist. The indication, the timing for surgery, I don't go into the choice of that because you seeing the patient from the beginning, we leave the timing of surgery to the gastroenterologist. Perioperatively, the two things which we say, preoperatively, two things we are more concerned is patients on high dose steroids, we are not happy. The second is nutritional assessment. These patients need at least some good nutritional assessment, means perioperative nutritional improvement. Most of the patients malnourishment, as I suggested, as I explained, we need at least an albumin of 3 or 3.5 for an anastomosis to stay. These two are the critical factors which we look at. Third is the feasibility for minimal access surgery. Majority of the time we will be able to offer the minimal access surgery, either a laparoscopic or robotic surgery. But here the major concern is the coexisting factors. Suppose the patient has multiple previous causes, the difficulty of surgery increases. These patients may not be ideal candidates for minimal access surgery. The second thing is, as we see in our condition, in our country, financial reasons are an issue. So these are the important preoperative considerations which you look at. Post-operatively, when we look at patients, those patients who are at high risk for leak, those patients who have an active abscess or a sepsis, perforation, all these patients, we tend to go into more of stoma, especially in Crohn's disease. Stoma is the thing which is our insurance policy. We bring out a stoma, we are reasonably safe with that.
So really nice talk, thank you. I just wanted to ask you about acute severe UC surgery, the Indian setting. Do you do them laparoscopically in those who are needing colectomy during that inpatient stay, and what is the sort of trend in the country in relation to ASUC surgery?
UC surgery, most of the time we do a two-stage procedure.
Laparoscopic or open in acute severe UC?
Acute severe UC, as I suggested, the fitness levels are important. Young patients, we tend to go into more into laparoscopic surgery. Definitely laparoscopic surgery gives lesser post-operative stress on the patient. Laparoscopic surgery is a much better option. The problem lies in patients who are unstable. There we want to do a quick surgery and come out. That time the longer operative time for the laparoscopic surgery is a problem. Those patients who are unstable, suppose patients with severe ulcerative colitis who are in ICU, hypertension, like bleeding, all these patients, those patients we tend to go for an open surgery in these patients. Hello.
Thank you. That was a very nice talk. Can I ask a very naive question? Are there pouches that you create for post-ulcerative colitis colectomy that are less prone towards pouchitis?
Didn't get it, sorry.
Are there different types of pouch surgery? Are there certain types that are less prone to pouchitis?
The most common type we do is a J pouch.
J pouch, yes.
And according to my knowledge, I don't see any difference in the pouch failure rates between the J pouch or an S pouch or a W pouch, all these things. Two patients who had very poor nutritional status, and those patients, as I told, ileorectal anastomosis. I had two patients who presented with, probably one is an indeterminate colitis, the other patient is vehemently against the pouch. These are the patients where I gave the option, I did an ileorectal anastomosis in them in a single stage. And I have the follow-up of those patients with around 4 years. Till now, rectum is maintained. So I don't know what is the future with the biologicals, whether we can preserve the rectum. It significantly changes rather than the type of the pouch. If we can preserve the rectum in these patients. Ileorectal anastomosis is such a simpler technique. We don't need to have a stoma. The anastomosis heals well. That is going to change the management in ulcerative colitis. If at all there is a molecule, magic molecule, something which comes, which will improve the outcome for the preservation of the rectum in these patients, it removes all the problems of the ileal pouch.
As we all know that although they are well, but the poor compliance for the follow-up and surveillance in rectal remnant with increased cancer risk is a challenge here in India. What are your opinions? What do you think about the follow-up of these patients?
Following ileorectal anastomosis. As I told, my experience is limited. I had only done it 2 times only because most of the time is the patient visits. Both the times it is patient visits. So they are happy with taking the chance. These patients had follow-up for 4 to 5 years. We call them for just a sigmoidoscopy. There is no need for a colonoscopy in this patient. Just sigmoidoscopy will cover this disease. And till now they are reasonably well. I don't know about the other studies. So that's what I wanted to discuss about this.
I think we are running short of time, and thank the speakers for enlightening us, and we'll move to the next session.
Thank you very much. I thank the chairpersons and the speakers of the session. I request the chairpersons to kindly come onto the dais to receive the mementos. Dr. Pavan and Dr. Mallikarjun also kindly request him to come onto the dais. I request Dr. Kiran Kumar also to come onto the dais.
Good morning all. Next we have another interesting panel discussion over opportunistic infections in the IBD. So we all know nowadays with the increasing use of the corticosteroids and immunomodulators and biologic agents, they are improving the clinical efficacy. Also they are having the adverse effects like an opportunistic infections. So now I invite the respected panelists, Dr. Vijay Eldandi, Dr. C.J. Ui, and Dr. Jatin Egurla, Dr. Kavita, Dr. Panduranga Rao, and Dr. B. Prabhakar. So I request one of the panelists. So we don't have this. And Dr. Mona Lisa. Now I request one of the panelists to introduce our speaker. Dr. Jatin, can you please invite our speaker to dais, Dr. Saurabh sir.
Good afternoon all. I would like to invite Dr. Saurabh Kedia, faculty gastroenterology at All India Institute of Medical Sciences, New Delhi, to start the session.
I can do with this. Yeah. Okay. Good afternoon, everyone. So first of all, on behalf of all my panelists, I would like to thank Dr. Kiran Peddi for this opportunity and invitation. So we have to discuss about the opportunistic infections in IBD over the next 40 minutes. So I'll start off with a brief introduction before I bang on my questions to my esteemed panelists. So ECO guidelines on opportunistic infections has defined opportunistic infection as a progressive infection by a microorganism that is limited to that has limited or no pathogenic ability under ordinary circumstances, but is able to cause a serious disease as a result of the predisposing effect of another disorder or its treatment. So what are the risk factors for opportunistic infections in patients with IBD? We all know that the use of immunosuppressants predispose them to the risk of infections. But other than that, the malnourished state, increasing age, patients who are post-operative, also especially if they have been malnourished prior to surgery, are at increased risk. And disease activity itself is a risk factor for infections, which often acts as a confounder when we assess the risk of infections on various IBD therapies in patients of IBD, ulcerative colitis as well as Crohn's disease. And if we consider the degree of immunosuppression with various IBD therapies, then aminosalicylates are absolutely safe. They don't have any risk or any systemic risk of infection. Topical steroids again are in general safe. Systemic steroids at a dose of less than 20 milligram equivalent of prednisolone for less than 2 weeks are considered as low risk to have a low risk of immunosuppression, while steroids at higher dose are moderate to high risk of immunosuppression. Vedolizumab, being gut selective, increases the risk of GI infections, but in general has low systemic toxicity in terms of infections. Methotrexate and azathioprine in low doses, which has been defined, again is considered as a low risk of immunosuppression, and other agents including the calcineurin inhibitors, the anti-TNF, anti-IL-23 JAK inhibitors are all considered as moderate to severe risk of immunosuppression. So now with this brief introduction, I'll move on to the case, who is a 40-year-old male, became symptomatic in 2013 with bloody diarrhea and abdominal pain, colonoscopy suggestive of ulcerative colitis, pancolitis, treated with mesalamine and steroids, and improved. I'll begin now with Dr. Prabhakar. This is slightly off the track, but I thought we should discuss this. So, Dr. Prabhakar, so do we need to work up our patients when they present to us for the first time for the infections? And also, when they relapse, do we need to rule out infections in these patients before we step up their therapy or start them on IBD-specific therapy?
With the case that you have given, 40-year-old who presented in 2013, that was the time. So, do we need to work up the patient for infectious present in the stool at the index presentation only? When any such patient, a patient who comes with abdominal pain, blood and mucus stools, the initial focus will be on making a diagnosis, which can be done with colonoscopy and also biopsy. Once that is confirmed, in such cases, suppose the disease is little atypical, the severity of symptoms are more, or it is lasting longer, then it is mandated at that point itself to look for some infectious reasons. For example, it can be either CD or any of these. So better investigate in such an aspect. So accordingly, they definitely make a difference, either it's infectious colitis or it is a case of that is ulcerative colitis. Second, during the flares that is there, usually in this case, for example, if a patient was stabilized and doing well, in between suddenly he becomes very bad or there's a flare. In such cases, if you remove the other cause, for example, he was not compliant with the treatment or other things that you would think of is, again, any infection has set in. In such case, again, look for these infectious causes, bacterial. I think the commonest one is this Clostridium difficile, or look for other causes also. So these two cases, at the index presentation, we should, depending on the clinical situation, and also when the patient has got flare-up, we should definitely investigate for the flare-up.
Yeah, thank you, sir. So this is what the ECO guidelines suggest. For the initial investigation, patients can be, C. diff should be excluded, and if the patient has flare, so patients should be tested for C. diff, and especially if the patient has background of severe disease or severe immunosuppressant use, then CMV infection should be excluded. Now, what about other enteric infections? So in this systematic review, which looked at the prevalence and the impact of enteric infections in patients with IBD, it concluded that clinical significance of positive result for non-C. diff enteric infection in patients with active IBD is debated because of lack of robust outcome-based evidence, and there have been several non-C. diff infections which have been associated with higher prevalence in patients with IBD as compared to controls, and there are some which have lower prevalence in IBD patients as compared to control. But as of now, if we go by the guideline and if we go by the recommendations, then for patients with flare, we need to test them for C. diff, CMV in specific situations, other enteric infection in a background, and it should be individualized and should be decided on case-to-case basis. So now my question to Dr. Kavita, moving from the enteric infections to the systemic infections. So ma'am, what is the prevalence of positive serology for viral infections such as chronic hepatitis B, C and HIV in patients with IBD? And do we test all of our IBD patients for these infections or a select group?
Sir, for any patients with IBD, routinely we do the screening for HBV, HCV and HIV to know the status of the patient so that transmission of the infection may not be there next, and what is the condition of the patient. If you see the prevalence of HBV and HCV and HIV, it's almost the same as the general population. There is no specific increase will be seen in these patients.
Yeah, thank you. So the same has been replicated in cohort studies from India, and this systematic review by Suprabhat, which again showed that the prevalence is similar to that of the general population. And ECO again suggests serological screening for B, C, HIV. It also suggests for CMV, EBV and varicella and measles in select situations at baseline, and especially before or during the immunosuppressive treatment. I'll add in a word about the anti-core antibody, which has been shown to be positive in about 14% of patients with IBD in that same systematic review. And the significance lies in the background of immunosuppressant use. So if we look at this table, then none of the IBD therapies in patients who are anti-HBC positive and HBsAg negative are associated with high risk of reactivation. But the integrins and anti-IL-23 and the anti-TNF and high-dose steroids have a moderate risk. So these patients we need to be cautious when we are using therapies in these patients, especially if they are anti-HBC positive. Although they are not recommended to be started on antivirals, but a regular testing with DNA and liver function test should be done when these patients are on these anti-immunosuppressants. So now we come back to the patient again. For the next 4 years, he received multiple courses of steroids with oral and topical 5-ASA therapy, had an aggressive disease course. To 2017, he was started on azathioprine, which till 2021, he received azathioprine with intermittent short course of steroids again. He had steroid-related adverse events, including cataract, for which he was operated. In January 2022, he again had increased symptoms with weight loss. And at this point of time, Dr. Rao, so what are the common infectious adverse events associated with steroid and azathioprine use? And is there a specific checklist which you follow while you start your patients on immunosuppressants?
Patients who are receiving azathioprine at dose more than 3 milligrams per kg body weight, or steroids who are being treated with more than 20 milligrams prednisolone equivalent are at higher risk of developing complications. By far most, when they are given together, risk of complication increases. By far most common thing we see is the candidal risk. So esophageal or orocutaneous or vaginal candida is most common. So if we can classify them as, for convenience sake, viral, bacterial and fungal. Viral cytomegalovirus, especially specific for this. Otherwise, other things is the reactivation of hepatitis B, measles, and herpes simplex, herpes zoster are common viral infections we see. And another thing is bacterial infections, especially those who are receiving bacterial infections are more prone for lower respiratory tract infections, cutaneous infections, and sepsis actually. If you take into pulmonary infection, reactivation of tuberculosis is important. And those with the pre-existing pulmonary diseases or diabetics or alcohol, take a lot of alcohol, they are prone for infections by pneumococcal and H influenza. Another fungal infection we can see is pneumocystitis and aspergillosis, cryptococcus. Rarely we can see patients with hyperinfection with
Strongyloides.
Strongyloides stercolis infection also.
Yeah. Thank you, sir. So this is in broad, although all these immunosuppressants are associated with different types of infections, but if we categorize them, and then risk of fungal infection increases with steroids, thiopurines are associated with increased risk of viral infections, and anti-TNF with tuberculosis, histoplasma, and the bacterial infection that's suggested by Dr. Rao, and anti-integrins are associated with the increased risk of GI infections. And if we compare the risk, then the risk increases with the increasing immunosuppression. So with combination therapy, the risk is highest, followed by anti-TNF monotherapy and thiopine monotherapy. The same was reiterated in this systematic review by Siddharth Singh, which again showed that the combination therapy has the highest risk. And if we compare the recent biologics, then between ustekinumab and anti-TNF, ustekinumab is safer in terms of opportunistic infections. Again, between vedolizumab and TNF-alpha antagonist, vedolizumab is safer. And between ustekinumab and vedolizumab, ustekinumab is considered safer than vedolizumab with compared to the risk of infections, although the risk varies between the ulcerative colitis versus Crohn's disease. So this is the checklist which has been recommended by ECO. It can be downloaded from the website, which has these components of detailed medical history for previous infections, vaccination, a detailed examination, history of travel, especially in cases which have low risk of infections, the immunization status, history of vaccination status for the measles and the varicella, and again the specific laboratory test to assess for any concomitant immunodeficiency or infection. So this checklist is a simple checklist which can be followed whenever we are planning our patients on immunosuppression. So now this patient again was started on tofacitinib in January 22 for his flare. There was no improvement. He also had pyoderma gangrenosum. In February and March, he received another course of steroid on which he had partial improvement. The pyoderma gangrenosum had resolved. So this patient had received multiple courses of steroids, had received azathioprine, and now he was started on tofacitinib. So my question to Dr. CJ, so what are the risk factors for herpes zoster reactivation, which is a common infection with tofacitinib, and what should be done if the patient develops herpes zoster? How should he be treated? And should tofacitinib be stopped or should it be continued?
I think on the first question, I think the biggest risk factor is age. Older patients tend to have development of herpes zoster more likely than the younger patients. The dose of the tofacitinib, so that means at induction dose, when the dose is higher, I think usually that's the biggest risk factor. Other treatments, like he's been on steroids, I think that's also an issue. If the previous biologics, especially anti-TNFs, I think that's also accumulated. And personal history of previous herpes zoster infections. And of course, we have to go back to whether he or she was vaccinated with herpes zoster. In Asia, there is a little bit of difference in terms of herpes zoster risk. I think for whatever reason, the Koreans and the Japanese, in their subset analysis of TOFA, octave studies and all that, they've shown that they have increased risk compared to Chinese, Indians. So Chinese and Indians are presumably like Europeans. Our risks are not as high as the Koreans and Japanese. What will we do? Funnily, today, my nurse called me and said, my patient on upadacitinib long-term study, year 4, developed herpes zoster. What am I going to do with the trial drug? So I asked the nurse, find out for me, please, whether it's single dermatome or it's complex. And what is the current dose of that label? Because it's blinded to me. Can the CRA tell me whether it's high dose, 30 milligrams, or a small dose? So whatever it is, we will intervene with oral isicovir, because he came back with the single dermatome buttock disease. If it's complicated, disseminated, and affects important visceral organs, I would definitely interrupt the small molecule for now. But most studies will say after they recover, you are able to put them back. In fact, if you do the rheumatology studies and all that, 95% of the patients either just require transient interruption or continued if they have uncomplicated mild disease.
Thank you. So high dose increases the risk. With patient with minor infection like single dermatome, tofacitinib can be continued. However, if it's a severe infection, then we need to stop. So now, Dr. Jatin, how do I prevent this complication?
So we can give recombinant zoster vaccine intramuscular, 2 doses, at least 2 months apart, and this will help us in preventing the zoster infection.
Yeah. So if we look at the vaccines, there are 2, the live vaccine and the recombinant vaccine, which was introduced in India last year and globally in 2017. So if we look at the vaccine efficacy in general population, then the recombinant vaccine has a higher efficacy than the live vaccine, which is equal about across all age groups and is persistent with the same efficacy beyond 4 years of age as shown in the studies, and even beyond 9 years. If you look at the evidence in inflammatory bowel disease, then this study in CGH showed that it was associated with the decreased risk of herpes zoster infection among all the age groups. And even in this study, it showed that the vaccine was immunogenic as well as safe in patients who were already on JAK inhibitors or other immunosuppressants, indicating that this recombinant vaccine can be given in patients who are already on immunosuppressant, although the efficacy may be slightly lower, but we need more data on this. So we look at the recommendations. Then the recombinant zoster vaccine is recommended in all categories, in patients more than 50 years of age, with or without immunosuppression, and even in any age group before starting biologics or JAK inhibitors. So now I come back to the case again. He did not do well on steroids. After receiving multiple prior courses of steroids, azathioprine and tofacitinib, so he was started on infliximab, which he received the usual induction doses at 0, 2 and 6 weeks. And at this point of time, he achieved clinical remission. Now, Dr. Prabhakar. So tuberculosis is a dreadful complication of anti-TNF use in India and the other endemic countries. So now what is the risk and what are the associated risk factors for the reactivation of TB with anti-TNF use, and how do I prevent this risk?
as this patient has received anti-TNF, and from the previous slide that you have shown, anti-TNF, they are more prone for reactivation of tuberculosis, especially in country like India. In our cases, we have to look for two things. Does the patient have latent tuberculosis, or this can get reactivated, or when there's infection, active infection, it's going to manifest further. In the presentation, what you have shown is the patient also had a loss of weight. So there is very, very high risk in this patient who is especially on anti-TNF. And we should take every effort to look for latent tuberculosis or active tuberculosis in this patient. How do you go about doing this one? One of the tests that is there available for us, this PPT, that is tuberculosis skin sensitivity test, Montos test. Another one is a TB gold quantiferon test. We have got a choice using these two, and the easiest one that we can get is usually this Montos test. And the interpretation regarding that one has got a lot of fun. Each person will. But if the positivity is more than 15, we can definitely take it as a positive one. Regarding the persons having the BCG vaccination, this test has got certain, controversies. In such cases, it is better that we go for this TB gold quantiferon test, which will show whether there is an active infection or even latent tuberculosis. Once we have that one and the patient has to be started anti-TNF, we have got two options. Go for prophylactic treatment. Here already patient has received that one. So if there is reactivation, go for active treatment of tuberculosis. For prophylactic, we have got INH prophylaxis, which is given for 9 months. In other cases, we have to go for full treatment of ATT.
Yeah. So the risk is higher in the TB endemic zones, and it increases with combination therapy, and as Dr. Prabhakar told, with underlying malnourishment and comorbidities of the patient. So this is a checklist which we can follow before administering anti-TNF to our patients, and we need to screen for latent TB and for viral infections. And we have shown that a stringent TB screening combining MON2, IGRA, CT chest, past history of TB and history of contact with active TB significantly reduces the risk of TB reactivation, and therefore we follow this strategy at our center. So we do both MON2 and IGRA. We do a CT chest, because it reveals more findings suggestive of latent TB like calcified lymph nodes or any fibrotic bands. We look for past history of TB, and also we look for history of active contact with TB before we decide whether we need to give patient prophylaxis for latent TB or not. And between MON2 and IGRA, as Dr. Prabhakar had told, that the MON2 would be less interpretable in patients who have received BCG vaccination. So this study by Dr. Puri from GB Pant showed that the concordance was not 100% between MON2 and IGRA, and there were cases in which either was positive. So it's recommended that to go for both if we need to have higher yield of latent tuberculosis and prevent the reactivation of TB in these patients. In patients with immunosuppressant use, the cutoff of MON2 can be reduced to 5 mm. In patients who have received BCG vaccination, it's 10 mm. So the cutoff will vary depending upon the background of the patient. So now, Dr. Rao, what are the various choices of TB chemoprophylaxis regimens, and can we start anti-TNF if the patient has developed active tuberculosis?
Actually, INH with 300 mg per day for 9 months is standard of care with 90% response rate. And we can give also for 6 months with a response rate between 60 to 80%. There are other equivalent options. One is rifampicin daily at the dose of 10 mg per kg body weight 4 months. Second, rifampicin plus INH for 3 months. And there is another supervised dose where you can give a rifampicin, which is a long-acting drug, in a dose of 900 mg with INH 900 mg once a week for 12 doses, 3 months. This is also found to be effective, and patient have a better adherence, and we are sure patient is receiving the treatment. And regarding the giving biologics when patient has active tuberculosis, the standard recommendation is stop the biologics if not taken, or give the treatment for 6 months course and then start biologics. However, there is one organization, British Thoracic Society, they recommend continuation because based on the experience of TB treatment in HIV patients who are more immunosuppressed, they recommend this should be continued if stopping is going to be affect the patient's active disease activity, can cause a relapse or complications.
Yeah, thank you, sir. So if a patient has latent TB, then if we can wait, we wait for 4 weeks before we start anti-TNF. However, it can be started simultaneously if the patient has more severe disease. With the active TB, we stop. We can start after 2 months of ATT if the patient requires anti-TNF urgently. Yeah, so Dr. CJ, is the screening for latent TB specific to anti-TNF, or we need to screen for all advanced therapies like JAK inhibitors, anti-integrins, or anti-IL-23?
I think we definitely need to screen LTB for JAK inhibitors. The bigger discussion is whether do we screen for anti-integrins or IL-12/23. I think as a habit, because we ran the studies for Gemini, for vedolizumab and so on and so forth, we did screen. But I think maybe there's a more movement saying that perhaps we don't have to, but the caveat is we still have to take a good history, make sure there's no possible exposures to tuberculosis, and also to understand where the patient is from, low or high endemic countries.
Yeah, thank you. So especially for India, we should screen for latent TB for all patients who have been planned for any of these advanced therapies, and we have reports of TB on vedolizumab, ustekinumab as well, and tofacitinib, it's very well documented to cause TB. Between these, tofacitinib has a higher risk, but the risk still remains with vedolizumab and ustekinumab, especially in areas with high endemicity for TB. Okay, so after 3 doses of infliximab, he had recurrence of colitis. He developed generalized weakness, weight loss, and at this time point, he also developed fever and cough. So when he presented to us at this time point, and at that time, he had profound pancytopenia, HB of 6, TSG of 800, platelet of 37,000, albumin was also low, and CRP was high. Sigmoidoscopy showed diffuse loss of vascular pattern with deep ulcers, mucosal bleed, and a severe endoscopic activity, UCIS of 6/8. So, Dr. Kavita, would you suspect CMV colitis also in this case? And if yes, then how would you investigate for CMV colitis?
Yes, sir, definitely we had to think of CMV colitis in this patient because he had taken immunosuppressants, steroids as well as azathioprine, then tofacitinib he had taken, and infliximab also has been given. After 1 month after giving infliximab also, he has the recurrence of symptoms. He's having fever, body pains, weakness, and cough is also there. We have to definitely think of opportunistic infections with CMV colitis with endoscopy suggestive of ulceration lesions which are there. And then in the evaluation for CMV colitis, we can have the tissue biopsy which will be taken from the edges of the ulcer and the base of the ulcer. For CMV inclusions which will be seen on histopathology. Second one is by means of testing for the antibodies IgM and IgG to assess for acute or chronic infection with active disease. And third one is by means of PCR reaction, we can assess the cytomegalovirus.
Thank you, ma'am. So we suspect CMV when a patient has a prior history of immunosuppressant use, severe disease, refractory disease, and the prevalence of CMV increases with the disease severity and refractoriness to the immunosuppressants. And both ECO and BSG suggest investigating patients for CMV, especially with refractory IBD who are not responding to the immunosuppressive therapy. So we need to differentiate between infection and disease. So infection is when CMV is a bystander, and disease when it's causing disease. So it is diagnosed in the presence of appropriate clinical and endoscopic disease activity or suspicion of disease. So testing, we can have blood tests which are not very specific for the tissue infection, so not recommended. In terms of tissue test, as Dr. Kavita has told, the best test is the inclusion body, but it has a very low sensitivity. So we go either for tissue PCR with a specific cutoff or for IHC for CMV antigen in the biopsy. So in this patient, the CD toxin was negative. His qualitative PCR was positive. We did not have the quantitative PCR value because it was not available in our hospital at present, and patient was unable to afford it to get it done from a private lab. So this was the summary of this patient. So ulcerative colitis, pancolitis, onset in 2013, a steroid-dependent disease course, azoran intolerant, azathioprine intolerant, received tofacitinib for 15 days, infliximab 3 doses, presenting with acute severe colitis, has pancytopenia, which probably is azathioprine induced, but could also be related to CMV with opportunistic infections. So, Dr. Jatin, to control the disease activity of this patient, what do you think would be the best therapy at this point?
Sir, since the patient is tested positive for CMV, we would start IV ganciclovir.
But the TLC is 800.
So we
He
would
has cytopenia.
start IV steroids because the patient has acute severe ulcerative colitis, and once the counts recover, or we can give GCSF and then treat with CMV as well.
Yeah. So we also had a dilemma in treating this patient. He was immunocompromised. He had infection. We could not give any anti-TNF, any JAK inhibitor. Surgery was also out because of profound cytopenia, which would increase the risk of postoperative complications. So we went ahead and gave him IV steroids followed by oral steroids. Fortunately, his disease activity improved. His steroids were tapered, and he was maintained on oral and topical 5-ASA and topical steroids. So now, Dr. Mona Lisa, coming to our ID specialists now. Patient had persistent fever, chest X-ray showed a left lower zone patch. So now, what would you suspect at this stage, and how would you investigate?
This patient of ours has like all the risk factors, like having been given the anti-TNF inhibitors, high dose steroids, and now he's having persistent fevers with chest X-ray showing patch. So in our scenario, it can most commonly be a tuberculosis with presenting such. The other non-tuberculous mycobacteria like the Mycobacterium cancerci and abscessus can also be there. The fungal infections are also higher on the list, like invasive mold infections with aspergillosis or mucormycosis. Even the cryptococcosis can cause this picture. Endemic mycoplasma infections like the histoplasmosis can also be there. They can also be due to bacterial infections like pulmonary septic emboli in case of endocarditis, but in those cases the blood culture will also be positive. So going ahead with the nocardia can also cause such pictures. So we got a broad list of DDs. So we should go ahead with the invasive testing, like going ahead with the bronchoscopy and taking the sample bronchoalveolar lavage to be sent for investigations. We should send it for AFB staining and gene expert ultra along with the cultures, liquid cultures. Send it for a KOH mount for the fungal infections, and the fungal PCR can also be done, and galactomannan and fungal cultures. The biomarker can also help us. Modified AFB staining for the nocardia can help, and gram stain and bacterial cultures can be done.
Yeah. So this CT showed nodular aposities in the left lower in the lower zones, and based on CT chest findings, patient was very sick for any ball, and we had sent his sputum workup, but we started him on empirical antitubercular therapy. So now, Dr. Vijay, Dr. Mona Lisa has already showed that fungal infection is also on the list. So what is the risk of these infections in patients on anti-TNF? And are there any biomarkers?
So I think just to put things in perspective, I'll tell you a little bit of my personal experiences, okay? The very first thing I did as a young assistant professor of medicine was investigate an outbreak of aspergillosis in lung transplant. In fact, we were the first people to report aspergillosis in lung transplant. And we looked at everything very carefully in terms of common exposure and other features like immunosuppression, all right? And the reason we look for all of that is that we always think that aspergillus is related to the amount of immunosuppression, specifically corticosteroids in particular, are very, very high risk. So in our cohort, we did not find any difference between the people who had aspergillus and the people who did not have aspergillus in terms of the immunosuppressive therapy that they got. But at that time, Bob Rubin, who was at Mayo, was also popularizing this concept of net immunosuppression. What net immunosuppression means is the immunosuppression that results as a consequence of the underlying disease or organ dysfunction. In addition to that, the iatrogenic immunosuppression, but just as importantly, immunomodulating viruses, in particular cytomegalovirus and Epstein-Barr virus, parvovirus B19, etc. That's germane to this case because you showed that he had pancytopenia. The first virus you would suspect of doing pancytopenia is parvovirus B19, and a quant PCR in the blood is the best way to diagnose it. It's very easy, simple, right? The study that we did showed that the greatest risk for aspergillosis was actually prior CMV disease. The odds ratio was something like 9 for people who had CMV disease as people who did not have CMV disease. Now, JAK inhibitors. Everybody talks about the risk of zoster, which is there obviously, but anybody on a JAK inhibitor, you should look for CMV reactivation. And the highest risk is if you have somebody who has a prior IgG positive for CMV, that's the person at risk for reactivation, all right? And there are two strategies. You can do CMV PCR surveillance, or you can just look and as and when they have a syndrome, ask for diagnosis. And typically, and we showed this again in our cohort at Loyola many years ago, that quantitative PCR in the blood would predict onset of CMV disease in a lung allograft. The hooker here is that this concept does not work for GI disease. We have found a big lag period in people who have biopsy-proven CMV disease in the gut and their peripheral blood viral loads of CMV. In fact, some of these people had the viral load in CMV go up in the peripheral blood a week to 2 weeks after we had made the diagnosis in the gut, all right? Secondly, be careful about ganciclovir. Unfortunately, for some reason in the gut, the ganciclovir doesn't work as well. Certainly the oral ganciclovir would not be an option, or oral valganciclovir would not be an option. You would try IV ganciclovir in these people. And if the cytopenia is actually caused by CMV, you will actually see an increase in the levels. So a couple of things that you could have done is you could have looked at whether or not there is CMV in the bone marrow biopsy, all right? And sometimes you'll find that, you get lucky. The problem with using qualitative PCR is in anybody with significant illness of any kind, they shed herpes viruses. They shed HSV, they shed CMV, they shed EBV, they also shed VZV. So really, qualitative PCR is non-diagnostic, it doesn't really help you. But a biopsy with immunoperoxidase staining for early antigen of CMV is very sensitive, and you'll pick it up long before you pick up cytopathogenic effects of CMV. The problem with serology, both IgM and IgG for acute disease, for any herpes virus, it is perfectly useless. In fact, that's one of the first studies I did as a young man, because everybody was doing weekly serology for toxo, EBV, CMV, HSV, and all transplant patients. And we showed that it was completely and totally worthless. It did not correlate. Why these antibodies go up, both IgM and IgG, in all of these ill people is something that we don't understand, but they do. But they don't correlate with disease. So I think this is key. The other thing that I would also say, just as a remarks about, in general, management of all of these patients that we put on immunosuppressive therapy, I think that clearly net immunosuppression is far more important than specifically what agent you put them on. And it's a net immunosuppression that is the highest risk for reactivation. And once you reactivate CMV, you can reactivate a lot of other things. In India, you should be careful about tuberculosis, because what we have seen is you think that they are getting reactivation tuberculosis, but very often what we have found is that they actually have primary infection from an index case that they were exposed to at home. And it's the immunosuppression that leads to rapid primary progressive tuberculosis with devastating effects. So both are possible. So even if you have treated somebody for latent tuberculosis, you still should worry about the possibility of a superimposed reinfection, and sometimes with drug-resistant TB that we are seeing in India increasingly.
Thank you for the excellent comments. The risk of fungal infection is not as high as the bacterial or the mycobacterial infections, but Candida is the most common in patients with IBD, and in patients with NTTNF, histoplasmosis infection has a higher risk. Candida aspergillosis is not as common, but invasive pulmonary aspergillosis can occur as discussed by Dr. Vijay in patients who are immunocompromised or who have net immunosuppression. And this is the progression of the pulmonary nodules in patients with aspergillosis, where it should make you suspect. And in our patient, this was the picture, so this was plus minus for aspergillosis. But if we go by the diagnostic criteria, Then the probable aspergillosis is diagnosed in a predisposed host. Our host was predisposed with clinical criteria. He had some matching clinical criteria, and when we did his sputum workup, then his the sputum was positive for septate hyphae on the KOH mount, and the culture revealed Aspergillus fumigatus. Although gene expert was negative, bacterial culture was negative, and his serum galactomannan was negative. So based upon this, we had enough evidence to label and treat as probable invasive aspergillosis. So he was started on voriconazole, and his anti-tubercular therapy was continued. So his leukopenia improved, but on day 7 of ATT, his miseries worsened. He developed seizures, required mechanical ventilation. His CSF was done, which revealed high protein, but the infection workup was negative. And this was his MRI picture, which showed multiple ring enhancing lesions in the right occipital lobe, frontal lobe with heterogeneous enhancement and microhemorrhages. So Dr. Monalisa, what would be your differences now? Chest infection plus brain lesions.
This patient has conglomerate brain lesions with the mass effect, and so this could be a case of tuberculomas, tubercular brain abscesses in this scenario. Also, as the fungus has already been detected in the lung, it could be a case of fungal brain abscess with the aspergillus or even the cryptococcosis, which not be in this case. Even in case of bacteremias, it can be there. The septic emboli can get lodged in the brain, and they cause this brain abscesses, mostly the anaerobes and the staph aureus. Also, in our situations, we can get gram-negative as well. So nocardiosis can also be there. So these are the main DDs that we would have.
So we also considered tuberculosis and aspergillosis in our patient, and we continued both ATT and voriconazole. So patient improved, did not have any recurrence of seizure. He was extubated, and repeat NCCT had showed some stabilization of the disease, but his had another organ affected by the infection. His miseries further worsened, and he has developed blurring of vision on day 12. The fundus examination showed multiple hemorrhage and exudates as shown in the previous photograph. The ophthalmologist suggested it to be infective ophthalmitis. His vitreous biopsy was also done, which was negative for fungus, bacteria and TB. So our differential at that time were CMV, fungus and tuberculosis. We were already treating him for fungus and TB. So Dr. Vijay, could it still be CMV infection in the eye?
Absolutely. And just a comment about the CT findings, so the initial lesion that you showed that had a halo around it, please understand it is not specific for aspergillus. Any angioinvasive pathogen will give you the identical findings. So it can be aspergillus, it can be mucormycosis, it can be pseudoallergia, so a whole lot of things. All right. So, yeah, and yes, if you see an immunocompromised patient who has lung disease, okay, particularly an angioinvasive pathogen or nocardia, you should automatically look for brain lesions with an MR, and that is the most sensitive thing to do. And like I said, all along this man could have had CMV disease. In fact, the fundus looks like CMV because you have the flame hemorrhages, and a simple blood quantitative PCR for CMV would give you the diagnosis. So when you have aspergillus, the onus is on us to prove that there wasn't any CMV around.
Yeah, thank you. In the meantime, we also had a sigmoid colon biopsy, and it revealed a granuloma to further complicate the picture. So now my question to both the ID specialists. So what other infections should we as a gastroenterologist consider when we are confronted with a granuloma in such a scenario?
There are a lot of things that will cause a granuloma. The granuloma is very, very non-specific. Yeah. Okay, so in India, you should look for tuberculosis, but you should also look for bovine tuberculosis. All right, and once in a while we have seen atypical mycobacteria. Non-tuberculous mycobacteria also cause granulomas, but the pathogen that will cause disease from one end of the gastrointestinal tract to the other end in an immunocompromised patient is histoplasmosis. So histoplasma should have been something that should be excluded. All the other things that are causing granulomatous lesions in the gut are very, very, very uncommon. So if you have looked for mycobacteria, you have looked for histoplasma, and then once in a while we see granulomas for which we cannot find any pathogens. And this, I think you should send specimens to your excellent microbiology department who've got an Illumina platform to do unbiased amplification and shotgun sequencing.
Thank you. So now we treated the patient with voriconazole, with ATT, as well as we treated him with ganciclovir for 3 weeks. The patient improved. He is well on follow-up. Fortunately, his disease has not relapsed, and he also had a positive NUDTG15 gene, which could explain his severe thrombocytopenia. And we have explained, we have counseled him that if he develops a further flare, he'll be advised for colectomy and no more immunosuppression now. Yeah. So I'll end the case now because of the shortage of time, and thank you all my panelists for their excellent inputs and discussions. Thank you.
Thank you, Saurabh, for an excellent discussion. Now I request all the panelists to come onto the stage for receiving mementos. May I request one of the international faculty, Dr. Deepak Parakal, to hand over some mementos to our panelists and also the speaker. Sure. Please come.
So those who haven't downloaded the app for the quiz, there is an opportunity to do it now. I think there were about 50 people who downloaded the app till now.
Request all the people to scan this and
Yeah. Yeah. You can scan the QR code and you'll be directed to the Slido app, and you'll have to enter your name and then the questions will show up. March 45 seconds March. Yeah. Your last opportunity to scan it, please. To scan the QR code. I can see some people are having fun. There is an MS Dhoni as well. Well, if you do win the quiz, then who does the award go to? We might struggle to identify you. Do you enter your name, sir?
Request everyone to enter their original names because you'll be missing out a prize otherwise. So if MS Dhoni is announced, I might as well go and take the prize actually. So.
Just the last 30 seconds for people who haven't logged in. Vishnu sir mentioned attractive prizes. He didn't mention the word iPad, so I'm just adding to the interest. Two MSDs. You start with the first question.
So there are 15 questions, 60 seconds for each question, and you need to opt for the best possible answer. So now we will start with the quiz. What is the mechanism of action of vedolizumab, anti-IL-1223 monoclonal antibody, antibody to alpha-4 beta-7 integrin, antibody to P40 subunit of IL-1223, non-selective antibody to alpha-4 beta integrin?
We started with a difficult question just to check if how many of you were awake yesterday. It's a lot of time. This is a simple question, yeah. Is there a... Okay. We'll give the answers later. I think we are giving the answers right away. Okay. MSD is leading on the scoreboard. Right, so this is the next question. In differentiating Crohn's disease from intestinal cocks, which of the following feature is not in favor of Crohn's disease? I stress on the word not in favor of Crohn's disease. Low visceral fat to subcutaneous fat ratio on abdominal imaging, long segment bowel segment, involvement with discrete homogeneous subcentric lymph nodes, subcentimetric lymph nodes, patchy chronic active colitis on biopsy, and microgranulomas on biopsy. So 3 of these are features of Crohn's disease, 1 isn't. Which one is that? Yes, so the first one is the right answer. We didn't mean to do that. Huh. Oh, this is the third question? No, this is the fourth question. Third question, okay. So a 40-year-old female presented with recurrent abdominal pain for the last 6 months, and a colonoscopy showed ulcerative stricture at the IC junction. The biopsy of this ulcerative stricture showed the following. Identify the circled finding. I think there's supposed to be 4 options. One is foamy macrophages, second crypt branching, the third one is a microgranuloma, and the fourth one was non-necrotizing granuloma. So necrotizing granuloma and non-necrotizing granuloma. So we just have to identify the abnormality in the circle area. Can you go down? Can you show the 3 and 4 options, please? Yeah, 3 and 4. So the next question. A 17-year-old male with history of small bowel resection and anastomosis for obstruction now presents with recurrent pain abdomen and intermittent diarrhea for 2 years. What is the possible diagnosis, Montreal classification-wise, on MR enterography? I stress it's a 17-year-old male with this abnormality seen on MR enterography. In the center of the abdomen. Yeah, can we show the, sorry, can I read
A is A1B2, B A2B2, C A1B3, and D A2, B3.
Laser pointer. Pointer. Pointer కావాలి. So A1, B2, A2, B2, A2, B3, and A1, A2, B2. Yeah. So the next question: which of the following drugs are not considered as probably safe for IBD during breastfeeding? So not considered as probably safe. Azathioprine, infliximab, methotrexate, all of the above. This is breastfeeding, not pregnancy. Okay, sorry, that was a long 60 seconds. Question 6. Which of the following drugs are effective in axial arthritis associated with IBD? So spondyloarthritis and IBD, which are, what happened there? Question 6, yeah. Which are effective drugs in IBD arthritis? Steroids, methotrexate, anti-TNF, all of the above. Can we start the timer? I think we'll skip that question. So this is question 7. So this is an endoscopic picture of an ulcerative colitis patient. What is the Mayo endoscopic score? 0, 1, 2, or 3? This picture actually highlights the deficiency in the Mayo endoscopic score. Most of us have made the choice. Okay. Question number 8. Which of the following inflammatory bowel disease medications can cause reversible male infertility? So reversible male infertility, do we see that with tofacitinib, sulfasalazine, mesalamine, or infliximab? I can see some of the faculty are also enjoying the quiz, but I'm afraid we won't be giving you the prizes. We expect you to score 15 out of 15 there. Okay, most of us got it right. Next one, please. Next question. Question number 9. A 65-year-old male with ulcerative colitis and a history of 2 steroid courses presented with bloody diarrhea. Sigmoidoscopy showed diffuse loss of vascular pattern with multiple superficial and deep ulcers. Identify the circle finding. There's no circle, but it's right in the center. Choices, please. Cryptitis with cryptapsis is number 1, CMV inclusion body number 2, basal plasmacytosis is number 3, and number 4 is a granuloma. So it's rectal biopsies, histology. Option number 1. Scroll up. Is that number 1? Option number 1, option number 2. Okay. Question number 10. A 55-year-old male with ileocecal Crohn's disease presents for his 5th infliximab infusion. Within 30 minutes into the infusion, he develops chest tightness and dyspnea. He becomes hypotensive and tachycardic. The infusion is stopped and treated with antihistamine and methylprednisolone. Which of the following is most likely seen on testing? Elevated ANAs, elevated human anti-chimeric antibodies, positive interferon gamma release assay, and normal 6-TG levels. So it's the 5th infusion of infliximab. Okay. Question number 11. A 50-year-old female with colitis presents with recurrence of bloody stools and new onset painful skin lesions in the neck for the last 3 days. Lab shows neutrophil predominant leukocytosis. What is the most possible diagnosis? And there's a picture that is not displaying. Gopi, picture. Yes, yes, there's a delay, sir. It's loading. Actually, it's a male. Got it wrong. So it's a rash on the back of the neck. Is it herpes zoster, pyoderma gangrenosum? Sorry, the order was wrong. Sweet syndrome, erythema nodosum, herpes zoster, or pyoderma gangrenosum. Okay. We'll be revealing the answers later anyway. Question number 12. A 25-year-old woman who's 28 weeks pregnant with UC is seen in your clinic for follow-up. Her disease is in clinical remission. She's on infliximab therapy and plans to receive the last dose during pregnancy at week 33. Which of the following vaccines, one vaccine or vaccines, should be withheld in her baby during the first 6 months of life? Diphtheria, hepatitis B, pneumococcal vaccine, and BCG vaccine. 26-year-old female presented with recurrent abdominal pain for the last 6 months. CT abdomen was done. What is the most possible diagnosis? Can we show the cursor on the ileocecal thickening that we can see at the top left hand, and there is a lymph node down below. That's the lymph node, and there's a thickened ileum and cecal segment. So the choices are abdominal TB, Crohn's disease, vasculitis, and appendicitis. Okay, last but one question. 50-year-old male with Crohn's disease on azathioprine, asymptomatic, found to have anemia. Can we go back to question 14? Yeah. Asymptomatic, found to have anemia, underwent capsule endoscopy and had capsule retention in the mid-ileum even after 7 days with no symptoms. What is the next best line of treatment? This is where the capsule is stuck. You can see an image of the stricture. Do we just observe? Do we give steroids? Do we do enteroscopy assisted capsule retrieval, or do we proceed with surgery? We had a very extensive discussion on this very topic by Dr. Santosh yesterday and the surgeons. Sorry? Someone had a question? Last question. A 38-year-old male with Crohn's disease who had undergone 38-year-old male or female, sorry, we got it wrong, extensive small bowel resection due to obstruction in the past, presents with a 2-hour history of severe groin and right flank pain. CT-KUB shows a stone in the right ureter with no hydronephrosis. Which of the following is the most likely type of kidney stones? Is it magnesium ammonium phosphate stones, calcium phosphate stones, calcium oxalate stones, or cysteine stones? It's a patient with extensive small bowel resections due to Crohn's disease in the past, who are at risk of both gallstones and kidney stones. What sort of kidney stones do we expect? Good. Thank you very much. The answers and the prizes will be announced after lunch.
Thank you all for joining the quiz. May I request Team Director Dr. Shruti Sagar to start the next session.
Good afternoon, everyone. So I'll introduce you to the last session before lunch. This session is titled Complex Scenarios in IBD. As part of this, we have 4 talks that focus on difficult problems that we commonly face in clinical practice. So for this, I'd like to invite the chairpersons, Dr. Kishore Alapati, Dr. Peddavi Raju sir, Dr. Upendra Shava, Dr. Sunil Jangala, Dr. Y. Pavan Kumar Reddy, and Dr. Ishwar Cheganti to join us. As we're running short of time, I request the speakers to curtail their talks to around 12 minutes, and then we'll take questions at the end of the session. I request the chairpersons to invite the speakers on stage. Thank you.
Now, for the first topic is TB versus Crohn's. Where are we up to? I request Dr. Vishal Sharma to give his presentation.
Thank you, first of all, Dr. Kiran, for the kind invitation. The task that I have is over the next 15 minutes to talk about this diagnostic dilemma that we have very frequently encountering in our day-to-day clinical practice. So this is a paper from South Korea which talks about the rates of misdiagnosis. And this was a large subset in which they saw that 18% of patients with Crohn's disease were misdiagnosed as GI TB, and around 11% of intestinal TB were misdiagnosed as Crohn's disease. So are there consequences of a misdiagnosis? So there are a couple of series. You certainly don't want to treat GI TB with immunosuppression, steroids or infliximab, because that will result in dissemination, worsening of symptoms, and even an excessive need for surgery and mortality. On the other hand, is it okay to treat TB, Crohn's disease as TB, as we often do? So these are a couple of papers. The first one is from All India Institute of Medical Sciences, which had two propensity score matched groups. You have, both of these are Crohn's disease patients. One of them received ATT, the other did not. And you can see that over time, the number of patients who had a stricturing phenotype increased with the use of ATT. Not just this, there's a Chinese study. All of these patients initially had inflammatory Crohn's disease, and some of them were started on a latent TB prophylaxis. So this is just a single drug. But you can see that those who used ATT were more likely to transform into a stricturing phenotype as compared to those who did not receive antitubercular therapy. So obviously misdiagnosis can be costly either of the ways. So there are a lot of tests or clinical features that we can use to discriminate these two entities. Pain and intestinal obstruction occur in both of these, but a shorter duration of symptoms, pulmonary involvement, fever, and peritoneal involvement in form of ascites would suggest TB. On the other hand, chronic diarrhea, hematochezia, extra-intestinal manifestations, and perianal disease tend to favor Crohn's disease, but none of these is specific. Now, we have talked about IGRA in the setting of latent TB previously, but if we talk about differentiating active GI TB and Crohn's disease, it's a different scenario. So this systematic review tended to suggest that it's got a good sensitivity and a fairly good specificity, but in an Indian study, you can see that the sensitivity is as low as 40% and specificity just 75%. So I cannot be sure with a positive test that it is TB, and a negative test certainly does not emphatically rule out TB. So certainly we do not use this for a clinical discrimination. Now people tend to order anti-Saccharomyces cerevisiae antibody, and this systematic review does suggest that it's fairly specific. But if you look only at the Indian studies, you can see that the specificity seems to fall and the sensitivity is not very good. And certainly it's just like tossing a coin, and therefore again, this test is not of much benefit. Now endoscopic findings may have a role, and although we know that Crohn's also involves the ileocecal area, but a contiguous involvement and a ileocecal predominant involvement tends to favor TB. Skip lesions and the type of ulcers may suggest Crohn's disease. So these are all images from patients with GI TB. You could have transverse ulcers, ileocecal involvement, distortion of the cecum, and these are images from Crohn's disease. Some of these are F-THE, cobbler stoning. You have linear ulcers and serpiginous ulcers. But again, there is an overlap, and you may not have these classical findings in every patient. Now, this is a meta-analysis which talked about the computed tomographic findings, and you can see that necrotic lymph nodes are the only specific feature for GI TB. And ileocecal involvement tends to favor TB, and the findings which favor Crohn's disease are comb signs, skip lesions, long segment that is more than 3 centimeter involvement, a muralist stratification, but none of these is specific for Crohn's disease. So these are some of the imaging findings. You can see the ileocecal involvement. This is again TB, but with skip lesions, and then you have the necrotic lymph nodes, and we had one of these images in the quiz. And then you can have in Crohn's disease, so there's a stricture, you have enteroenteric, entrovesical fistulae hair, and you have this kind of an asymmetric involvement with the mesenteric side which is involved and a pseudosacculation forming, and then there is the comb sign. Now coming to histology, and then there are features which might favor tuberculosis, like in TB you are more likely to find granulomas. The granulomas are larger, they are more confluent. Microgranulomas or less frequency of granulomas tends to suggest Crohn's disease. Again, you have histiocytes lining the ulcer base that may suggest TB. So here you have larger granulomas, you have sometimes AFB positivity. This is GI TB. On the other hand, you have microgranulomas here, deep fissuring ulcers, changes in the crypt, chronic colitis, or even cryptitis may favor Crohn's disease. Now, the biggest problem here is with the microbiological tests. The problem is that we do not have very sensitive tests because GI TB is a paucibacillary condition. AFB positivity is as frequent as less than 5%. And if you look at culture positivity in clinical practice is actually around 20 to 30%. There is a slight increment if you use MJIT, which is also quicker and gives you a quicker diagnosis. And then the traditional TB PCR, which was IS6110 primer, had a sensitivity of 46% and a specificity of 95%. But it is also important that when you are thinking about TB versus Crohn's to also look at sites like the chest and lymph nodes, and sometimes you would be rewarded with a positive diagnosis. Now, this is a systematic review we did on GeneXpert, and you can see that this test, which has come out in a big way for pulmonary TB, it is positive in just 1 out of 4 intestinal tissue samples, although it has got a very good specificity. So what is the way forward here? So we have started looking at better molecular diagnostics, and all of these are actually data from our center. So TrueNat MTB Plus, which utilizes 2 primers. One is the NRDZ, and the other is IS6100, which are combined, and this apparently is performing better than GeneXpert. Now, multiplex PCR, which is an in-house PCR at our institution, and this uses 3 primers, it improves the sensitivity to almost 80%. Now, GeneXpert Ultra, we have just finished this study, and it seems to improve the sensitivity, as we know also from pulmonary TB and meningeal tuberculosis, but it comes at a cost of a worsening specificity. So although these new molecular diagnostic techniques are seemingly improving the sensitivity, but they do seem to come at a loss of some specificity. So what is the preferred approach? You have a patient, you are thinking this is TB or Crohn's, and even after histology and the standard microbiological test, let's say you still don't have a solution. So what is the way forward from there? So if you are considering immunosuppression, I think that's a big no if you are even having a slight hunch that this could be TB in a setting like India. If you have a stricturing disease and a recurrent, let's say, intestinal obstruction, a severely symptomatic patient, surgery is a good option because that can sort out the symptoms and also give you adequate amount of tissue for diagnosis. But when that's not the scenario, we usually go ahead with antitubercular therapy. And I'll discuss slightly in detail this elegant study, which came from All India Institute, which took patients where there was a diagnostic confusion between TB and Crohn's. And what they did, they started everybody on antitubercular therapy. And there are very important messages from this study. So just look at the clinical response rate. At 2 months, 1/3 of the patients, even with Crohn's disease, have a clinical response. And at 6 months, almost the same number, in fact, a slightly higher number of Crohn's disease have a clinical response to ATT. So which means that merely looking for subjective features, clinical responses is not ideal. And therefore, what you should look at is endoscopic healing of the ulcers. And you can see the stark difference here. Almost 100% of those with TB have a mucosal healing, but only 5% with Crohn's disease have a mucosal healing. But we also know that if you end up giving such a prolonged duration of ATT, there are concerns which I already talked about. You're delaying the diagnosis, you're increasing the risk of stricturing phenotype, and you're going to deal with an aggressive Crohn's disease. So then, what we started looking at was doing colonoscopies at 2 months, and what we called was early mucosal response. And you can see that the healing does start happening as early as 2 months. And if you don't have a healing, either it's an alternative diagnosis like Crohn's disease, or very occasionally drug-resistant tuberculosis. So early colonoscopy might avoid, to some extent, the delays in diagnosis. Can colonoscopy be replaced? So these are a couple of our studies which looked at biomarkers, including fecal calprotectin and CRP, and you can see that a very clear decline in calprotectin at 2 months and 6 months in intestinal TB, but not in Crohn's disease. Again, CRP also seems to perform good, but not as well as calprotectin. Now, we talked about the ATT, but we did not talk about people who undergo surgery. Now, what typically happens is that there are strictures and people undergo surgery, and even after evaluation of that specimen, you're not very clear of the underlying diagnosis. And there is still a confusion whether this is TB and Crohn's, so people typically will give ATT, and the patient has responded, and you are fine with it, and you think it is all TB, let's forget it. So we recently reported, and this is ahead of print, with a small series of patients who were actually thought to have TB, operated upon, given ATT and forgotten. And then they landed sometimes years later with what were classical findings of postoperative Crohn's disease. Meaning thereby that the strategy now should actually be that when the diagnosis is not clear, we should offer a 6-monthly colonoscopy when you have operated for a diagnostic uncertainty. So what is in the future? So this is a model from Limsey-Valley, which was created after a lot of testing, not just testing, but created from a meta-analysis, a Bayesian meta-analysis, and then tested in an external population. And now it has also been compared with 4 other models, and apparently it seems to perform the best. And this is a model that which is publicly available, and we tend to use it whenever you want a kind of a probability or an estimate of what is the underlying risk. Now, people are also using artificial intelligence, and in fact, this is largely textual data, but I think we are also looking forward to image-based analysis of colonoscopy and radiological images to have a clearer, probability of the underlying diagnosis. And then a group from Ames has also shown that T regulatory cells, FOXP3 positive, at a particular cutoff seem to be fairly sensitive and specific for GITB, although they are difficult to do in routine clinics and also not validated from other centers as of now. So these are the things which we are looking forward to in the future. To conclude, in our setting, GITB versus Crohn's is an important clinical concern. A microbiological and a histological evaluation which is complete will yield a diagnosis in less than half of the patients. ATT first is a reasonable approach when there is a diagnostic confusion, and we must look for early mucosal responses. Biomarker-based responses are upcoming, and a follow-up colonoscopy is important in patients who undergo surgery for a diagnostic confusion. Thank you for your attention.
Thank you, Dr. Sharma. We'll take the questions probably at the end of the panel. Next up is Dr. Deepak Parakal, talk about perianal Crohn's and how to conquer it.
If you can get the slides up. Okay. All right. I guess I'm one of the speakers between you and lunch. So I'll try my best to be in the T20 mode and kind of make this fast. I think I'm also helped by the wonderful lecture from Sumit this morning in the case discussion. So there's a lot of repetition here, so might skip over a few slides since it's repetition. And there's lunch. So the topic is perianal Crohn's disease, how to conquer. So given how complex this topic is, I thought the best comparison here is trying to climb Mount Everest. Obviously, in full disclaimer, I have not climbed Mount Everest, but we will kind of see how this is similar to that. So outline, brief intro, diagnostic approach, look at current FDA-approved therapies for perianal Crohn's disease, brief look at future options, including some recent controversies in stem cell therapies, and then surgical approaches, very briefly again, has been discussed by the surgeons really well, so we'll shorten that. Perianal Crohn's disease at this point, this slide is, you've seen the cases. Up to a third of the patients with Crohn's disease will develop perianal fistula and/or abscesses at some point in their journey. If treated, recurrence rates are high because we still are not very good at treating them to fistula healing. Up to a fifth of the patients may require proctectomy, and again, these numbers vary depending on the series. And interestingly, about 1 in 5 patients will either have these symptoms as their initial symptom and have Crohn's disease in other parts of the bowel later on, or in a small subset, about 5% totally, this may be the only presenting symptom as isolated perianal Crohn's disease, something we don't still understand well, often a severe phenotype. Fistula categorization, I just have a slide up because these are terms which are often used, but just for the trainees in the audience, this is the Parkes classification which came out of St. Mark's, London, and this is named in terms of where the fistula starts and where does it go. So you have intersphincteric fistulas, which are between the sphincters, transsphincteric crossing the sphincters, suprasphincteric which goes above the sphincter, and then extrasphincteric completely bypassing it. And what's also interesting is that you do have very clear-cut anatomy that's visible in the MRI images which are down at the bottom to correspond with the cartoons above. So the diagnostic approach to perianal Crohn's disease again has been discussed widely in the morning session, but the main point to make here is this old study which is almost 23 years old, which shows that you have diagnostic modalities of endoscopic ultrasound, exam under anesthesia, as well as magnetic imaging fistula protocol. What's important is that this study showed that combining any two modalities, such as an endoscopic ultrasound or the MRI with the exam under anesthesia, probably is the best approach, improving the accuracy to 100% in that study. So the plea here is that not just to go with an exam under anesthesia, but also to complement this with an MRI or an endoscopic ultrasound as locally available. So the initial classification, again, I'll kind of go fast. This was all discussed in the morning. You figure out the fistula anatomy, look for proctitis, simple versus complex fistulas as shown here in the cartoon. Again, this is the AGA classification that Sumit discussed in the morning. To the left, you have the simple fistulas, which are low origin, non-branching, single external opening, and no abscess. And all the others are complex fistulas, or to the, sorry. My bad. Or to the, okay, or to the right. Classification, once you know that you have complex anatomy, cetons are recommended as discussed again in the morning, and non-cutting cetons for that matter. It is recommended in the classification that you place a ceton for local drainage before starting an anti-TNF. I would say that, again, some of this data are under evaluation and to be looked at again, because most of those studies are actually of poor quality. So what are the FDA-approved therapies? You have the anti-TNFs, infliximab to start with. I just show the data because, again, infliximab as Seb likes to call it, is still king of the hill, and it especially is the king of the hill when it comes to perianal Crohn's disease. This was a classic study done a really long time ago by Dan Present and others, which looked at a primary endpoint of a greater than 50% reduction in open fistulas. And you show here sort of the initial data at the end of induction, where you can pretty clearly see both for the 5 milligram per kilogram dose and the 10 milligram per kilogram dose that are in the orange and the red are superior to placebo that's in green. The data was good also for maintenance at week 54 as shown here, where the 5 milligrams per kilogram dose was continued. It's in red versus the placebo in green. We have data for adalimumab, although again it's not a randomized trial and was post hoc or pulled out from the trial data as shown here for the every other week data and the weekly data. So then this concept was brought up by Sumit in the morning, that the idea that you need higher infliximab trough levels for higher rates of perianal fistula healing. So this is the data from the first paper on this topic from Andres Yarur in 2017, and you can see here sort of going from left to right, you have the various quartiles of the infliximab levels, and then the outcome rates for perianal fistula healing is along the y-axis, and the data pretty much speaks for itself in terms of the rates of mucosal healing, fistula healing, and fistula closure as you go from left to right. More recently, a group from Australia showed the idea that this is not just fistula healing, but also correlating it with radiological outcomes. And this, I think, in a sense, it's a more objective study compared to the first study from Yarur. And they looked at radiological healing based on the Van Asch index value shown here and the idea of radiological remission. Again, the data pretty much speaks for itself, both on the left as well as on the right. When you look at active disease healing and remission, in terms of the primary endpoint of radiological healing, apologize, that's a typo, versus radiological remission on the left. So then this another study of importance is the idea of using antibiotics, and this was I think a point brought up by Seb in the morning, that this was a study published in 2014 that looked at patients who were started on adalimumab and were randomized to either ciprofloxacin 500 twice daily or placebo for a 12-week period. And then this is data looking at the placebo arm that's in blue, and then sort of the, I guess, a lighter shade of blue, which is ciprofloxacin. And you can see differences at around week 12, but not maintained out to week 24. So certainly in my practice, I definitely start patients on antibiotics for the first 12-week period based on data from this study. So then let's say you start the patient on anti-TNF, everything goes well, that's great. But let's say things start going wrong, you start having recurrence of disease, you try to optimize the anti-TNF. Some of this was discussed in the morning. If a ceton was not present, then place one, better drainage, reintroduce antibiotics, and if all goes well, that's great. But often it doesn't. So one does have to start thinking of second-line therapies. Were available, and I realized there may be limitations in certain resource-limited settings here. So we'll briefly look at sort of the second-line therapies and what's available. Ustekinumab is one of them. This is post-hoc analysis of the data from for ustekinumab specific to fistulizing perianal Crohn's disease. And data are drawn from Certify Unity 1 and Unity 2. And especially I would draw your attention to the dose at which we normally use, which is here, and certainly a trend towards significance. And this data from real world that it does work from the French cohort. Enterprise study was with vedolizumab, comparing vedolizumab to an extra dose at 10 weeks, and honestly there was no difference. This was a study that had trouble with recruitment, COVID times, not a lot of patients, low double-digit numbers. Certainly a suggestion that vedolizumab does work in selected patients. So there's certainly something you still could consider. Filgotinib, this is more recent data on filgotinib specific to fistulizing perianal Crohn's disease. The main takeaway from this for me was that for the endpoint of combined fistula response at week 24 and remission, there's certainly a dose effect where filgotinib at 200 milligram dose certainly performs well for fistulizing perianal Crohn's disease, more so than the 100 milligram dose. More to come on this, and we need more data from the real world to look at this. What about upadacitinib? This is post-hoc data, slide courtesy of Jean-Fred Colombel, and they did a post-hoc analysis of patients from the phase 3 trials, UEXCEED, UEXCEL, and UENDURE studies, and they looked at resolution of drainage and closure of external openings of the perianal fistula with once daily upadacitinib treatment. So the data here is the 12-week induction dose, and then the data is across here, and then you have like the, sorry, my pointer is bad, 52-week maintenance dose and the data here. So you can see that the 12-week induction data is certainly impressive for the 45 milligram dose. This gets a little more tempered once you look at the 52-week dose, and honestly not really a difference between the 15 milligram dose or the 30 milligram dose when it comes to the two endpoints they looked at. Again, it's a post-hoc analysis, so the study really wasn't empowered to look at this, but I think certainly another tool in the armamentarium. So let's say you have a different kind of patient where the rectal inflammation has improved, but the patient continues to have drainage. Now this was the group of patients where the idea of stem cell therapies was being considered. So let's briefly look at this in the remaining time. I'll skip over this. So adipose-derived stem cells, it is postulated to work through several mechanisms, including impact on immune cells, angiogenesis, inflammation, and impact on cell proliferation. This was initial data from ADMIRE-CD where things looked good. The primary endpoint was combined remission, both clinical and MRI endpoints at week 24. And there was definitely appreciable deltas in the intent to treat population, going all the way across to the right to the per protocol population. And CX601 was what was called at that time, later on renamed as davastrocel. What's interesting here is the data stratified by what treatment they were on at the time of randomization. And you can see here that the biggest delta was actually in patients who were on no significant treatment at the time of randomization. And this kind of gets to some of the findings from ADMIRE-CD2. Now ADMIRE-CD was done in Europe, ADMIRE-CD2 was done in the United States, and again looked at a combined remission endpoint. But this time it failed to actually show any difference from placebo, as you can clearly see in the data. What could be the reasons? Couple of things. ADMIRE-CD2, if you look at it, that patients who were on no treatment of any sort at randomization was just 4% versus 21% in ADMIRE-CD. And as I showed you earlier, the best deltas were in those who were on no treatment. Additionally, all kinds of add-ons which increased doses of immunomodulators or monoclonal antibodies were allowed in ADMIRE-CD2. There's probably other reasons, but at least these kind of stand out for possible reasons. So what was the main really takeaway from the ADMIRE studies? I think one of the things was the high placebo response rates, and one of the key things they did during the study was closing the internal opening of the fistula and curating the tract. I think that's one of the things you can understand could potentially help these patients, and I think needs to be studied further, including the immunological effects of this. So just in the interest of time, I think I'll just skip over the surgery portion. Surgeons play a major role in terms of drainage, ceton removal, ceton placement. PISA 1 and 2 was covered in the morning, so I'll kind of skip over that. The one thing I'll show you is that PISA 2, this is where the ceton removal and the radiological response was shown. So the key thing to know here was there were very specific inclusion and exclusion criteria for the fistulas in PISA 2. So I would keep that in mind when you think of your own patient, that these were the kind of patients in PISA-2 who were specifically studied. So in a patient with active inflammation, probably not a patient, in the rectum is not a patient where the ceton should probably be removed. And some other findings such as if they have a stricture or more complex fistulas. So so the main takeaway, chronic ceton drainage to be reconsidered, especially in light of PISA 1 and 2, and think of surgical closure of fistulas. And to conclude, difficult to treat, infliximab still remains king of the hill in terms of perianal Crohn's disease. Stem cell therapies may offer a novel approach, but with a heavy emphasis and underline, we need to know more. So at this point, I think the way I think of it, in the Mount Everest climb, we are pretty much still at base camp in perianal Crohn's disease. So a lot more needs to be done. Hopefully, this talk in the future has some of those future things, including radiomics and other newer pathways. Thank you.
Thank you, Deepak. A slight change in the program in the interest of time. So I need 5 minutes. So we are going to announce the quiz prizes. Then after that, people who are going to have the hands-on training at Somajiguda, they can all have quick lunch and then head to Somajiguda. Now, interesting results in the quiz, and I would like to ask both Dr. Sharda and Dr. Srikanth to join us on the stage. So I'm going to announce all the winners in the order, but we may have to disqualify the speakers, disqualify Yashoda group. So whoever comes next, they will be winning the prizes. But we acknowledge that you scored high. So the first prize, the highest score is tied between Deepak Parakal and Sumit Bhatia, but unfortunately both of you are disqualified. You are also a speaker. No. So next one is J. Kiran Kumar. Again, J. Kiran is Yashoda, so he is also disqualified. Fourth, Virat Kohli. Who is Virat Kohli? Okay, you have to prove yourself. We'll give you a bat. You have to prove yourself here. Okay? So, come over. So, you identify yourself. Give a mic. Okay.
Because final year Usmania Medical College.
Sorry?
Final year Usmania Medical College.
Okay.
So why did you become Virat Kohli?
I'm a big fan of him.
You're a big fan of Virat. Oh, great.
Okay. So stay there for a minute. So he scored 12 out of 14. Okay. Next is SK. Who is SK? Well, let them translate. SK, identify yourself on the stage.
Come here.
Both are Usmania. So you haven't got the paper before this, right? So next one is Vishal Sharma. Again, unfortunately disqualified. Vishal. Where is Vishal? He left. Is it? Thanks for scoring, but we can't give you a prize. Next is again Vishwanath Reddy from Yashoda. Who is Vishwanath? So, congratulations. So now next is Ram. Who is Ram? No full name. Okay. Oh, he's also Usmania, is it? Yashoda. Oh, Yashoda second. That's fine. But he's a resident. He's not a consultant. So that's fine. Okay. So. First prize goes to Virat Kohli. This is the first prize. So I request Dr. Vishnu sir on behalf of Yashoda Group to give prizes. First is to Virat Kohli.
The second prize goes to Suraj, who's also a trainee from Osmania. And the third prize goes to Ram, who's a trainee from Yashoda Hospitals, Hyderabad.
Yeah, we'll continue.
The faculty and the delegates for the participants of the IUS workshop can leave now for lunch. Thanks.
The rest can stay back for the rest of the session.
So you can introduce the next speaker, actually.
Okay, sir. The next topic is very early onset IBD, what a gastroenterologist needs to know. So Dr. Arul from CMC Vellore will be talking on this topic. I request Dr. Arul to take over the mic.
Good morning, everyone. I am a pediatric gastroenterologist, and the topic given to me was a very early onset IBD. Thank you, Dr. Kiran and Yashoda team for giving this opportunity. I'm going to talk about very early onset IBD. Let me start with some case scenarios, and then I will talk about very early onset IBD. So starting with the case scenario, it's an 8-year-old boy who has come with history of recurrent loose stools with blood and mucus for 2 years duration. At 6 years of age, he had fistula in ano, which he underwent fistulectomy. And at his hometown, he has been evaluated and diagnosed to have Crohn's disease, treated with steroids, no response, multiple courses of steroids has been given, tried azathioprine and received 8 doses of adalimumab. So by the time we admitted, the child was quite sick, malnourished, noted to have ascites and perianal ulceration and fistulas. And you can see from the evaluation, his inflammatory markers were very high, and his proctosigmoidoscopy and histopathology suggestive of moderate to severe activity of the disease. And his immunodeficiency workup was negative, and he was again treated with steroids, methotrexate. TPN was given for malnutrition. He was noted to have severe dilated cardiomyopathy, probably secondary to the chronic illness, or maybe related to the treatment also. By the time his genetic test has come, which was suggestive of a XIAP deficiency, which is a X-linked lymphoproliferative syndrome 2. So it's an underlying monogenic IBD with the immunodeficiency. So he was referred for stem cell transplant. While awaiting for the stem cell transplant, he developed the complication HLH and he expired. So coming to the scenario 2, it's a very young infant, 2-month-old infant. He was firstborn to non-consanguineous parents, and he was noted to have eczema from 2 weeks of life, recurrent perianal abscess from 3 weeks of life. He has other infections also like ear discharge, umbilical discharge, recurrent loose stools with blood and mucus. What else to suspect? What else needed to suspect primary immunodeficiency? So NGS was sent. There was a perianal small pustule with perianal erythema, and his investigation again immunological workup was negative. However, fecal calprotectin was high. His colonoscopy showed a small aphthous ulcers over the colon, and also histopath was suggestive of chronic active colitis. His genetic investigation has come as homozygous mutation for interleukin 10 RA deficiency, again a monogenic form of IBD with underlying immunodeficiency. So he was referred for a stem cell transplant as a curative option. In the interim, he was treated with antibiotics, mesalamine. He needed steroids and azathioprine also to control his inflammation. Father was a match, and he has underwent stem cell transplant successfully. 12 months, now 1 year to post-transplant, he is on follow-up. Azathioprine was stopped successfully immediately post-BMT, and he is doing well, development normally. So what is special about these two children with IBD? It's a very early onset IBD with underlying monogenic etiology. The first child presented diagnosed late and succumbed to the illness and complications. However, the second infant diagnosed early and got the chance to got a bone marrow transplant as a curative option. So coming to very early onset IBD, when the onset is before 6 years of age, we call it as very early onset IBD. There is always a genetic or a immunological abnormalities that may be closely related to very early onset IBD. I skipped this slide, and epidemiology also I skip. Sorry for that. And what is the difference between very early onset IBD and the older onset IBD? Predominantly, very early onset IBD is predominantly colonic involvement and extensive disease at presentation, and classifying them into ulcerative colitis or Crohn's disease is difficult. Always there is a overlapping of these findings, and there may be a strong family history, and in older onset it's more of polygenic, but in younger onset it can be a monogenic disorders. And moreover, there is a response to the conventional treatment is very poor in very early onset IBDs. So all these very early onset IBDs or monogenic IBDs can fall into these six main types of inborn errors of immunity. Earlier it was labeled as PID, but the new term is inborn error of immunity, IEI. So the epithelial barrier dysfunction, interleukin 10 signaling defects, T regulatory cell defects, neutrophil or phagocyte dysfunction, either combined or isolated T or B cell defects, and hyperinflammatory disorders. This picture looks a little complicated, but this is not that complicated. This is a module to identify the key regulators of the this immunodeficiency, where the center, that is the center circle, says what all the cells involved, like T cells, B cells, and what are the cells involved, and the middle circle says what is the function that is defective, and the outer circle says what is the gene involved. So this is the table form of the previous picture. Having said that, like we are talking about, like we know there is a autoimmunity and immunodeficiency that can be associated. How clinically we can identify these syndromes? There are a lot of things like the comorbidities, extraintestinal comorbidities, are the physical findings that can give us a clue that it could be point towards a monogenic type of IBD. Starting from hair to toe, there are a lot of clues that we can see from these children, like hair abnormality, dysmorphic features, and features of HLH, hepatosplenomegaly, and storage disorders. Very specifically, skin disease can be associated with monogenic disorders like eczema, ectodermal dysplasias, and blistering disease, all this. And we can look for other autoimmune disorders like arthritis, uveitis, oral ulcers, which can point towards a specific immunodeficiency. So coming to with this background, when to suspect monogenic IBD, somebody has formed a mnemonic for that, that is young age matters most. So what it says, like when the onset is very young age, when the multiple family history is there, autoimmune manifestations are there, failure to thrive, and conventional treatment fails, endocrine concerns, recurrent infections, severe perianal disease, macrophage activation syndrome, and atrechias or obstruction of the intestine, skin lesions, tumors, all this could any of these features could suggest monogenic form of IBD. Endoscopic finding, very early onset often presents as non-specific intestinal inflammation with overlap of both Crohn's disease and ulcerative colitis. And yesterday there was a discussion on the histological features. So this eosinophilic infiltrate, we may not see the classical picture of granuloma or the crypt abscess or cryptitis, but these features like eosinophilic infiltrates, villus atrophy, apoptosis, and pigmented macrophages and intraepithelial lymphocytes, all this can suggest there is a underlying primary immunodeficiency behind this. Say for example, apoptosis can be seen in IPEX syndrome and severe combined immunodeficiency. Pigmented macrophages can be seen in chronic granulomatous disease. So this is the approach to very early onset IBD. So nothing, like if it's like after we establish the diagnosis of IBD, the next step is go for a genetic testing. Before genetic testing, we have to do some functional confirmation, which is a simple test, lab test that we do routinely with CBC, with the immunoglobulin profile. We can see what type of immunodeficiency that we are dealing with. So once we know that, once we narrow down our immunodeficiency or the syndromic diagnosis, we can go for a genetic testing, either by a targeted clinical exome sequencing, or if you have a wide variety of differentials, then we can go for a whole exome sequencing or a whole genome sequencing. Coming to the treatment part, yes, methotrexate and thiopurine has been used as a monotherapy or as a dual therapy with biological agents. However, there is a poor response. In addition to that, there is a high risk of developing severe infections, HLH, and malignancy in these patients. So then what is the next step? Then comes the precision medicine. That is something like when we know the gene affected and we know the pathogenesis, then we can target the pathogenesis. So for example, interleukin-1 therapy such as anakinra can be used in chronic granulomatous disease where infliximab can lead to a lethal outcome because of infection. So this is an example of this picture says the example of precision medicine in monogenic IBD. I would take that first example as interleukin signaling defect. Interleukin signaling defect, what it says is like instead of treating the inflammation, just treat the underlying pathophysiology. So that is, we know that interleukin-10 is a hyperinflammatory disorder where the inflammation is robust. So we have to control the inflammation with the blocking the cascade. That is, by using the anakinra, we can block the inflammation. But however, eventually allogenic bone marrow transplant is the treatment of choice. There are other precision medicine that are available, and there are more and more precision medicine are under evaluation in the experimental stage. Stem cell transplant, yes, interleukin stem cell transplant is a curative therapy for some of the immunodeficiencies like interleukin-10 receptor defects and IPEX syndrome and chronic granulomatous disease and XAP deficiency. And having said that, not all the immunodeficiency will benefit by bone marrow transplant. There are epithelial barrier defect group of the immunodeficiency disorders which won't respond to even stem cell transplant also. Having said that, stem cell transplant carries its own other risk also like GVHD and severe infections. So summary of treatment, there is a precision medicine that is underway and that is on the pipeline. There are so many precision medicines are there. Stem cell transplant is the standard treatment. Some of the epithelial barrier defect may not improve with stem cell transplant. This one systematic review that I want to say because this includes nearly 750 children with monogenic IBD. Interestingly, again, IL-10RA and XAP are the most common gene involved. If you can see this picture where they found out nearly 11% of the children presented over 18 years of age. That is quite interesting, and nearly 76, that is 75% of them had extraintestinal comorbidities. They also studied the bowel surgery, biologicals and the stem cell transplant. What is the outcome of this treatment also they studied. Out of the 250 children who received biologicals, only 1/4 of them responded, remaining not responded. Among the stem cell transplant children, nearly 72% of them, the IBD has been improved. So why should we care about monogenic IBD? There is monogenic IBDs are associated with high morbidity and mortality, and there is specific treatment for specific etiology, and we can avoid unnecessary surgery and the other medical side effects, and genetic information can give us chance to give a genetic counseling and look for other extraintestinal manifestation of this disease. So in conclusion, children presenting with very early onset IBD can have a monogenic etiology, and awareness of these clinical features associated with that, comorbidities associated with that, is a key to diagnose early diagnosis for these children. And next generation sequencing will give us an idea about the genetic etiology behind this. And the treatment is still difficult. Yes, targeted therapies and hematopoietic stem cell transplantation stands the mainstay of treatment. The last point, if the patient is having extraintestinal comorbidities or shows a refractory response to the conventional therapy, then suspect monogenic IBD even if the child's age is more than 6 years. Thank you.
That's an in-depth, great presentation by Dr. Arul on a rare topic. And thank you, sir, for finishing within the time. And now invite Dr. S.K. Sinha for his discussion on IBD mimics in Indian context.
Thank you so much. And before I start, I would like to thank Dr. Kiran and the organizing team for giving me opportunity to be here. I'm going to talk about IBD mimics, and part of it has been covered already, mostly by Dr. Vishal and then subsequently in the previous talks. As we see lots of infection,
acute as well as chronic. In the chronic, the mycobacterium leads that can mimic IBD. Then there are localized inflammatory processes like segmental colitis associated with diverticular disease, endometriosis, vasculitis associated. Then iatrogenic causes like immune checkpoint inhibitors, NSAIDs, radiation injury, diversion colitis, all those. And then miscellaneous causes, we have VSAIDs, ischemic colitis, vasculitis, and then monogenic disorders. So the clinical, as a clinician, if we approach it from the site of involvement, that becomes a little easier. So this list shows that depending on the site of involvement, we can narrow down the possibilities. So because there is no gold standard for diagnosis of IBD, so this confusion will remain, and many times it will remain. Sometimes it may be inconsequential, which I am going to show you, but still it is important to make a distinction wherever is possible. So this is IBD statement. So it says the diagnosis of plasmacytosis favors over-infection, but that is not 100% foolproof, and granulomas are notoriously unreliable for the diagnosis of confirmation of diagnosis of IBD, because you see granulomas in variety of situation. The more investigation you add, possibly the more firm the diagnosis will be added. So what helps in the final diagnosis? If we take additional endoscopic biopsies, particularly for the vasculitis, the endoscopic biopsies are almost always negative, whereas surgical biopsies will give you resected specimen, the diagnosis of vasculitis. So if we take sometimes biopsies outside from GIT, like in sarcoid, so that will give us diagnosis. Then genetic testing for particularly monogenic disorders, that is the thing to look at. Then the deeper analysis of the patient history, and keeping our eyes open, always suspicious for the things. And lots of infection, I told you, that can mimic IBD at different stages of the disease, and these are some of the reports that chlamydia, nocardia, strongyloides, then Shigella toxin and acute severe colitis, EBV, and then some drugs like tacrolimus induced. And then there are certain other situations like this, you see dermatomyositis with particular antibody, and then there will be GI involvement. So all these are IBD mimics. Case report material, uncommon or uncommonly diagnosed, more uncommonly diagnosed than actually being uncommon. So that should be remembered, that usual diagnostic tool will be helpful, like PCR can be helpful and many times. But in addition to all those conditions, sometimes what happens that actually in post-operative situations, some of the surgical complications can actually mimic IBD. So what was labeled as pouch Crohn's disease is actually half of it, if you see the study, the half of it was actually surgical complication like fistula and all. So that always should be remembered, that okay, all these can mimic at different points of time. Dr. Vishal has covered it so well. Still, I will like to highlight few points on TB versus Crohn's, which is the leading mimicker, IBD mimic. So we see that over the years, earlier misdiagnosis was much more common, but we have seen that over the years it has come down clearly. And for distinction, there is no gold standard test, and for the either TB or for Crohn's disease, particularly for Crohn's disease. So that problem persists, and this problem persists because the phenotypically the two diseases has a gross overlap between the two. So the antibody, Dr. Vishal already talked that ASCA is not useful. The combination of ASCA and ANCA, that is also not useful individually as well as together. So that will not help in distinction. So that has been shown clearly in meta-analysis also. The similarly IGRA or IGRA with MAN2 test, TST, that helps in a small percentage of cases, but in large percentage of the cases it may not be useful. PCR, the problem of PCR, particularly real-time single primer PCR, is sensitivity is too low, and spasticity may be high. So in particular situation, if you are good, you are fortunate enough to get positivity, then you can believe that this is TB. But when it turns out to be negative, which will be more common, then there will be problem. But at our center, we routinely are using multiplex PCR, which I strongly believe that that is possibly a way forward compared to single primer PCR, and that has a better sensitivity, specificity almost comparable or slightly better. So sensitivity is the thing which we wanted, that we are getting with multiplex PCR. So if you see that single primer PCR, where is only 47% or maybe even lower sensitivity, the multiplex PCR you get 75 to 90% positivity. So that solves part of the issue. Histological features, if you are able to find cageation in the granulomas or AFB positivity, that clinches the diagnosis of TB. But not finding that doesn't make it Crohn's, or it still can be TB. So positive diagnosis is possible, but exclusion is not possible. Although people have talked lots of features like confluent granuloma, small granuloma, large granuloma, but in given individual cases it is very difficult to apply. One paper, this is immunohistochemistry, has been used for staining using different parameters, and that has shown good sensitivity. And this is a study from Hyderabad only. So this is granulomas of intestinal tuberculosis and Crohn's can be differentiated using CD73 cell surface marker expression. Unfortunately, this paper appeared quite promising, but subsequently there has been not much of follow-up information on this. So this is the summary slide, which is widely quoted. So you use the clinical, radiological, endoscopic and histological parameters to make a reasonable distinction between TB and Crohn's. No single parameter will be foolproof. So this is the ECO table, and even in the ECO 22 guideline, if you see that it talks about the empirical ATT as a diagnosis towards the TB or Crohn's. So the mimic is to the root level, so it can be extremely difficult. Ultimately, we have to go for antitubercular therapy to make the distinction. So vasculitis are very close mimickers, and if mostly vasculitis will be diagnosed by systemic manifestation, extraintestinal manifestation, and they are not dominant or they are missed because of the casual or cursory examination, then this can be very, very serious. Like HSV, we always have rash. But if somebody has missed the rash because the person is fully covered by clothes, so then it is possible to make a mistake. So in that situation, almost 90% will be the GI involvement. Depending on the other situation, the positivity rate will be less than 5%. But that is not all. That there are certain varieties of vasculitis which are dominantly restricted to GIT, and that one particular variant, which is these pictures, you can imagine that this will closely mimic Crohn's disease. So there are certain biomarkers which help in suspecting vasculitis, although it will have to be confirmed by subsequent studies, and these are the eosinophilia, HbSAg or HCV positivity, cryoglobulin positivity, P-ANCA or C-ANCA positivity, that type of thing. So if those things are positive, we should always do extra workup, walk extra mile to look for that. What happens that many of these conditions are treated by the same drugs which are effective in IBD, so response will not rule out vasculitis. So this one particular form which closely mimics Crohn's disease, and we have our finger on multiple occasions. This is localized GI vasculitis. Here we take endoscopic biopsies, but endoscopic biopsies are almost always negative for vasculitis, and what will be positive is the resected specimen, which gives the diagnosis. And if you see manifestation, virtually these are everything can be seen in Crohn's disease, barring the overt GI bleed, which is little less common in Crohn's disease compared to this situation. So we had our patients where resected specimen showed. but important that these tend to respond to some extent by the immunomodulators or which we see, which we used to these patients. So for the diagnosis of vasculitis, as I already highlighted, the serological test, like you say, that will give you reasonable clue, but final diagnosis will come from the resected expression and histology. Basets can very closely remember, and this is actually a form of vasculitis. So certain tests are helpful, but ultimately it will come from the overall picture. Sarcoidosis, again, it can mimic, but diagnosis doesn't come from the local site, it comes from the extraintestinal site, particularly if we biopsy the lymph node or biopsy, take the imaging of chest, that is helpful, but the treatment of IBD, which we use corticosteroid and immunomodulators, that is effective in sarcoidosis. So drug industry are very important part. Only certain drugs can be diagnosed, certain drug toxicity can be diagnosed on the basis of imaging and histology, so that should be remembered. And notable among them, mycophenolate toxicity can be diagnosed on histology in certain percentage. Diaphragm-like injury, diaphragm-like lesions seen on imaging, that is classic of NSAID injury, but that is seen in only a small percentage of the patients. Otherwise, no microscopic or other features will distinguish. This has become a big problem now, and that is immune checkpoint inhibitors related adverse drug reactions, CTLA4 or PDL1 inhibitors. They are very notorious and they give rise to enterocolitis. The clinical picture will be very, very similar to Crohn's disease. So if combination is used, that risk is higher, but among them the ipilimumab and is the worst among them, and that is more likely to give to such effects. But fortunately, that misdiagnosis is not so risky, because the treatments which we use, like steroid or infliximab, that is effective in these situations also. So echo confirms the same, that there is no routine biomarker specific for immune checkpoint related enterocolitis. So another is monogenic inflammatory bowel disease, which last speaker has talked. There are different categories of category of this disease. 5 categories I have listed here, and many of the disorder can have overlap features of immunodeficiency. So these are the disorders which can be present in adults. There is another childhood variant which is more common, and what will happen that many of it is almost impossible to diagnose for want of next gen sequencing or whole exome sequencing, and they will be in the between diagnosis of either non-specific ileal ulcer, non-specific jejunal ulcer, or what we call now C-Muse, so that type of things. So that should be kept in mind. There are certain features which will make us suspect that. So the warning signs are young age of onset, refractoriness of conventional therapy, growth failure, multisystemic disease, recurrent childhood infection, and similar manifestations in first degree relative. So history will be very important if we are not going for next gen sequencing. So this is the way to diagnose these situations, and obviously the whole thing depends on the exome sequencing of that. So basically echo statements confirms the same. The vascular disorder, chronic ischemia, that can very closely mimic IBD, particularly Crohn's disease. There are certain features like hemosiderin accumulation, highlightation in lamina propria, and fibrosis in lamina propria. That is suggestive, and if it reported in histology, that should be suspected and worked up accordingly. Autoimmune enteropathy is rare condition, but can mimic IBD and radiation injury in I'm not talking of radiation proctitis, but radiation injury of the GIT, and that can very closely mimic. And occasionally hidradenitis suppurativa, that has also been listed as a mimicker of IBD. So there is no gold standard for diagnosis of IBD. However, a number of conditions mimic, so we should keep our eyes open. Many of those conditions respond to IBD treatment, so response should not be taken as a criteria for positive diagnosis for IBD, alternate diagnosis can emerge even in the course of the disease. Some IBD mimics can be diagnosed easily, while others will require sophisticated like exome sequencing. Suspecting is the key to the diagnosis, because unless we suspect, we will not go for further workup, and the tools which are available I have mentioned already. Thank you all.
It is a very good presentation, sir, and the session is open for discussion. Sir, I had a patient 2 years ago. One young fellow had come with blood mixed stools, fever, and very toxic guy. To me, he was looking like a acute episode of ulcerative colitis. He never had any symptoms regarding that. So I thought it is either acute infection, infective colitis versus IBD. And the investigations, everything was done which was showing inflammation, but there is no infection. Rectal biopsy also was showing some non-specific colitis. So I started him on steroids, IV steroids, oral steroids, and with covered antibiotics, including cyclosporin. But at the 7th day he died. What may be the possible thing that we could have done in that patient?
Very difficult.
What may be the probable diagnosis?
Which is very difficult to comment with this much of information. Obviously, death can happen even in acute onset IBD, which you are treating. Then certain percentage of patients will die, either de novo because of the basic condition, or even because of complications, or because of further infections acquired, or it can be, diagnosis can be something else, maybe infective conditions. So I will not like to comment with this much information, particularly the terminal events not being very clear, whether this was perforation, whether this was septic shock, hypotension, intractable bleed leading to those things. So difficult to comment, but the basic issue is that we should be open to additional diagnosis. And as I said, that even in this era of workup, even the guidelines, standard guidelines, like I showed you the multiple echo statements. So everywhere they say that treatment trial is valid, even at TB versus Crohn's, whereas in other situations also.
Dr. Sinha, 30 years back, there no Crohn's in India. So it is very comfortable for diagnose intestinal tuberculosis. Any patient with ileocolonic disease, if I blindly say it is intestinal tuberculosis, I used to be correct. Last 10 years, the problem is because the intestinal tuberculosis is waning, but it did not disappear, and Crohn's disease is on the rise. Maybe in the future, next 10 years, this problem will not be there because intestinal tuberculosis will disappear and Crohn's will be remaining. That's what I am hoping for.
Yeah, that is a rise and fall curve. Typically, possibly at this point of time, the crossing is happening. So possibly the decreasing tuberculosis is going below Crohn's disease, and after some time the Crohn's disease will be on top, and then TB will be at bottom. So that is changing time, changing epidemiology of the disease.
Sir, sometimes NSAID presents typical like ulcerative colitis, not the diaphragm types, but did you anytime come across this type of things?
Two things I will say. One is like diaphragm, which I said, that is the chronic injury of ulcerative colitis, chronic NSAID takers. That is not the acute situation. What you are talking of mostly related acute injury related to NSAID, which can be of two force. Like one patient can be actually having ulcerative colitis, and severity may not have been severe enough to bring the patient to physician or gastroenterologist. But if patient receives an NSAID, there is flare, and then the symptoms worsen, and you do endoscopy, sigmoidoscopy, then you see those changes, ulcerative colitis like changes. So both are possible. So one has to make distinction, and on the top of the list there is always infective colitis, which comes as a differential diagnosis.
Yeah, these were very few instances where we have followed up these patients. There wasn't any ulcerative colitis. It subsided with NSAID.
No, that is perfectly known. I told you that is perfectly possible, but there is additional point I am telling, that sometimes what happens that like in the forenoon when talk was being given for PSC, then it was mentioned that chronic smoldering IBD, which doesn't manifest by like over symptoms of GI bleed and bloody diarrhea, they tend to have present with PSC. And then the recommendation says, even the guideline says that if you have PSC, before saying this is not associated with IBD, do sigmoidoscopy and take biopsies even. So there can be situations. So it is always better to keep eyes open, but even even if there was no IBD, it is possible that NSAID can give rise to that IBD-like picture, because NSAID are listed cause for all this. So colitic type of picture, microscopic colitis-like picture, everything is possible with NSAID.
Yeah, we did re-challenge also these patients. Unfortunately, we had to re-challenge because of the requirement, but still it did not reoccur so much.
Okay.
Any queries? Close the session. Thank you all the speakers, and thank you all the chairpersons.
Thank you to all the speakers and chairpersons for an insightful session on some difficult topics. I now request Dr. Ravishankar sir to present mementos to our speakers. Dr. Vishal Sharma sir. Yeah. Dr. S.K. Sinha sir and Dr. Arul Premanand Leonel sir. I request Dr. Santosh Sheniganti sir to present mementos to our chairpersons. Dr. Kishore, Dr. Peddaviraju sir, Dr. Upendra Shava, Dr. Sunil Janagala, Dr. Pavan Kumar Reddy and Dr. Ishwar Cheganti.
I think everybody is feeling very hungry. Nobody is really applauding. But anyway, it was a wonderful session. So after this presentation, we'll break for lunch. We'll try to cut short the lunch. I think 20 minutes we'll keep for lunch. We'll assemble back here, and then we have 4 more talks for the next session. Instead of the 5 that are listed, we have only 4 talks. One speaker didn't come. So have a great lunch and then come back in 20 minutes. Thank you.
Welcome everyone to the post-lunch session. So extraintestinal manifestations, 1/4 of our IBD patients will be having extraintestinal manifestations involving the eyes, skin, lungs, joints and the liver. So to give more insights into the topic, so we have some excellent and exciting talks coming in from the experts. So I would like to invite the chairpersons for the session, Dr. Raghavendra Y, Dr. Ramanna Macharla, Dr. L. Rajendra Prasad, Dr. Arun Karyampudi. I request one of the chairpersons to introduce the next speaker, which is the next topic, that is cardiometabolic manifestations of IBD. And the speaker is Dr. Deepak Parakkal.
So, good afternoon. I welcome you all for the last session of this conclave. So, it's a post-lunch session. So, the topic is the extraintestinal manifestations in IBD. So, the topic given is the cardiometabolic manifestations of IBD. Sure. I request Dr. Deepak Parakkal to take the dash. So, Dr. Deepak Parakkal is a physician scientist in the IBD Center in Division of Gastroenterology, WSM, in St. Louis, Missouri, where he is an associate professor in medicine and director of clinical translation. Sir, the chair is yours.
Thank you, Chairperson. Thank you again for all those who are still here in the hopefully the last hour of this wonderful CME. So I'll hopefully be quick here and hopefully give you a few learning points in the process. So the topic I was given was cardiometabolic disease in IBD. I slightly modified it to syndrome because I think this covers a few different things rather than kind of a single disease. And I added the complications and implications just to how this fits in with how you treat the patient, how you see the patient, etc. So the outline of the talk, just very briefly on metabolic syndrome in IBD, metabolic dysfunction associated steatotic liver disease and cirrhosis in IBD. And I recognize the next speaker is actually speaking on liver disease in IBD. So hopefully not a huge amount of overlap, but some overlap. Atherosclerotic cardiovascular disease in IBD and implications for IBD management. Now I will do the disclaimer that since this is still sort of an emerging topic, so I'll show you some of the data. Some of this is hypothesized, and especially when it comes to sort of the management piece, because that's what's suggested, but again needs to be validated in future studies. So metabolic syndrome in IBD. And just to start with, just to align everybody, there's the Harmonized International Diabetes Federation criteria. We're meeting 3 or more of the following, including elevated waist circumference, triglycerides being high, high density lipoprotein C being low, systolic diastolic blood pressure being elevated or being on treatment, as well as fasting glucose levels being elevated or on drug treatment for diabetes mellitus. Any 3 of these or more meet criteria for metabolic syndrome. So this has been reported, and this I recognize is a busy slide and I don't expect anyone to read through it, but this was more to sort of show you that there have already been so many different studies looking at various aspects of the metabolic syndrome, mostly retrospective, some cross-sectional, some prospective, but mostly retrospective. And the studies have started all the way from 2006 going through the years till 2022. And these often have reported MASLD, the prevalence of it, also more recently hypertension, diabetes, and hyperlipidemia. And the rates vary depending on the country. Some places it's as high as the general population, some places it's lower. So the data is sort of all over the place in terms of whether it's truly higher or lower in IBD. So going to MASLD and cirrhosis, I've used the more recent term. Most of the studies were described with the old term of NAFLD, but since the term has been updated, so I updated the terms in my presentation. So this is one of the earliest appreciated extraintestinal manifestation shown in autopsy studies and intra-biopsy studies. The pool prevalence, especially from a systematic review that's listed on the slide by Mohammad Zamani and group, and also including Rohit Lumba as a senior author, showed pool prevalence of 30.7% in IBD, which is pretty significant. They also reported that the risk of MASLD was 2 times higher than healthy subjects or non-IBD controls. And there was a 2-fold elevation in mortality due to MASLD in IBD in this study by Meena Butra that published in Inflammatory Bowel Diseases in 2013. And studies have varied, but generally not shown a significant difference in Crohn's versus ulcerative colitis. So then we looked at this question using a more defined way of looking at it, which was really, we added on MR sequences that allowed us to calculate a MRI proton density fat fraction of 5% or higher, which is currently considered the gold standard short of doing a liver biopsy in MASH trials. And so we were able to compare the patients with Crohn's disease to non-Crohn's radiology controls. And then in yellow, you have the patients from the historical Dallas Heart study. But again, you have, oh, my bad. Sorry. Okay. Oops. Okay. Technical issues post-lunch. Thank you. So anyway, the message is that the prevalence is higher. But what's also significant is that even the patients with the BMI less than 25, or sort of what was previously known as the skinny NAFLD, or now the skinny MASLD, this is higher prevalence in Crohn's disease compared to the controls. So a problem that definitely is worthy of our time. Then we looked at clinically predicted fibrosis using the FIB4 score, and we defined an elevated FIB4 score of greater than 1.3, and then showed that clinically predicted fibrosis was higher in our Crohn's disease cohort compared to Dallas Heart study controls. Now, what's interesting is, and this was data we received from the Brooke Army Medical Center in San Antonio, Asian Institute of Gastroenterology right here in this city, and McGill University. So what's interesting here is that, and especially focusing on the AIG cohort, this was a resident from our institution who was actually hosted here for a month through a global health rotation by Dr. Banerjee, who was so kind to do that. And in addition, we also had 100 patients who were recruited through the clinic and had serial fibroscan, and using various CAP parameters or control attenuation parameters, cutoffs, you can see that the prevalence of steatosis is very similar to that in Canada at McGill, or even slightly higher, and this remains the case even with a higher cutoff. So it's a problem that exists even here in the patients based on this data. So then open questions of what are the risk factors in the IBD population, and if there is there any consequence to having MASL? Because this was a question asked of me that sure, there's fat in the liver, but how is it any different from patients with who are not having IBD, and is it the same? So then this is somewhat of a busy pathophysiology slide that we've tried to put together for an upcoming review, but essentially makes a point that there's multiple factors, and hopefully you'll enjoy the read once it comes out, including adipokines, adipose tissue dysregulation, including various cytokines elevated like TNF alpha, MCP1, alterations in the bile acid pathway, going clockwise, dysbiosis, as has been discussed yesterday, impact of the surgery itself, including on the ileal farnesoid receptor expression, and impacts on the GLP-1 pathway. We all know about the effects of total parenteral nutrition, certain medications, especially corticosteroids. There's certain shared pathways in terms of genetics between common MASLD and the IBD cohort. So this tries to encapsulate that, and again in the review we go through great detail, but we don't have time right now, so I've tried to summarize it with this figure. So then the next question was, does MASL matter? Is it any different? So we looked at this question using the Danish Health Registry in collaboration with Tina Jess at Predict Center. Using prospectively collected data, IBD patients matched to 1:10 to non-IBD persons, matched on sex, age, year of IBD diagnosis, and then where they were living in Denmark. So Kaplan-Meier curves here, initially comparing IBD versus non-IBD, it's pretty clear the curves are divergent, and the continuous line above is IBD, the dashed line below is controls. And then we also looked at Crohn's versus UC, and then Crohn's were matched to their Crohn's controls, UC to their UC controls. Again, you can see that the two subtypes lines are well above the controls below. And then what's interesting also was that the time in years from IBD diagnosis to the diagnosis of cirrhosis was actually not that long in the cohort. Median time was 6.3 years, varying from 3 to 10.7 in terms of the interquartile range. Then looking at sort of the hazard ratios for cirrhosis in this cohort, What's significant were for the IBD type, Crohn's being at a greater, showing higher hazards than UC. Also, younger patients who were diagnosed at 40 years or younger, having a higher hazard ratios for cirrhosis. And then there was a bit of a signal for year of cohort entry. So then we further looked at this in a sensitivity analysis, which also included liver-related death in addition to cirrhosis, and the data was pretty consistent here for the IBD type as well as the age group or year of diagnosis of IBD and younger patients being at greater risk. The signal for the year of cohort entry was no longer existent in the sensitivity analysis. So then looking at what were the potential diagnoses within the population, so this you have IBD on the right side and controls on the left. The Crohn's panel is on top, the UC panel is below. And you can see that in pink are the patients with presumed NAFLD. Again, the limitation I will say is that this was based on codes, but we also had liver biopsies on a subset of patients to validate some of our findings. And you'll see, and going in, I would say that our collaborator didn't really believe that in Denmark you'd have so much mast cell in the IBD population, but it was interesting that the data speaks for itself. So the summary of findings at the moment in the talk is mast cell is about twice as prevalent as it should be in IBD. Risk factors both metabolic and IBD specific. There's a twofold increase in risk of cirrhosis with Crohn's being at a higher risk than UC. And so next we'll slightly change gears to atherosclerotic cardiovascular disease. So real quick, there's a common definition of ASCVD that includes coronary artery disease and cerebrovascular disease. But then there's also a definition for acute arterial events that in addition to this includes peripheral arterial disease. So then what's the data here? This was a study from Rochester Epidemiology Project that clearly shows that there's an increased risk of acute myocardial infarction in patients with IBD, and the line continues to climb up over the years. And you can see up top the percentage of patients with new onset acute myocardial infarction within this cohort. Another study looked at the definition of acute arterial events from the French cohort of hospital discharge data, and they also showed about a 20% increase in standardized incidence ratio of acute arterial events of patients with IBD compared to non-IBD controls. And then next was a study we did using the UK Biobank data. Jacob yesterday talked about the UK Biobank data, amazing resource. Anyone can apply for it, and you can actually get protocols approved at a cost. So what we showed here was that about 5,000 IBD patients in the UK Biobank matched 1:4 to about 20,000 non-IBD controls, age and sex matched. We had a follow-up period of almost 12.4 years, which is again impressive in the UK Biobank. And it showed that there was a 19% increase risk of acute arterial events in the IBD group, with a shorter time to developing composite acute arterial events compared to the non-IBD group. Now what was even more striking was that when we looked at the premature acute arterial events, which is by definition of from the ACC-AHA, events happening in men under the age of 55 or women under the age of 65, this risk was even higher at 39% for premature acute arterial events in the IBD population compared to the non-IBD population. Again, with a shorter time to developing the composite premature acute arterial events. Next, looking at what are the predictors of these acute arterial events within the IBD cohort. Now, some of the usual stuff stood out, including male sex, hypertension, diabetes mellitus. What was interesting was this impact of disease severity and activity. Activity in this cohort was defined based on the high sensitivity CRP. And we could show there was a quartile effect of the highest versus the lowest quartile, and there was almost a 54% higher risk of acute arterial events in the highest quartile. So definitely disease activity linkage. And there may be an effect of treatment. Again, another study from the French cohort showing that anti-TNFs but not hyperurines were associated with a decreased risk of acute arterial events. More to come on this, I would say. I'll skip over this in the interest of time, but the pathogenesis in terms of acute gut microbial dysbiosis, the inflammatory cytokines, the hypercoagulable state, lipid changes and other proposed mechanisms including impact of diet, mast cell and smoking, and of course some of the genetic influences I showed before. So to summarize here, increased risk of incident coronary vascular disease in IBD, association with disease activity and traditional risk factors, and they may be improved by control of disease. So real quick final few slides. Think of cardiovascular disease, especially in terms of treatment. Here we have common use of tofacitinib. So I would say think in terms of the patient who's over the age of 65, has a strong family history of cardiovascular disease, personal risk factors, and again, kind of outside this talk, but there's increased risk of cardiovascular disease pretty commonly shown in the South Asian population. So something to think of with the tofacitinib use. S1P receptor modulators, again, just to keep in mind the conduction abnormalities and hypertension issues. I'll skip over this in the interest of time. So prevention, as the last few slides, think of risk factors, assess for them, treat them, and if it's abnormal, think of statins as required antiplatelet agents. All these are obviously done in collaboration with the cardiologist, not by the gastroenterologist. And so I'll just skip over this. We already talked about this. So the last slide, treatment of cardiometabolic phenotype of IBD, counsel about diet, because again, diet was discussed before, but a good diet is important, exercise, and stay tuned for some of these other factors such as GLP-1 analogs. There's interesting data presented at DDW for those who attended that it may even have an impact on the immune system. So that's something we and other groups are going to study shortly. So more to come on that. Thank you, chairpersons, for slightly going over the time limit. Thank you.
Questions will be at the end of the session. So the next topic.
That was a good talk by Dr. Deepak. So next I would like to invite Dr. Naveen Polarpu to deliver his talk on liver in inflammatory bowel disease.
Right. Good afternoon, everyone. I know it's a post-lunch session, but we'll try to quickly wrap up a few of the things which are commonly seen. In fact, the extraintestinal manifestations are quite common to see, and almost 50% of the IBD patients somehow have the extraintestinal manifestations. It could be joint-related issues, or it could be dermatological issues, or it could be liver, or as we discussed, cardiovascular as well. And out of them, at least 30% of the patients with IBD do have some abnormal LFTs. Of course, the good thing is most of them don't have any significant abnormalities, but you do see IBD patients, about 30% having abnormal LFTs. And up to 5% of them can develop chronic liver disease to an extent where they can have liver failures and including liver transplant. And the interesting part is both these diseases, liver diseases and the IBD, they are independent in their course and their presentations. It can happen at any time during the IBD, during the course of the inflammatory bowel disease. The liver disease can crop up. Also, similarly, in the other way around as well, it can happen in terms of not related to the severity of the disease as well. So I just summarized the main abnormalities in the liver disease on these 4 or 5 different categories. So as we know, IBD is an autoimmune condition, and obviously there will be a lot of correlation with the other autoimmune conditions, particularly affecting the liver. The primary one is the PSC, the primary sclerosing cholangitis, the autoimmune hepatitis, then you have the PBC, the primary biliary cholangitis, IgG4 cholangiopathy or the secondary cholangiopathies, and also the overlap syndromes. And also, as we know that IBD is an inflammatory condition, so it has got links with the pro-inflammatory conditions and can lead to portal vein thrombosis, pyogenic abscesses, granulomatous hepatitis, and also pleosis and Budd-Chiari syndrome. Metabolic causes, we already discussed some of them, the MAFLD and the MASLD. Along with this, we also have increased risk of cholelithiasis and also amyloidosis. So another important thing that we commonly see in our practice with the IBD patients is the interaction with the drugs, the drug-induced, particularly the thiopurines, the azathioprine, the 6-methylcaptopurine, and also the methotrexate. And we also touch on the viral reactivation, which is also a very important point in patients with IBD. Yeah, so if you look at all these conditions, some of them are common in ulcerative colitis, some of them are common in the Crohn's disease. As we pointed out here, in ulcerative colitis, you see more of primary sclerosing cholangitis. In fact, if you see primary sclerosing cholangitis, 80% of the times, most of the times it's actually UC. Only about 10% of them may present in Crohn's disease and 10% in indeterminate, but predominantly it is ulcerative colitis group that we see. And similarly, autoimmune hepatitis, overlap syndromes, PBC, all of them are more common in the ulcerative colitis group. If you look at Crohn's disease, more common are the inflammatory conditions and liver abscesses, cholelithiasis, hepatic amyloidosis, and the MAFLD. Of course, drugs are more common in both of these conditions. So let's talk about each individual condition, and one of the most important things is the primary sclerosing cholangitis. We all know it is a progressive and irreversible condition where it causes inflammatory, which leads to fibrosis of the bile ducts, which lead to multiple strictures in intrahepatic and extrahepatic regions. And as a consequence of this, it can lead to secondary biliary cirrhosis and also may require a transplant, and also having an increased risk of cholangiocarcinomas. So what is interesting is patients with IBD, if you have a patient with PSC, once you diagnose a patient with PSC, you should always do a colonoscopy, because 70% of the patients with PSC do have inflammatory bowel disease. Okay, so if you see a patient with PSC, you diagnose on the radiological imaging you find in a PSC, please make sure that we do a colonoscopy on this patient. Okay, and I'll also show in another slide how the IBD in PSC is different in terms of the course and the presentation compared to a patient who has non-PSC IBD. Okay. On the other hand, if you actually have UC and Crohn's disease, you have about 8% incidence of PSC in patients who've been diagnosed with the UC, and similarly with Crohn's about 3%. And PSC is more common in males at 30 to 40 years age group. And of course, they can present, most of them present as asymptomatic in initial stages, of course, and as they progress, they can give symptoms like cholangitis and the cholestasis picture. And as I said, all PSC patients should have a colonoscopy and also the biopsies. Now, I also say biopsies because a lot of these patients have milder disease, quiescent disease, which does not get picked up just on the macroscopic examination. We should always do a random biopsies for these patients who is suspecting, with a patient with PSC who is suspecting IBD. Okay. So compared to patients with the IBD in PSC presents differently. Okay, so if you look at the patients who have PSC with IBD, they have more of a milder disease. They have more of a quiescent disease, and most of them have pancolitis, unlike the other conditions where you can have left-sided colitis. Along with this, there is also a risk of having more of a right colon disease, and it's a milder disease and happens in a younger age group. And also the need of biologics is less, okay, compared to patients who actually have a non-PSC IBD, okay. So it's a milder disease, but don't get fooled by being it's a milder disease, because this condition of PSC have got a very high risk of malignancy. They have a high risk of developing dysplasias and malignancies. The colorectal cancers are very high in patients with PSC and IBD patients. So although, in fact, I remember a patient who actually came from Nigeria to us. He came in a very bad cholangitis, progressive disease. He had a PSC. So when we actually evaluated for a colonoscopy, he had a PSC, we had an IBD as well, pancolitis, predominantly the right colon, okay. So very, very important that any patient with PSC who's having IBD make sure that we do surveillance on a regular basis for them, because very high risk of malignancy. The etiology, of course, is multifactorial, which will not go in detail, genetic, environmental, and immunological factors. The antibodies that we check regularly, if you see P anchor is present in more than 65 to 88% of these population with PSC. However, they're not reliable, they're not diagnostic, and they don't have any prognostic value as well. So yes, of course, it may add to your diagnosis, but it is essentially not the prerequisite for the diagnosis. And the reason why they develop the PSC is that it thought to be the portal pyema, portal bacterium that happens, that goes through the portal system, and it causes constant inflammation to the bile duct, which leads to the inflammation in the bile duct. And it is also thought that this inflammation actually has a negative effect in terms of reducing the colitis. So if you have more inflammation in the bile duct, that causes innate immunity response that reduces the inflammation in the IBD. Okay, in the colon, I mean. So in other words, you have a lesser, milder disease in the colon whenever you have PSC, because the PSC has a controlling effect on the inflammation in the colon. Most of these patients are asymptomatic, but they can also present with cholestatic LFTs, as I said. In about 15% of patients with PSC, they can present just with acute cholangitis as a first presentation. Diagnosis, of course, MRCP is very helpful, and MRCP also is helpful in excluding other causes like cholangiocarcinoma. So in about 10% of the patients with PSC, the first presentation could be just as a cholangiocarcinoma. The sensitivity of the MRCP is about 86% and specificity of 94%. And please do not use ERCP as a modality for diagnose these patients with PSC. They're very high risk of developing cholangitis. One of the other new modalities which has been used is spyglass cholangioscopy. The advantage of spyglass cholangioscopy is you don't put any contrast or dye, so that you can visualize and you can actually take targeted biopsy. So this is cholangioscopy is been an emerging modality in terms of diagnosing patients with PSC. The role of biopsy is very minimal, particularly if you have a large duct PSC. The role of biopsy predominantly is if you have a small duct PSC. So we would not normally ask for a biopsy for these patients unless we are suspecting any unexplained cholestasis in a patient with IBD and there is no extrahepatic disease being picked up on the MRCP. So those are the patients where we actually ask for a biopsy. Now we know, as I said, it's a fibrotic obliterating condition. It progresses, and it is, as I said, it's a progressive and unavoidable condition. The mean time from diagnosis to death or liver transplant is about 27 to 22 years. Liver transplant survival rates with PSC is about 86% in 5 years and 70% at 10 years. The graft recurrence rate for PSC is about almost 25 to 30%. And the course of colitis post liver transplant can be variable, so that's why we need to monitor these patients on a regular basis. They have an increased risk of cholangiocarcinoma, as I said, less of a gallbladder cancer, and also of the HCC. The PSC has, we already discussed about it. They have increased concentration of bile acids in the proximal colon. That's the reason why we see more of the right colonic pathology. And there's a 20-fold increase in the colorectal cancers in patients with the PSC in a patient post-transplant. But however, we don't recommend any synchronous colectomy for these patients, for patients who actually have a PSC with IBD. The small duct PSC is not so common. We have a normal cholangiogram with a PSC with normal cholangiogram. After we need a biopsy, they do reasonably well. There is no increased risk of cholangiocarcinomas, but sometimes about 12 to 13% of patients can progress towards large duct PSC. IgG4 cholangiopathy or the secondary cholangiopathies, these are not common, but the important point I want to mention is if you do diagnose these patients, you can give treatment with the steroids because they are steroid responses. So we should not miss these patients with IgG4 cholangiopathy, so we can because the treatment modalities are different and they respond to the steroids. PBC is not common, and it's common linked in US in ulcerative colitis, but not so common. Okay, autoimmune hepatitis is seen about 16% of patients with the UC. They have a varied course both in IBD and the autoimmune hepatitis. They can have a severe disease in both these patients, both these conditions, and it can even lead to the liver transplant in some of these. Overlap syndromes are also common. Particularly PSC and autoimmune are more common in the ulcerative colitis group of patients. They affect the younger age, and they do have better prognosis compared to having PSC alone. Now coming to inflammatory conditions, there are Obviously, because of pro-inflammatory and hypercoagulable states, you have increased risk of developing portal vein thrombosis. There are several factors, as I mentioned here, increased platelet count, high fibrinogen, acquired factors like the surgery, immobilization, inflammation. They're all the risk factors for developing the portal vein thrombosis. This is something new which I came across, but here is about 8-fold increased risk in acute flares. And treatment obviously is anticoagulation. Granulomatous hepatitis is not so common. It is seen in Crohn's disease, but it's a very rare condition, mostly asymptomatic, benign, so we don't need to worry about. The only thing which you need to rule out is in a patient with granulomas, you want to rule out if there is any associated tuberculosis in these patients, and also sometimes malignancies can also mimic. So it's important that we exclude the differentials. Liver abscesses could be a complication, either more common and seen in Crohn's disease patients, either it could be an extrahepatic extension, intra-abdominal extensions into the liver, or it could be through the portal pyema, which can lead to the abscesses. Now, the management of all these is similar to what we normally do with an abscess or even with the portal vein thrombosis conditions. Now, cholelithiasis is also common more so in Crohn's disease, particularly in patients who actually had a ileal resections, or because obviously, it affects the intrahepatic circulation. Because intrahepatic circulation is been affected, you have increased bile acids which get stored into the gallbladder, and therefore the increased risk of gallbladder stones in these patients. But it is not advised to do a synchronous or prophylactic cholecystectomy for these patients, although there is increase. Now, metabolic cause, which already been discussed, the MAFLD, so I will not dwell on that part. Now, coming to drugs, which I'll take a couple of minutes because it's also an important part. The 5-ASA group of drugs can also cause abnormal LFTs, but they are very, very rare. As I mentioned here, it's 3.1 cases per million in mesalamine, and sulfasalazine is about 6 cases per million. So we don't normally worry about abnormal LFTs in patients who are starting on 5-ASA, but we do need to check them. Now, thiopurines is very important, the 6-mercaptopurine and the azathioprine. They can either be a dose independent, in other words, allergic reactions, which we normally see in the first 3 months, or it could be a dose dependent because of the myelotoxicity. Which can lead to the myelotoxicity. So the common presentations are the rash, fever, arthralgias, and the pancreatitis. And the hepatotoxicity can happen in both the as a dose dependent and dose independent. Now, I just wanted to point out one thing important here is we check for TPMT levels for the patients who we start on azathioprine. The reason we do that is if you have a high TPMT levels, it shunts it shunts to the 6-MMP or methyl mercaptopurine, which increase the risk of hepatotoxicity. So that's why you always check for the TPMT levels. Your therapeutic levels of the azathioprine will be based on the higher levels of TGNs. If you have higher TGNs, then you have a higher clinical efficacy, and also it has got increased risk of myelotoxicity with these patients. So monitoring with azathioprine. Once you start azathioprine, every week you should do for first 2 weeks, then after the fortnightly for next 2 weeks, and after that every 3 months. So methotrexate, I'll just take another 4 or 5 slides to be honest. So methotrexate again is another important drug which affects the which cause liver toxicity, and have increased risk in patients with alcohol, chronic viral hepatitis, and obesity. And you had to check once you start the methotrexate, you check every 2 weeks for first 2 months and every 2 to 3 monthly afterwards. Now, we thought of having a cumulative dose effect of methotrexate. So, we read in the textbooks before that if you have more than 1.5 grams of accumulation of the methotrexate, it is toxic to the liver, but that's not the case. There are enough studies now that we don't have to do any cumulative dose monitoring for these patients. And the role of biopsy is also very minimal because fibroscans have taken up has been a promising alternative for these patients. Biologics, they're very safe. Infliximab is the only one which has got some FDA box label saying it's having some concern because 70% of the patients with the infliximab can have abnormal LFTs, but otherwise rest of all the biologics are more or less safe, including the anti-integrins and anti-leukins and also the JAK2 inhibitors. Now, last but one slide, the reactivation of hepatitis B. It's very important because obviously you are giving a lot of immunosuppression to these patients, either through the steroids or azathioprine or even through the biologics. So it's very important we check for this hepatitis B status. In fact, as soon as you see a patient with IBD, I think we all should start them on vaccination program. So to vaccinate them because we never know when they will need actually these higher molecules, biologics, and etc. So if you have hepatitis positive patient, then obviously you start antiviral treatments 3 to 4 weeks before and continue for 12 months after the immunosuppression has been stopped. If you are surface antigen negative and have core antibody positive, which means you're occult positive, then you check the liver function test every 2-3 months. If you're negative, obviously vaccinate. And if you are HPSAG negative, core antibody negative, surface antibody positive, then you check and give the vaccination of the booster dose accordingly. So just to summarize, hepatobiliary diseases are quite frequent in liver disease, in IBD, almost to the tune of 50% of the patients, but thankfully they're not severe. One of the most common conditions which affects the liver is the PSC, so keep out for these things. Unexplained abnormal LFTs, particularly cholestasis, you need to definitely do a MRCP for these patients. And various pathological mechanisms which I actually showed earlier, and we should always have a stepwise approach as we discussed. And also, last but not the least, do not forget the other non-IBD causes, non-liver IBD causes of abnormal LFTs. Okay, not just the PSC or the PBC. Look at the common things. The common things are common first. So also exclude those things before you label as the IBD, the liver in IBD gamut of those diseases. So thank you very much. Take questions at the end?
At the end of the session. That's a great talk, extensively covering all aspects. I would like to invite Dr. Girdhar, H4D, Department of Gastroenterology, KGH Vizag, to give the talk on pregnancy and IBD.
Good afternoon, everybody. I would like to thank Dr. Kiran and Yashoda team for a wonderful conference. My topic is IBD and pregnancy, and I'll just briefly go through all the important systemic reviews available in the last 2 years and what can we do the best. The first slide itself shows in pregnancy, still IBD we can always do the best for the patient. Remember, the main issues in fertility and pregnancy can be discussed under these headings. One is fertility, and then IBD effect on pregnancy, pregnancy effect on IBD, the drugs that are used in IBD, in lactation, and what about the non-birthing parent. So a brief introduction about the global prevalence. We know that it's on the rise even in the developing nations and like India, but the curve is slow. And remember, these patients are all most of them belong to the reproductive age groups, especially from 30 to 40 years, especially the South Asian countries. So we need to deal with these patients, the pregnancy and everything are all about conception always. And India, we know that in the last 2 decades, the prevalence always reached 1.4 billion. We crossed more than the US population of IBD. And unlike the Western mode, we don't have any bimodal distribution. So remember that we deal in the near future with more of this reproductive age group patients. So first, what about the preconception? Those patients who come to us who wants to have pregnancy, and there are so much of knowledge gaps are there even in the West. So the patients tend to have pregnancy avoidance, they involuntarily say no to the child, and there is inappropriate changes in their own medications. So the best part is we need to counsel and educate them. So this period of preconception is very important in IBD. So it helps them in management of good medications, and tell them we should have very good physical activity. We should assess the nutrition, assessment and planning before the pregnancy itself. Tell them to avoid tobacco, cannabis or alcohol which have a detrimental effect on the pregnancy, and also tell them about the drugs and fatal outcomes. So there has been a study in the West, like a single in-person intervention, a proper interview with the patient, tell them about the IBD. There is definitely an improved clinical outcome and emotional well-being, and almost 50% improvement in their knowledge. And there has been a study in UK and US in the last year. They found that even the IBD healthcare workers are inconsistent in applying this knowledge about IBD and giving to the patients. So what they did is they developed some digital tools like the AGA IBD Parenthood Project and the Pregnancy in IBD Decision Aid. See, these two are digital tools which can be used by the patients themselves. So what is the knowledge gap? when they did the survey, that is a CCP no question survey, they found that only 31% of the patients had a proper knowledge about their IBD, and 33% of females and 15% of males are considered not having any children because of the knowledge gap, and 30% stopped or changed the medication on their own, that is, and 40% without any physician consultation. And what the survey did was, the patients wanted more information. Almost 60% need more information regarding IBD. So the knowledge is very important. So then first issue is fertility. Usually voluntary childlessness is seen in 14% in women when compared with 5% in general population. And involuntary infertility is around 14%. It is the same as those without IBD. Only exceptions are that those who are having perianal Crohn's, IPA surgery, active disease around periconception, and remember, those women who wants to conceive, they should be told that let us postpone the major surgery like IPAA, let's have a pregnancy and then go ahead. And regarding assisted fertility procedures, it's the same as in any general population. What about the men? Fertility of men is not much affected. Only those who are on sulfasalazine, sometimes they need to stop sulfasalazine for 6 months before they get their sperm check and then go for a assisted fertility procedure. Otherwise, men do not need any stoppage of drugs. And in some studies, it was shown that there is some amount of erectile dysfunction in those who undergone IPA surgeries. So when we counsel them, we have to tell them what is the heritable disease in this way, offspring. Remember, patients where there is history of family history in one person, there is chance of 14% for Crohn's disease, and in ulcerative colitis is 9%. And when 2 or more family members are affected, like first degree relatives, the chance is more, and if both parents are affected by IBD, it is up to 33%. So that is the importance of knowing the family history. And till now, we do not have any genetic testing say that this is the gene, if you have this, you can avoid this pregnancy. It's nothing like that, because there are so many chromosome loci found, more than 260, and we cannot really advise anything about the genetic testing in IBD. So let us see just before the periconception area. So the disease activity is very important. So those patients who have a good remission, their chance of getting a disease activity during pregnancy is around 38%. Those who are active during the periconception period, almost it is double, and those that are active in previous pregnancy, again the chance is 50% for them to get active disease in the present pregnancy. So what are the risks of having an active disease? These are all the risks. The low birth weight is around 3.8 pooled odds ratio. SGA, small for gestation age, is 1.5. Preterm is 2.4. There is early pregnancy loss, but it is less when compared with other risks. Preeclampsia can be seen up to 2.8, and stillbirth around 2.3. So the dictum is, it is better to maintain remission for at least 6 months before they think of conception. This is the best method. And use appropriate contraceptive methods for those in active disease to show that they cannot have any unplanned pregnancies. So now we come to pregnancy state. What do we do? What do we tell the patients? The best thing is nutrition. Take care of the iron, folic acid levels, and vitamin B12. The patients themselves can be checking these factors, and always see that the vitamin D levels are more than 20 international units per minute per ml. And remember, from the normal folic acid requirement, they need more supplementation, especially those who are on sulfasalazine. They need at least 2 milligrams more per day than the usual doses. And since the planning of the delivery is very important in these patients, more visits are needed in the third trimester. So let us see how we monitor the disease activity during the pregnancy period. One is clinical, because we have a lot of patients, sometimes we get confused whether these are symptoms of flare from the IBD or is it something unrelated to IBD. They can be having simple abdominal discomfort, constipation or hemorrhoid, which is unrelated to IBD. So symptoms will be very subtle. So we depend on biochemical parameters. The best are biochemical, especially the CRP and fecal calprotectin. These are the recommended biochemical parameters. Remember, hemoglobin, albumin, ESR, all these are not useful in pregnancy because they themselves are low. Hemoglobin and albumin are usually low in pregnancy. ESR can be rising in pregnancy, so they don't have any value. So in these patients, to monitor the disease activity, as told by Dr. In the morning session, intestinal ultrasound is the best. And what about the drug levels monitoring in pregnancy? Usually not recommended, because most of the drugs which we use for treatment of activity wise, they are safe. Only thiopurines, we need to do some amount of monitoring, where these 6-MT, as Dr. Naveen was telling, these 6-MT metabolites, they have an effect on the liver. They can mimic intrahepatic cholestasis in the 3rd trimester. So we have to be careful. So we have to monitor these thiopurine levels. And what are the other modalities to monitor this pregnancy? If required, to know the activity, endoscopy can be safely done, where we take a minimal time and sedation in the 2nd trimester. And CT usually is avoided. MRE and IUS are safe. And gadolinium contrast is usually avoided in these patients. And suppose we don't have the facility of IUS or MRI, CT still can be used if warranted. It has to be, the radiation should be less than 50 milligauss. And for capsule endoscope, to determine whether in case of Crohn's activity, it is still contraindicated, because still the manufacturers are in doubt whether the electromagnetic waves that are given by the capsule are detrimental to the fetus. So we don't use capsule endoscopy. Now let us go to the medications during pregnancy and lactation. These are the drugs which have minimal risk: corticosteroids, mesalazines, thiopurines, TNF-alpha inhibitors. So when we go through this chart, usually most of the drugs which are commonly used are safe. We have limited data on cyclosporine, natalizumab, vedolizumab, and ustekinumab. Recent studies have come, some small studies are in the last 2 years. Those drugs usually which are contraindicated are the small molecules, rifaximin, thalidomide, and methotrexate. So just briefly about corticosteroids, there is an ongoing registry, Piano 1 and 2 registry in the US. Almost one study showed that almost 1,490 patients on corticosteroids, most of them it is associated with gestational diabetes, very mild association with preterm and low birth weight risks, and there is absolutely no association with congenital malformation. So that is the safety of corticosteroids. When we come to TNF-alpha inhibitors, there are n number of studies, but these are the 3 main studies. The one is a French study, which had total of around 5,000 patients. What they did is they continued 50% of the patients for 24 weeks with TNF-alpha inhibitors. After that, and one group discontinued them. Those who continued, they had minimal flares and there are no complications. So the thing is, TNF-alpha inhibitors are safe and should be continued throughout the pregnancy. And another study from Denmark, again they showed that we shouldn't discontinue TNF-alpha inhibitors, because discontinuation or de-escalation of these drugs resulted in more flares in these patients. So the dictum is TNF-alpha inhibitors should be continued in pregnancy to avoid flares and are safe. So this is the same thing with the various biological risks. What about thiopurines and pregnancy? The SNDS database from French, they almost had this thiopurine, 3,500 patients with thiopurine, 3,500 with DNF, combination 800 patients. What they found is only thiopurine usage was associated with preterm stillbirth to some extent, TNF no risks, and combined preterm births were there. So caution should be used in prescribing thiopurines, and allopurinol is not at all recommended. So what about other upcoming drugs? Vedolizumab and ustekinumab are safe, but data is limited, and some malformations are noted with vedolizumab up to 6% to 13% of children. And regarding small molecules, they are not recommended because they cross the placenta during organogenesis. What about in utero exposure and child infections? Absolutely safe because all the data show that there is very mild infections in childhood. So how do you manage flares in IBD? They are usually managed in as well as in a non-pregnant basis. All the drugs that are used for induction are safe. And if you want to consider using corticosteroids for a long term, better change them to budesonide because they have little lower side effects. And regarding acute severe ulcerative colitis management, the protocol is same, though we don't have any large data available. Last data. The delivery modes is the same thing. As in normal patients, we can go for vaginal delivery, except whenever there is a perianal involvement or any perianal surgeries are there. Lactation safe is for most of the IBD medications. So only thing is methotrexate, small molecules, allopurinol, cyclosporin and thalidomide are avoided in lactating mothers. The other issues like wound healing is good, nothing different from the normal population. Only thing is the vascular complications. We have to be discussing on case-to-case basis. Those who are active disease and very prone to vascular complications, there you can start prophylaxis. What about vaccinations? Remember, most of the vaccines can be given. Only live vaccines should be little postponed. It should be given after 6 months or 1 year if you are planning for a live vaccinations. Those who are on biologicals. Right. So the last thing is, what about the father, non-birthing parent? Fathers on IBD medication, do they have any risk? Yes, they don't have any risk because their infertility is not at all disturbed. They can continue with their normal medication. Only methotrexate has to be discontinued in the preconception area for non-birthing parent. So the final thing, what is the future? The fertility, pregnancy and childbirth are vital in one's life. People living in IBD should have a proper guidance from a multidisciplinary team regarding pregnancy and lactation based on latest recommendations. Regarding IBD medications and their safety, we have a lot of registries and studies. Piano registry from US, Piccolo registry from Australia and Dumbo studies from Spain. They are ongoing studies. The main thing is optimal nutrition care and mode of delivery has to be planned properly. And moreover, by giving this education, emotional support is very important for all these people in emergencies and flares. Thank you. Next, we invite you all for our IBD national meeting in Vizag in October. Thank you, sir.
Thank you, Girnath sir, for nice talk. Next presentation by Dr. Vishwanath Reddy sir, managing pouch behaving badly.
So meanwhile, we can take up some questions till Dr. Vishwanath Reddy sir is preparing his presentation. So I have a question to Dr. Deepak. So how do you manage dyslipidemias when patient is on JAK inhibitors? So can you hand over mic to Dr. Deepak?
Sorry, the question was
dyslipidemia on management of dyslipidemia while the patient is on JAK inhibitors.
So like someone whose lipids were normal and then went up.
So yeah.
Okay.
So to start with, they were normal, and when we start TOFA, and then we find that the lipids are getting deranged.
Yeah. I usually work with the patient's primary care physician in terms of recommendations to start a statin based on those lipid findings. I mean, because this question presumes that the patient, and again, this is a patient who has tried other therapies, they're on, let's say, tofacitinib for that reason. So if there's not a easy reason to switch over to some other therapy, and in most cases it's not. I mean, so I would continue the tofacitinib and manage the lipids, unless it's some, very dramatic elevation, but usually it's not that dramatic.
And another question, maybe you can take, or Dr. Naveen. So a patient on azathioprine, so we frequently find some mild LFT derangements. So on azathioprine, patient on azathioprine, we find some mild LFT derangements. For example, like SGOT-PT goes up less than 1.5 times. So how do you follow up these patients? How do you continue azathioprine dose modification, so on?
See, the abnormal LFTs with azathioprine can happen anytime during the course of the treatment, not necessarily during the first initial times. But if you see the idiosyncratic reactions or the drug dose, not dose independent rather, that happens in the first 3 months. So that's the reason why we monitor them very carefully initially. First, every 1 week for first 2 weeks, then after that fortnightly for next 2 weeks, 4 weeks, and then 3 monthly after that. But if the abnormal LFTs happen even after which are dose independent, then the two things we need to do. One is reduce the dose of it, okay, and then see. Very rarely we may have to stop the drug if the LFTs or transaminase are continue to go up. The other alternative which you can do is we can switch to a 6-mercaptopurine or even add allopurinol, because allopurinol will increase the levels of 6-mercaptopurine, which in turn will increase the levels of the 6-TGN, and it reduces shunting of the TPMT levels. So therefore, you can do either switch to 6-mercaptopurine or add the allopurinol. Most of the times we should be able to continue with the azathioprine. Very rarely may have to stop the drug.
We've published as a small paper is there are patients where definitely as a first step you check the metabolites. So if you find that the metabolites, the 6-MMPN is normal, but you're seeing this phenomenon, that's actually also a place where then you can think of, and if it's not already tested, look for mast in the patient. Because I've had a few patients like this with completely normal metabolites, where seemingly after they started on azathioprine, their LFT started going up. So some kind of a unique interaction there.
Thank you, sir. So I think over to Dr. Vishwanath Reddy for his presentation.
So good afternoon, everyone. Sorry for the technical issue. I'm the last man standing. I think it was a wonderful 2-day session. I congratulate Kiran sir and thank him once again for giving me the opportunity. To chairpersons and international and national faculty, it's a great privilege for me to talk in front of you. I will be speaking on managing pouches which behave badly. So as you all know, like around 10 to 25% of patients of ulcerative colitis ultimately land up in surgery over a period of time, and there are several types of pouches in them. J pouch is the most common one being preferred because of good successful outcome with these. And if you want a sphincter continence, probably K pouch, but S and W are less preferred nowadays. The problem with doing a pouch is like you will have some issues which we'll be discussing now. It's like a flame in the forest. So for the PGs, I'll just describe about the pouch. As you can see, the pouch in the center, you have the cuff, which is mainly the rectal cuff removed, that is mucosa removed rectal cuff, and you have the afferent limb and then the pouch, and then you have the pre-pouch ileum. So this is the symptomatic, I mean this figure of rectal cuff in the lower corner. You can see the anal sphincter and the sphenocolumnar junction here, and you have the J pouch blind end, that is the other limb of the pouch, and then the pre-pouch ileum on the right hand side. You have the oval eye shape appearance of the proper pouch body on endoscopy appearance. So the disease can involve any part of this pouch, but generally it's on this which we'll discuss next. So I'll be just presenting in this angle. Before that, I'll just go through a case. 39-year-old male diagnosed with moderate ulcerative colitis in 2015 without any extraintestinal manifestations or PSC, or he's not a smoker, and he was initially given 5-ASA and a steroid taper and multiple flares, which azathioprine was added along with the steroids in 2016, and later on we switched to biologicals, and then he had multiple relapses, so we thought of going for surgery in 2020, and ileal pouch anal anastomosis was done, and then he presented with diarrhea after a year later with multiple episodes, 15 stools a day with mucus, blood, tenesmus, and symptoms suggestive of pouchitis, and then there were more than 3 consecutive episodes within 6 months period requiring antibiotics, and on scopy there were erosions and ulcers and mucus exudates, and then we tried 1 month dose of antibiotics along with the high dose of probiotics. Budesonide was given, then mesocol suppository as well, and patient didn't respond well, so we also ruled out other etiologies which could worsen the pouch behavior like CMV, Clostridium difficile and associated Crohn's by doing a biopsy which didn't show any features suggestive. And then so coming to the discussion, the pouchitis is nothing but a non-specific inflammation of the ileal reservoir pouch created following the IPAA, and you can see that it's a magnitude which is very high, like 81% of the patients who underwent IPAA in IBD patients experience pouchitis at some point of time, like generally about 40% within the first year and about 72% in the 10 years. There is a recent publication in the AGG where they said where they did a long-term follow-up retrospectively from the registry, and they found that it was about 72% in 10 years follow-up study. So this is a very big problem in patients who undergo pouch, and acute pouchitis is where they have symptoms which are self-limiting or which require antibiotics but last duration of less than 4 weeks, and if they are the common symptoms of pouchitis are they have an increased stool frequency and diarrhea, urgency, incontinence and tenesmus, rectal bleeding, pelvic discomfort and lower abdominal pain or colic. Mind you, you'll have 1 to 8 stools in patients who undergo pouchitis. It's common for them. If you have more than 8 stools, only then you consider is abnormal. This has to be counseled to the patients before undergoing any surgery in these. So if you are thinking of controlling with preservation of the sphincter, you have this problem like overflow can still happen when there is like diarrhea in these patients, like you see in patients with smaller levels of dams. So there is again increased burden of these cases, and you have a spectrum of diseases. You have an acute thing, chronic, and then chronic antibiotic refractory, and then you have the Crohn's like behavior in these patients. So when do you do the pouchscopy? Generally, when if your patient is asymptomatic, you need not do it immediately. After 10 years for surveillance you can do, but if you have symptoms, probably you have to do a pouchoscopy. And then you have high risk features, probably you can do a pouchoscopy to just for surveillance. This is a normal pouch on the right hand side, you can see. And then if you have recurrent episodes of pouchitis, if you have inadequate response to antibiotics before considering of escalation of therapy, and if you have atypical symptoms of pouchitis and Crohn's like behavior, probably you should do a pouchoscopy and get it biopsy done. And this is a phenotypic thing, as I said, acute initially usually is antibiotic responsive, and acute relapsing course can be there, but they tend to respond to antibiotics most of the times. But some subset of patients go on to become chronic antibiotic refractory pouchitis, and then in these subset you have to do a study to evaluate and rule out any reversible causes like stopping NSAIDs and then Clostridium difficile and CMV other workups, and then there are many pathogenetic factors, but the dysbiosis and the dysregulated immunity are the key factors here. You can see pouchitis also in patients who don't have IBD, like in patients who undergo IBD for the APC, that is familial adenomatous polyposis, you still see about 6 to 10% of patients develop pouchitis, but they are generally responsive to medication. But in these patients of UC who undergo pouchitis, this pouch therapy and pouch surgery, they generally tend to have a higher incidence, as we discussed, the tune of 80% by the end of 10 years. So there is a lot of factors in causation of this disease, and probably we have to look at these factors and also generalize it to the IBD management as well, because we are removing the disease part of the intestine and the patient still gets the disease. There's something wrong in the bacterial flora or the genetic or the local intestinal factors. Then coming to the scoring system, there is a pouch disease activity index. We have 19 points, of which if there is more than 7, it is an active disease. You have a modified PDA index, and if is more than 4, it is active disease. This is on biopsy. You find loss of architecture, the blunting of crypts and crypt abscesses, and lymphocyte basal plasmacytosis as well. And then lot of lymphocytic infiltration and neutrophil infiltration and exudates as well. So this is a normal pouch, and this is a case with pouchitis. This again, one point which I wanted to discuss here is if you have an ulcer at the anastomotic margin, it is not pouchitis. You can see the scar, the scarred area, there is a small ulcer. It is not considered as pouchitis. If you develop ulcers on the other part of the pouch, only then you should consider it as pouchitis. Here you can see on the second image as well as in the third image, this is the afferent limb, and you have a pseudopolyp as well. And actually there is a Chicago classification of pouchitis, and the focal inflammation is what is almost 80% of the times, and then you have the inlet involvement most of the times, about 60%, and then afferent limb involvement, and then you have the diffuse inflammation. Later on you will have about 5 to 10% develop cuffitis, where there will be retained rectal cuff of mucosa as well as fistula formation in less than 10% of the patients. This is again a picture, endoscopic view, where you see a lot of pouchitis pictures, and you see fistulae also in the last part of the screen. So what are the risk factors? Patients who have a background extensive colitis, they are more likely to develop, and more so who have received anti-TNF alpha agents, they are also likely to develop. And so, and then those who have PSC, probably 7% of them, P-ANCA positive, genetic, rheumatological disease associated, that is, there is some immunological problem in these patients who undergo this procedure, so they are more likely to develop pouchitis. So we have to see these patients, probably counsel them in beforehand, and then probably proceed for the surgery in these cases, and do more vigorous monitoring by doing pouchoscopy. So then coming to the definitions, intermittent pouchitis are where you have infrequent episodes, and they respond well to antibiotics spontaneously also. Antibiotic responsive, they respond to short courses of antibiotics and less than 3 episodes per year. Chronic antibiotic dependent, they require repeated episodes of antibiotic use administration, and they may require maintenance or a cyclical rotation of antibiotics or advanced immunosuppressives. Chronic antibiotic refractory is where you don't have a satisfactory response to 4 weeks of antibiotic course. They require a immunosuppressive therapy most of the times. And there is about 10% of the patients have Crohn's like disease of the pouch. Again, they would require advanced immunosuppressive therapy most of the time. So monitoring, we do markers, fecal calprotectin again helps here, lactoferrin and CRP as well, MRI, pelvis, dynamic. It look at other factors as well, like strictures, also fistula and other things. Apart from the rest of the small bowel, if there is a Crohn's disease or an indeterminate colitis at this to start with. CCT again helps, and pouchogram again to look for stricture, and also deficogram to look for any functional defecation disorder associated in these patients. So you also have to rule out other causes of pouch dysfunction like infection, as I said, CMV and Clostridium difficile, ischemia, NSAIDs, and also we have to look at functional abnormalities, and also look at cuffitis, malignancy development in these patients, and these sepsis, pelvic abscesses, and functional disorders. So these are again the endoscopic pictures. You can see the first image was normal, second is severe proctitis. They again you can classify it as normal pouchitis, normal. Then you have mild to moderate, where you have only little bit of urgency and little increased frequency, but less or no incontinence or less or no bleeding. If you have severe, you have the bleeding and incontinence in these patients apart from increased stool frequency. The third one has a sinus, and the fourth one has a fistula. So you have to look at the other factors which are causing the patient's non-response to antibiotics. So most primary mainstay of these treatments is treatment of pouchitis is antibiotic. So the treatment is antibiotic ciprofloxacin or metroxyl alone, or you can give a combination of these two. You can also try sulfasalazine for 8 weeks. So most of them respond, but few of them go on to develop the chronic variant. And chronic, again, you have the other antibiotics as well, like vancomycin also. You can give probiotics in the first episode. To prevent the first episode, you can give probiotics in those high risk patients, which we discussed. And the secondary prophylaxis, you had a first episode of pouchitis, you can give in these high dose of VSL at 6 grams per day, and you also can give the other bacterial species. So the chronic antibiotic dependent pouchitis, more than 3 episodes, again you can try to do with antibiotics. And if rotation of antibiotics, the problem is the antimicrobial resistance, so you have to consider advanced immunosuppressive therapy if you are requiring multiple antibiotic administration. And then you have an earnest trial where you can give vedolizumab with more than 50% response in these patients, and very good response compared to placebo in these. And then you have anti-TNF agents. There are modest response in these subset of patients, but you can still try them. And then ustekinumab. These all probably will help in patients who have a behavior similar to Crohn's. Tacrolimus orally and enemas also tofacitinib. There is little evidence of this, and guidelines don't recommend these as of now, but they can be tried if they don't respond to one modality of treatment. So there are again other molecules, again experimental only. They don't have any very good evidence to give or recommend. So again, last few slides, you have the chronic antibiotic refractory pouchitis, where again you should think of advanced immunosuppressive therapies. Vedolizumab is having better evidence compared to the other biological agents. You have to do the endoscopy and biopsy to rule out a Crohn's-like disease in these patients, and cuphitis if you retain a little bit of rectal mucosa at the anastomotic margin. Pouch failure may require excision and end ileostomy. You have surveillance malignancy we have to look at in these patients, although there is less prevalence, but we have to look at these factors as well. The other thing, smoking probably helps UC patients, but we shouldn't recommend any smoking in these patients. The non-smokers, there is a higher risk of development of pouchitis in these subset of patients. We should stop NSAIDs. Diet, again we discussed yesterday at length, probably we can recommend some diets which may help in these patients. Probably soluble fiber should avoid if they have a reduced pouch compliance. We can do manometry to check for that. Prevention, not much evidence, but probiotics can be helpful because they are not harmful. Sulfasalazine have been tried, but immunomodulatory, azathioprine, there is no role. So if you have pouchitis, you have to rule out the other things which we saw, like CMV and Clostridium and NSAIDs. If it is an acute one, just give antibiotics. If it is a chronic one, again cyclical antibiotics if required, and steroids and upscaling to immunosuppressives later on. And then as it's a difficult disease to treat, I think you should counsel them beforehand, and I feel it's a difficult disease to treat, but there are no alternatives. We have to do a multidisciplinary approach, antibiotics, probiotics, and steroids, and then immunomodulators. Again, treat like an IBD, because the patient has some amount of immune dysregulation which we are not attending by just doing a colectomy in these cases. Lifestyle changes, and we need better molecules probably in this subset of patients. Thank you.
Yeah, thank you, Vishwanath. You have covered almost everything about the pouch. So if any questions, you please.
Sir, any comments, sir? Shaji sir and Deepak sir on pouch.
So, we started yesterday thinking about patients as the goal. So, do you think we counsel patients enough before proposing a pouch? And is there sort of mechanisms in place across the country in relation to giving them the real information? Because I don't see a taxi driver in Hyderabad actually having a pouch. Yeah. So I just wondered what is the setup, what is available? Does CCFA and other organizations have a role to include patients when, when they are coming up with guidelines. A lot of them are Western guidelines, so you need to think about developing something. I just wondered what your thoughts are in your local setting and also across the country.
So actually the experience with pouch is very little, sir. Actually, we most of the time manage with medical management. Most of the times patients refuse for surgery, and somehow changing of molecules, it works for them. Very few cases have undergone this pouch surgery, and yeah, it's difficult for them to accept that frequency of stools, like you're expecting about 8 times a day with this. I mean, it will hinder the quality of life anyway, so it's difficult to convince them to get it done. But I think as of now, there is nothing much from the CCFI, probably. Kiran sir, maybe.
CCFA tried to initiate the nurse education program a while ago. I don't know how far it is done. They had 2 set of educational activities, but very valid points. As Shaji said, the IBD nurses play a crucial role when it comes to counseling. Of course, we do counsel the medical part of it and all, but the ongoing counseling, the support mainly comes largely from IBD nurses. But that is lacking a big time in India. But I think CCFA is working on it. So hopefully in the next few years, there should be some IBD nurses we can see. As a patient load is increasing, that plays a great role, I think.
One question.
Sir, I have a question for you. Apart from the increased frequency and difficult to cope with the frequency of the stools, some will develop intractable perianal skin excoriation with sleeplessness, non-responding to analgesics. How do you address those group of people?
It's a good question. Actually, we come across that, and there is actually, we treat almost like the Wild West. We even give them, bile salt replacement. We obviously try and firm up the stools. A lot of it is down to, I would suspect, concentration of what is in the effluent, basically. But it's a really important, and it is actually more of a problem than we recognize, because patients who go for the pouch, quite often, they don't, just like we talk about failure of medical therapy, they don't want to then say, actually, my decision to have the pouch actually made my quality of life worse, because they consider that as a failure. So many of the time, they actually, hide that sort of particular symptoms which you are talking about. I've given bile salts and all that with, I would suspect, not great deal of evidence in that setting.
Anything to add to change the composition of the effluent, or any preference to the skin application creams?
Not really. I don't have much experience on it. As I said, I've done sometimes high doses of bile salt replacement, basically.
Yeah, sometimes even considering, acid-reducing agents to alter it. But I think local therapy, at least the way I got trained, we often prescribe, we often ask the patient to use something like a infant diaper rash cream kind of agent, because that stays there locally and kind of protects the skin.
Yeah. Hi, this is Dr. Srinivas. I just want to know from the house and from the experts, how many of these patients have undergone pouch, need to go back to ileostomy because of their refractory symptoms?
Yeah, there's a pouch failure happens about 4 to 10%, so they have to ultimately undergo.
Do many such people who have such refractory symptoms like perianal excoriation, diarrhea, causing miserable life, do they go back to ileostomy again? Which is, I think it's a better than having a pouch.
Yeah. I would agree with you, but we are not in their shoes. So if you think of that expression, I'm not living in the shoes of somebody with a pouch or with IBD, so they probably don't. Clearly, pouch excision is a big surgery. It's actually bigger than pouch construction. So, you also have to have, whenever you decide anything, you have to have an exit strategy. So if you are diverting the pouch or disconnecting the pouch, what are you going to do with the pouch, what is there? So these are considerations which patients have, but also clinicians. I just wanted to ask a general question about PSC and UC. Is there a practice of giving oral vancomycin in patients with PSC and UC in India? And is there any experience? I'm keen to learn from it rather than.
I don't think we are giving it routinely. I mean, I don't know about the.
No, I don't think we're giving routinely. And even the UDCA, there's no great evidence for it. We don't use UDCA on a regular basis. Vancomycin, yes, there's no guideline which actually suggests it, but on ad hoc basis, we do use it. In fact, I had a patient who had a liver transplant who had a recurrence of PSC, and we started him on vancomycin. He went back to US actually, and he's doing well. You know, he's been still in follow-up 3 years down the line, and he's doing well on intermittent doses of vancomycin. It's again ad hoc basis that we've been giving, but there's no guidelines as such. Agreed.
Thank you, sir.
Kiran sir, one question regarding radiation exposure in pregnancy. So in the first 4 to 6 weeks, radiation exposure increase the fetal risk, fetal anomalies risk. After that, even less than 50 milligyrus exposure can increase the risk of malignancies in the first decade of that fetus.
It is
because that's why it's better to avoid CT scan during pregnancy. We can do
it's better. It's
MRI.
Yeah, according to guidelines, it's always better to avoid CT. Unless there are no centers which are providing MRI, then only we tend to do CT with a low radiation protocol. That too for the first 2 trimester, first trimester, that's all.
So, thank you speakers for those excellent talks. And now I invite Dr. Sriram, consultant gastroenterologist at Yashoda Hospitals, Somajiguda, to give mementos to the chairpersons. Chairpersons, please come onto the dais.
Thank you, everyone. Finally, we come to this exhaustive conference, and for the last 2 months or 3 months, we've been put a lot of efforts, and we had a huge response. About 380 people got registered, and for an IBD conference, because as you know, a lot of gastroenterologists will be interested in endoscopy and liver, not much in IBD, but 380 registrations in IBD is extremely good. So we had a fantastic response, and thanks everyone for putting their efforts. To start with, I would like to thank all the international faculty. I'm sure I must have bored Seb, Deepak, Charlie, and everyone. I was messaging them constantly to see anything is missing or whatever, but they've been extremely kind and very receptive for whatever I was asking. So Seb in particular, because he is the one who I contacted first, and then he guided me in the program as well. So special thanks to you, Seb, and all other international faculty and all the national faculty. We had faculty coming from Ludhiana, Dr. Ajit Sood, and from PGH Chandigarh, CMC Vellore, All Indian Institute of Medical Sciences, and we had delegates coming from neighboring states, Bangalore, Chennai, and Bhubaneswar, lots of other places. People have been extremely proactively, they came and helped us in the conference. And all the delegates, postgraduate, they showed extraordinary interest, and without their attendance wouldn't have been successful. So our management, Yashoda Hospital group of management, especially special thanks to Dr. G.S. Rao sir and all the directors who kind of supported without any hindrance and constantly been following up what is the progress of the conference. And special thanks to again our so much good a level of management, especially led by Makesh Garu and Ravi and Anuj, and extraordinary efforts by all our marketing team, and led by Satya, Radhakrishna, Anjaneyulu, and Naveen, and all other supporting staff, all other marketing staff. They put extraordinary efforts and to bring it to this level. And without pharma support, it wouldn't have been, if you forgot anybody else in the delegates, faculty or anything else, it's just unintentional, because hard to remember everyone, but everybody contributed in a great way. And all our colleagues from Yashoda, from starting from Secunderabad, Malakpet and High-Tech City have been extraordinarily support. And I would say that working in a different hospital like Somajiguda and conducting in a different hospital like High-Tech City, would have been possible only because of the gastro group. I don't think it would have been possible with any other specialty, or less possible, because all gastro group, the gastro colleagues across the 4 branches, we just work like brothers. So it's extraordinary support from all other gastroenterologists. I would say working in, I was talking to some of my colleagues in Somajiguda. When I say that we were conducting in high-tech city, they just couldn't believe. They were just asking, are you going to move to high-tech city? I said, no, we're just conducting the conference in high-tech city. So thank you, colleagues. Thanks a lot for all your help, and we come to this conclusion. So we wanted to recognize the extraordinary support we received from all the pharma companies. So to take the proceedings further, I would request my colleague gastroenterologist, Dr. Sriram, to invite all the pharmas where you can come and collect a small token of appreciation for all the efforts. You are the guys, you stand behind any conference and then you stand outside and support extraordinarily. If anything missing from our side, do let me know. We are happy to support in whatever way we can. But we wanted to recognize all the supports offered by you. Dr. Sriram to take over.
We'd like to call upon individual companies so that the representatives and all the staff can come and take the mementos. First, we'd like to invite people from Johnson & Johnson Group to come and take.
This is a tale of three brothers, several obstacles, and a mother who would never give up. Hailing from a small, middle-class agricultural family, the mother understood the value of education and worked relentlessly to provide the best education for her children. As the time marched on, they are now stalwarts, and the world looks up to them and is inspired by their path and success. But who are these three brothers? Mr. Ravindra Rao, Dr. Surendra Rao, Mr. Devendra Rao, and their mother, Mrs. Yashoda. The name that resonates when one talks about trust and the best affordable healthcare. Back in 1989, Yashoda Hospitals began as a modest facility in Somajiguda with 50 beds, with the goal of providing care to both domestic and international patients. It has since grown not just in size but also in number by adding 3 more hospitals to become a more than 4,000 bedded respected chain of hospitals. These state-of-the-art hospitals are a beacon of hope for thousands of patients with its all-round holistic medical care offerings. But this journey hasn't been easy, with infrastructural challenges to administrational difficulties and a constant endeavor to bring the finest of doctors across the country under one umbrella. The perseverance and hard work poured into these hospitals is the reason it is today considered the top hospital chain in Telugu-speaking states and is recognized as one of the best hospitals in the country. The three brothers, moved by the desire to give back to the society that had given them so much, founded the Yashoda Foundation in 2011. Their goal was to continue their humanitarian endeavors and make a positive impact on the lives of orphan children. The Yashoda Foundation provides programs such as Abhaya, Akshara, Varadi, and Ma Kutumbam. Abhaya is a social inclusion through employment-linked training. Akshara, tuition support. Varadi, advocacy program for orphans to raise awareness and support for their needs. And Ma Kutumbam is a community of alumni from the Abhaya. Around 4,000 children are currently benefited by this project each year, and more than 100 batches of pupils have graduated as of this date. This journey of three brothers and a lovely mother is just getting started.